questions is acceptable, and it's okay to feel embarrassed if you do not know all the questions to everything. And kindly state if you are speaking for yourself or for the organization. Yun po. So I hope that this would become and this would be really a fruitful event to all of us. Ayun po.
Okay, thank you po ulit, Dr. Ralph Martinez Flores. So as we continue, we would like to acknowledge our participants this morning. So we really do appreciate your attendance today, and hopefully all throughout the activities and the following days ng activity po natin. So if I may po, can we request the respected participant to please stand and wave and say hi, maybe? Okay, to the other participants, no? So once I call your name, could you please stand up and raise your hand, no? Okay, so may we call on first in our list, may we acknowledge the presence of Dr. Sonia Ulanday. Kapital ng Palawan. Welcome po, ma'am. Dr. Jose Maria Bautista. Dr. Odi Cipriana. And Dr. Mary Joy C. Tianton. Ay, hindi po doctor. Sorry. Okay po. Kaya ma'am, Ophelia.
No fort.
Sorry. Welcome po. And kay Dr. Israel Vargas. Welcome. Kay Dr. Paul Castillo. And kay Sir Arlo Winston de Guzman. PH4. Kay Mama Niling de Guzman. And kay Dr. Kennedy Wilson Lee. So, kaya din po, thank you for coming and welcome po. Okay, so thank you for giving your time, though, and welcome once again. So, to overview of the activity, may we call once again Dr. Ralph Marco S. Flores, the medical officer 3 of the e-health office.
Okay na yung overview.
Before I continue, I would like also to recognize po our members that are present in the Zoom. Dr. Adelito Posas, Dr. Yun po, our members coming from the PhD ni Maropa, Sir MD Magno of the HPN, and then Sir Arthur Gonzalez from HMOD. Yun po, just to give you an overview na rin po of this activity that we will be having. Basically, this is designed for us para po dati po, di ba, meron tayong referral manual. That's by the El Nido, Puerto Princesa referral manual. And by because of the universal healthcare law, iba na po yung hatian ngayon. It's not just about interlocal health zones. It's more of the healthcare provider network that is, yun na po yung network, hindi lang po interlocal health zones. And LGUs have their option to have an healthcare provider network or a sub-healthcare provider network. So meaning, isa pong LGU, like for example, Palawan, which has geographically can be divided into North and South, can have 2 HCPN. So for us here in Puerto Princesa, why we are doing this yun na po, for us to revisit and then talaga po ang gusto po nating mangyari is dito po kasi sa Puerto Princesa the challenges that we don't have in LGU owned na hospital. by the city. So we are really relying on the private hospitals and all hospital ng Palawan for all the patients for their inpatient care. So ayun po, we are doing this, yun po, yung different parts po na makikita niyo sa program will be really focusing on the network provider, healthcare provider network will focus on the uh, co- uh, cooperation with the integrated po na coordination and integrated management. That's why we also invited our guests from the central office and from PhilHealth for us to be able to grasp what financial integration, managerial integration would be in the light of universal healthcare, not only in the primary care level, but also in how we will be dealing with it in the with the inpatients po. So, ayun. So with the yun po, just to give you a brief overview, the Universal Healthcare Act, matagal na po, 2019, and it was, the IRR was provided, na-sign po siya ng February 2019, and the IRR were provided October 2019. And then, yun po, ang part po ng Universal Healthcare, is population coverage, service coverage, and financing coverage, which will be documented din po. So, yun po yung magiging overview natin. So basically, yung hospitals po, yung ating pong participation dito would be how yung referral manual po may draft na rin po kami. It's actually coming from the previous na referral manual. And then, we just want to for you to comment and also to give your insights of if it is applicable to your hospital, if it's not, or do we go, we should for our refer this to the Apex Hospital, all of those things, those are the things that we will be talking about during this session. So, okay. So for us, to give an overview of the Universal Healthcare Law and its correct direction, Sir Arthur Rosales from PhD Maropa is on the line on Zoom to discuss the current direction of Universal Healthcare in Maropa. Sir Art, over to you.
Good morning po, Doc Marco. Good morning to everyone. Is my audio clear?
Yeah, yes, sir. Yes, sir.
All right. So magandang umaga po ulit. Again, I'm Arthur Rosales from CHD Maropa, and I'm part of the Field Health Operations under Miss Badge dating Ginoo. Thank you po for having us here, and apologies for not being there physically today, as it is currently our schedule. We are scheduled today for our ISO audit, but tomorrow we will be Ma'am Badge and I will be joining
sorry to cut you, Sir Ark. Wait lang po. May technical difficulties lang po with in-person po na ano. Wait lang po, sir.
Okay, thank you.
Sir.
Hello? Alright. So, rinig na po ako ng lahat. Okay. Ayan. So, I'm turning my camera para lang makilala niyo po ako. Again, good morning. I am Arped Rosales from the Field Health Operations of CHD Maropa under Miss Badge dating Ginoo. Again, thank you po for having us here with you. Unfortunately, we can't be there physically today because of our ISO audit, but we will be joining you tomorrow. So we will fly in tomorrow morning to be with you for the rest of the day. And as was written in the program and in the invitation po, no, I am tasked to provide you with the updates on the Universal Healthcare Act implementation. And I'll be borrowing the slide deck of Dr. Lester Tan, the one that was used during the rollout of the local health system's maturity level information system. For this has the latest updates, what relevant issuances have been provided by the different concerned agencies in terms of implementing UHC. Okay, so I'm turning off my camera just to conserve bandwidth and to ensure that stable phone connection go all throughout the presentation, right? Okay, so I just see. Okay, to the host, can we start with us sharing of the slide deck? All right. Thank you, Ma'am Joy. So again, this is the updates as of some of the information here is as of the first semester of the year, and some have been inserted before the September 1 orientation. So let's proceed to the next slide. Ayan. So nabanggit po ni Doc Marco kanina no, that since the signing of the UHC Act and its IRR in 2019, we have been in this runway for 3 years and counting. And although we have had the law since 2019, there have been some bottlenecks and road bumps in its implementation, primarily because of the COVID pandemic that started in 2020. But nonetheless, we have been implementing different strategies to promote universal healthcare and see local health systems integration across the different sites in the Philippines through various platforms. So mostly the technical assistance provided to the sites, including Puerto, Princesa, have been through the virtual platform. But currently, with the increase in the vaccination coverage and our thriving health systems capacity, nakakabalik na po tayo pa konti-konti sa ating face-to-face activities. All right, so that's about it for our runway for UHC, and we will proceed to the promise of UHC Act. Okay, so the promise of UHC follows the universal healthcare or universal health coverage cube of the WHO, giving us population coverage, service coverage, and financial coverage. So I think this is not new for most of us, as we have been hearing this in our public health works. So what is population coverage? Basically, population coverage answers who is covered. And with the advent of UHC law, everybody, so both paying and non-paying, every Filipino is automatically included in the National Health Insurance Program. And to effect this, PhilHealth already has established a system for identifying whether a client can pay or will be part of the indirect contributors of PhilHealth. Okay, second is service coverage. This answers the question, anong mga serbisyo ang covered or babayaran? Again, it was emphasized na that with all Filipinos being covered by PhilHealth, we now have immediate eligibility and access to both population and individual-based health services. So when we talk about population-based health services, these are the services provided to us by rural health units, urban health centers, and is mainly targeting the whole of the community. So later on, we will see what are those under the population-based health services. While individual-based health services, these are services directed to an individual, traceable to a single person. So ito yung ating mga consultation sa health centers, hospitalization, diagnostic procedures, and then access to medicines. So both these services, service coverage is basically covered by a network of healthcare providers, which is the focus of your workshop. Developing your referral system and ultimately creating your healthcare providers network for the city of Puerto Princesa. Okay, so completing the cube is the financial coverage part, which talks about who pays for what. So it was established under the UHC Act that population-based health services will be funded by the national government through the Department of Health and of course the local government unit. And I think this has been further emphasized with the implementation of the Mandanas-Garcia ruling and has been guided by the devolution transition plan for the health sector. Okay, for the individual-based health services, this is primarily paid or funded through prepayment mechanism. So what do we mean by prepayment mechanism? So as we all know, no, ibig sabihin nito prepaid. So we have paid for the services even before we receive them. And there are several payers for this. Main payer natin dito is of course PhilHealth or our social health insurance provider. We also have private health insurances and HMOs. So as to how this will be executed, so PhilHealth has created na several issuances and is currently together with the Department of Health creating additional issuances to guide us on the payment mechanisms. So why are we transitioning to this kind of payment mechanisms for both population and individual-based health services? It's because we want to achieve a lower out-of-pocket expenditures from our constituents. Because nationally, currently, based on our latest national health accounts, ang atin pong out-of-pocket is at 40% pa rin. Mataas pa rin siya. And hopefully, with the promise of universal healthcare and with the transition of payment mechanisms, we can decrease out-of-pocket expenditures and increase instead social health insurance payment for services provided. Right. So membership has been simplified. Binanggit natin siya kanina on who gets covered by PhilHealth. So the simplification, dati ang dami nating criteria. Now this has been summed up into two: direct contributors and indirect contributors. So nandiyan si Doc Ish, he can explain this better than me, of course. But for the sake of the presentation, direct contributors, these are us who have the capacity to pay premiums, especially those who are formally employed. So automatic na siyang binabawas sa ating salary before we get the net of it. And then for those naman who are not part of the formal sector but has their capacity to pay, there are mechanisms naman for them to pay directly to PhilHealth. While for indirect contributors, ito naman yung subsidized by the national government and those that are covered as mandated by the law. So senior citizens, PWDs. So all Filipinos who are not included as direct contributors and including their dependent, their premium shall be subsidized by the national government and would automatically be considered indirect contributors. So currently, meron sila, ang ating PhilHealth has released the revised PhilHealth membership registration form, and part of that registration form is yung pag-identify whether may capacity to pay pa talaga ang ating clients or wala. Okay. So talking about access to the services, as of current, 100% of the population has been covered. So it's an estimate of more than 111 million Filipinos covered or has given immediate access or is eligible pala to immediate access to health services. What differs lang naman is that hindi na kailangan ng PhilHealth ID, and then hindi na kailangan yung like before na 3 out of 6 months paid ka na. You can get access to the services, but just that if you have delays in your payment, then certain penalties will be imposed on you. Right. So with 100% of the population covered and payment for services for individual-based health services governed by our existing guidelines kay PhilHealth, we have further secured financial protection for our clientele through the establishment of more than 151 malasakit centers across the country. So familiar din tayo dito, no? We have under this malasakit program, the Medical Assistance for Indigent Patients Program or our MAIP. Itong MAIP natin na ito, I think apart from our hospital ng Palawan, several of our private hospitals in Puerto, Princesa and across the province has an existing MOA with the CHD to implement the MAIP program po. And this MAIP program has provided financial assistance to over 7.2 million patients from its start in January 2018 up to July of 2022. So that is across the country po. Okay. So entitlement to benefit through the National Health Insurance Program. Again, there is immediate eligibility. And when we say immediate eligibility, hindi ka nahanapan ng ID, hindi ka na i-require ng certain payments or certain payments have been made across for several months. But again, if there are payment delays, you will incur penalties that you have to settle later on. Nabanggit din natin na that there will be no co-payment in basic or ward accommodation, whether in public or private healthcare facilities. And there are issuances dito both from DOH and PhilHealth. And these issuances you can check on the notes section of this presentation, which has been provided to the team of Dr. Marco and Ma'am Joy. So before the no balance billing is only for the indigents. But currently with the enactment of the law of the UHC Act, every Filipino can have access to no balance billing provided they take advantage of basic or ward accommodation. So, but for the co-payment mechanism pala, no, as was updated to us during the September 2 orientation, kinakraft pa din yung operational details and guidelines on co-payment mechanism. And this is currently being processed by both the Department of Health and the PhilHealth. So, what is co-payment ba? As it is defined, co-payment will only, ito yung magbabayad ka apart on top of those that will be paid by PhilHealth. And this will only apply for those patients who prefer to avail additional amenities over and above the basic accommodation. So, current PhilHealth packages will not be reduced. Ito yung sinasabi ng ating batas. And when necessary, kapag mas malaki na ang ating fiscal space, we can add more benefits. And this will be designed later on as we progress with the UHC implementation. All right. So where do we get our funds? Where do we get do PhilHealth gets its fund? So primarily this is through the pooling of funds for all individual based health services. So the sources here is those coming from the contributions of our direct contributors, subsidy from the national government. So ito po yung estimates based sa estimates ng indirect contributors that we have. And latest is ito po, 50% of the national government share from PAGCOR and 40% of the charity fund net of documentary stamp tax payments and mandatory contributions of PCSO. So yung kanilang medical assistance funds ng both offices at PAGCOR and PCSO shall be transitioned to PhilHealth. And that has been agreed upon following the joint resolution signed between the Department of Health, DBM, PhilHealth, PCSO, and PAGCOR. Right. So those are the fund sources natin currently. So we can expect that with the implementation of this joint resolution, mas tataas na ang coffers ng PhilHealth to help us cover for those basic services and those within their packages. Right. So 2011 to present, PhilHealth has been implementing case rates, and as required by the law, we will be transitioning to a prospective payment based on disease or diagnosis-related grouping and following a validated costing methodologies. So this DRGs or the payment mechanism that will be implemented will use a performance-driven close and prospective payment. And currently, what we have for the PhilHealth has already issued a general guidelines on the mechanisms in implementing this transition is still being developed. So meron na po tayong transitioning provider payment mechanism for all case rates to DRG. So while we are using case rates now, ito yung familiar tayo, we can see changes in the coming years. So PhilHealth shall implement a comprehensive outpatient benefit package. in accordance with the recommendations of our Health Technology and Assessment Committee. So currently what we have as an interim is the consulta. And this is governed by their Circular 2022-005 implementing guidelines for PhilHealth Consulta Package Revision 1. This PhilHealth Consulta Package will be the basis po muna no, ng ating magiging form for network contracting later on. And I think we will touch base on that later on. But as of July 31, 2022, there are 643 accredited consulta providers in the country. Okay, so that's it for financial coverage, no, and who gets covered. So let's talk about service coverage. So how do we deliver services? For population-based health services, the law mandates DOH to contract province and citywide health systems to provide population-based health services. So itong mga local health systems na to, basically they will provide primary care services through their RHUs, BHS, and for Puerto Princesa, we have health centers. No, we have the main health centers and its satellite health centers. So apart from that, the primary care provider network will include or may include its barangay health stations, the satellite health centers, if there are existing lying-ins, diagnostic facilities, and even pharmacies. So apart from the requirement of being able to provide primary care services through a primary care provider network, the law also requires population-based health services to be implemented through our government facilities, and then including to that is the implementation of health promotion program and campaigns.
Ako din dati.
Right. So later on po, we will towards the end of the presentation, we will see what are the different priorities for health promotion. So currently meron tayong sinusod na system. It has been themed. There are 7 priority areas where we do health promotion programs, and where we focus pala our health promotion programs and campaign. Another requirement for population-based health service delivery is the implementation of the epidemiology and surveillance system. And this has been further stressed with the release of the 11332, the law governing naman mandatory reporting of diseases. While not really included in the law, during the IRR development, pinasok din po yung requirement for the local government unit, for the province and citywide health system to implement and ensure na functional ang kanilang disease reduction, the disaster risk reduction and management in health. So this ensures that even at times of disaster, there is continuity of health services being provided across the catchment population. So ito yung mga requirement po sa ating mga citywide health systems. Okay. So, ayan. So for individual-based health services, the health goods and services must be classified muna, either population or individual-based, to guide both the DOH, PhilHealth, and of course LGUs and other partners on how to appropriately finance mechanisms in the provision of their services. And the classification process ng mga services or ng service packages will follow a set of criteria based on the concept of public good. So when we say public good, ang ating sinusunod niyan is the concepts of rivalry, excludability, and externality. So basically, tatanungin, ang serbisyong to ba ay pang isang tao lang or pangkalahatan? So that's rivalry. Kung isang tao lang makikinabang, then that's at any given time of the service provision, then that is for individual-based. Excludability. Kapag ba yung ito bang service na to kapag pinrovide ay ilan na pwedeng makinabang sa service na to or maka-access ng benefit na to. So kapag isa lang, then excludable siya. Yung benefit ng service na yun is only intended for a single person, like administration of drugs, isang tao lang. And then there is the concept of externality. kapag binigay mo ba yung serbisyo sa isang tao, will it have external effects sa immediate community niya? If wala, then this can be categorized as an individual-based health services. So again, this concept, this can be found under the Department of Health AO 2020-40, which is the guidelines on the classification of individual-based and population-based health services. So kailangan mo na klaro yun, no? Paano mo ma-identify kung ang serbisyo mo ay pang population-based at individual-based para mas madali ang payment, ang pag-fund natin ng mga mechanisms na to. So what other things do we have to support service delivery? Ito tanong din to ni Ma'am Ana kasi this has been issued early on this year. I think January pa lang. The department issued the manual for primary care managers. This comes in two parts. Currently, part 1 pa lang ang release. The second one is on the technicalities of operating a healthcare provider network, which would really help out our HCPNs or our province-wide health system in developing their respective HCPNs. So as of current, same pa rin po ang response natin on this. The rollout on the use of the primary care manuals or the manual for primary care managers, hindi pa po siya nagka-conduct. So we are still waiting for its conduct and its rollout para po makascade sa atin pong mga integration sites. So apart from releasing the manual for primary care managers, meron na rin po tayong integrated course on primary care. And this has been uploaded in our DOH Academy. So DOH Academy is an online platform of the Department of Health to provide necessary learnings or capability building inputs on the different aspects of health services. So this comes, I think, with a CPD unit, and this can be accessed by anyone. You just have to create your account under the DOH Academy, which can be accessed through the URL learn.do.gov.ph. So another to support service delivery is the currently issued Omnibus Health Guidelines for life stages. Ito pong tatlong to, the Manual for Primary Care Managers, actually it's a self-help handbook naman. The integrated course on primary care, which is in the DOH Academy, and then the Omnibus Guidelines or the Omnibus Health Guidelines per life stage will or can help our health workers in their management of primary care facilities, especially in the RHUs and the BHSs. Okay, so on the establishment of epidemiologic surveillance and response systems and mandatory reporting of notifiable diseases, this has been further articulated in RA 11332 and its revised IRR. So ito po yung sinusunod natin currently for COVID reporting. All right. Another aspect ng ating service delivery is, nabanggit nga kanina, this has been included in the IRR development, which is the Dream Age system. So disaster risk reduction and management in health. And this is just for your pleasure, this is the operational framework that we follow. So instituting kasi a Dream Age system in the province or citywide health system guarantees uninterrupted delivery of essential health services during emergencies and disaster. So this is aimed to make our health system more resilient, and the objective in each of the Dream Age 4 thematic areas must be addressed. So ito po, this is the mastery of our DRRMO, and ang ating Dream Age manager ang tawag sa kanila, in our city health offices. All right. So moving towards individual-based health services, okay. So for individual-based health services, PhilHealth will be contracting public-private or mixed healthcare provider networks for the provision of individual-based health services. If kanina it was DOH contracting the province-wide and citywide health system for population-based, DOH supporting population-based services, For individual-based health services, it will be with PhilHealth. So this network, however, should agree with our PhilHealth on service quality, co-payment or co-insurance, and data submission standards. So currently, PhilHealth will be implementing a sandbox approach for selected consultant networks. So ito yung if we go back dun sa kaninang um, service coverage for population-based health services, no, yung PCPN natin, which is the foundation of the HCPN. Kate, wag niyo na pabalikan yung slide na yun. How it will be contracted, una po is magsa-sandbox muna si PhilHealth next year in order to test the new reforms. So paano magiging contracting arrangement natin, and to make it simpler with the PCPNs muna, or what we call it consultant network. Currently kasi the network contracting guidelines is still being developed on it. So it's still in the works, and ayun na nga. Para siyang ladderized. Uunahin muna ng ating partner na PhilHealth is-sandbox yung pag-contract ng consultant networks or the primary care provider networks before really going to the whole of the HCPN. Okay. Alright, so healthcare provider networks. Ito po yung ating focus for the 3-day activity. And basically, there are 3 types. We have the public healthcare provider network, the mixed healthcare provider network, and then the private healthcare provider network. Ito po yung binanggit sa ating batas and then the IRR. So public healthcare provider network is the same as the province-wide or the citywide health system. So for Puerto Princesa, that's a citywide health system. And development ng network arrangement na to is initially governed by DOH Administrative Order 2020-19 Guidelines and Service Delivery Design of Healthcare Providers Network. Ito po yung lagi namin napag-uusapan ni Ma'am Choi na current reference natin. So focusing first on the public HCPN, which is the current one that the department is espousing for the networks or for the UIS to use. So the first type is the public HCPN, or similarly, it is the citywide health system, which is created by grouping public primary care providers and facilities into primary care provider network. And this PCPN will be linked to a secondary or a tertiary care provider within the geographic or political boundaries. So nabanggit ka ni Doc Marco kanina, yun yung challenge for the HCPN of Puerto Princesa. The primary care provider network, meron sila. However, in terms of completing the package para maging HCPN siya, doon may struggle. So on the public side, the delivery of service of a CWHS/HCPN, they will deliver both population-based and individual-based health services, because again, it is incumbent to the government facilities to provide population-based health services, and then to each HCPNs, be it public or private, individual-based health services. Okay, so hospitals or other qualified health facilities within the network shall provide outpatient specialty care services and syempre the usual inpatient care services natin. So again, the primary care providers or the PCPN shall be responsible for primary care services. That's the current that we have now. This is the working model, public model. Isa pang model is yung sa kabilang side, which is the private HCPN. Kung sa public model, ayan po. Kung sa public model, we are bounded by our geopolitical boundaries, meaning hindi siya lalabas. Kung Puerto Princesa City facilities lamang yan. Pagdating sa private HCPN, this is governed by market-based forces. And this meaning they are not limited or defined by geopolitical boundaries. So it will be contracted by PhilHealth to provide individual-based health services only. Since hindi naman sila part ng provision talaga hindi sila required to provide population-based health services. Okay. So, although may mga existing na tayo nito like the Ayala Group, the Medical City Group, yung models nila, they're existing models, they're existing na, no? Pero how we can guide other private facilities, especially yung hindi naman sa isang magkakasama sa isang kumpanya, inaaral pa. So guidelines on private HCP and development will come forth on a latter time. Okay. So going back kay sa sitwasyon ni Puerto Princesa, no? In case or in the case of Puerto Princesa, now there are no LGU owned or managed secondary or tertiary care providers. The city may link with a DOH, so that's in your case ONP, or private hospital to complete its HCPN, provided that the hospital shall be of the level and service capability needed as identified in our DOH standards. So I think that will be these standards will be further discussed po, no? Through I think through a video later on or a recorded presentation from our partners from the Health Facilities Development Bureau. Ang priority dito is the proximity of the facility doon sa existing na public or CWHS. Okay, so what does that mean? Currently, to ensure that the HCPN of Puerto Princesa and make a contractual arrangement with existing private facilities and DOH hospital within the city. Contract ng ating city na to help them complete the HCPN. So bakit? Because the middle ground, the mixed HCPN, wherein both public and private entities have co-ownership of health facilities and services within the network. Ito po, wala pa siyang existing model at inaaral pa din how this can be operationalized. Kasi one of the concerns here is that one of the concerns natin for mixed HCPN is that once mag-enter into a joint venture, ang mga private facility with a government facility, ang tinitignan na concern dyan is how will COA take it? Lalo na yung mga auditing rules and regulations. So hindi pa siya established. If the private model meron na inaaral pa, for the mixed model, wala pa talaga tayong existing within the country and we're looking into experiences from outside. So currently, ganun lang po tayo. Again, mixed and private HCPN under study pa. What we have is the public model with Puerto Princesa that is basically they can establish their primary care provider network, making contractual arrangements with the different hospitals within the city to complete its HCPN. Okay po. So that's for the HCPN based on our local health systems integration. That's how we approach it. And later on, this will be further expanded by our HFDB partners. So we move on to organizing our local health systems. And so to harmonize efforts and ensure efficient delivery of health services in public facilities, local health systems will be integrated into a citywide health system. So for Puerto Princesa, that will not be difficult. Isa lang ang ating steward of the ship. It will always be the mayor, as compared to a province-wide health system wherein there are component LGUs that will take part in the decision making. Although the lead for the city is the mayor, as per the UHC Act, the ones to decide on the health system will not be upon one person, but a body, which is the City Health Board. So the City Health Board shall oversee integration of health services. Kasama dito kung paano yung arrangement natin with private partners. It shall manage the Special Health Fund and exercise only the administrative and technical supervision over health facilities and the health resources for health. Again, that's only supervision and administrative and technical supervision. So supervision lang siya. But for the city, medyo hindi siya nagmamatter because management and control of facilities and manpower rest with the LCE. And again, wala ka namang ini-integrate dito, but just the services. So the last part, entitlement of municipalities and component cities. In the provincial health board, this only applies to a province-wide health system. Okay. So since 2020, the DOH has engaged several universal healthcare integration sites, or as we call it, the UIS. These are LGUs, so they are provinces like the Puerto Princesa, highly urbanized city, and other independent component cities that express their commitment to integrate their health system and have signed a tripartite memorandum of understanding with DOH and PhilHealth to implement the integration reforms. So basically, ayan, we have 73 integration sites as of now, and these integration sites will be the basis of whether, or the experiences of all these integration sites at the end of 2025 will be the basis of whether UHC can be fully implemented across the country. So for Mimaropa, we have 5, and that includes Puerto Princesa City. Okay, so how do we monitor progress of local health systems integration? We do that through the local health systems maturity level, which is a monitoring tool that tracks the progress of integration. Ito po yung aming ginagamit ng mga integration site. This has been implemented as December 2020.
Sige na lang. Kunti-kunti. Lalo basama ka. Sana naman walang urine na UTI. Pag may UTI,
Okay, sorry for it. Okay, so going back, so the LHSML maturity level is the tool that we use to monitor or keep track of the progress of our integration site in how they integrate the health system. So there are levels. We have preparatory level, organizational level, and functional level. So for this year, we are aiming for 100% preparatory level, and starting and towards this latter part of the year, working towards some of the organizational level indicators. So ito po yung ating reference, no. This is based on the June 2020 result of our rapid assessment across the country. We have 22 integration sites na tapos na or na naka-achieve na ng 100% at preparatory level. So nung time na to, Puerto Princesa belonged to the 24% or those between 80 to 89% accomplishment. So later on po, I think Sir Arthur will be updating us as to their current status for this year. All right. So moving forward, we have as part of the universal healthcare reforms, ayan, special health fund. So what is the special health fund? Basically, the special health fund is a mechanism for us to pool resources intended for health and health-related services at the province-wide or city-wide health system level. So province or city level siya. Sinasabi dito that all PhilHealth income shall accrue to the special health fund and credited as the annual regular income of the LGU. So currently meron tayong na-issue na joint memorandum circular, that's 2021-0001. This is between DOH, PhilHealth, DBM, DOF, DILG. This was issued January of last year. That provides us the guidelines on the allocation, utilization, monitoring, and accountability for the special health fund. So nung time na na-release na to, actually excited ang mga sites, excited tayong lahat dahil may operational guidelines na tayo. But turned out that the GMC alone is not enough for us to really make use of the special health fund. So currently, COA is developing guidelines on accounting, recording, and reporting for the special health fund. And while they are in their works, so kailangan po yung magiging issuance ni COA to complement yung JMC para ma-implement talaga natin yung, or para ma-start natin yung pag-manage ng special health fund, ang actually waiting pa din, no, for the result of the sandbox implementation for the selected consultant network by PhilHealth. Again, this will be the implementation, sandboxing of the consultant networks. Ito na rin yung magiging pilot for the implementation of PhilHealth payments to the Special Health Fund. So, apart from contracting consulta networks, kasama na dito papaano babayaran sila as a network. So the sources of income for the Special Health Fund, again, kasama dyan yung national government financial grants and subsidies. So if we talk of DOH, especially with the release of the DTP or the Devolution Transition Plan, mas bumaba ang national government share for population-based health services. So basically, lumalabas siya as barya lang. In cash, what we transfer is the fixed tranche, the support for UHC integration, and then if there are capital outlay support, depende po siya. Usually, the CHD implements it, but at times, transfer siya sa LGU. And then, most of what the DOH provide is in kind. Kasama dito yung mga HRH that are deployed to the city. So what makes the bulk of the SHF? Bulk of the HSF will come from your income from PhilHealth. And of course, some of which will come from grants from other partners, and optional din na yung inyong LGU budget for health ay ipapasok na sa Special Health Fund. So instead na ma-retain siya as a general fund or part of the general fund, the health board can issue a resolution strongly recommending to the Sangguniang Panglungsod to transfer the budget for health from the general fund to the Special Health Fund to safeguard it for use specifically for health and health-related services. So para saan po ba yung Special Health Fund? This is to fund population and individual-based health services. Kasama po ang ating health systems operating costs. So yung paano mo papatakbuhin, no, lahat ng serbisyo natin, capital investments if there are capital improvements, and remuneration for additional health workers and incentives. So additional health workers, meaning po dito that these are contractual personnel kasi most of the money here are capital outlay and MOOE, wala pong PS. And thus, plantilla position is still care of the local government unit of Puerto, Princesa. All right. So we transition now to the human resources for health. These are the current updates that we have for you. Na-issue na ang National Human Resources for Health Master Plan for 2020 to 2024. So ano po ba itong National Health Human Resource Master Plan? This contains different strategies. It's a policy guide and a guide and on the approach on how do we appropriate generation, recruitment, retraining, how do we regulate, how do we retain, basically different strategies on how do we keep and increase our HRH until we get to 2040 to ensure that we have enough manpower to provide services to our clientele. So in parallel po doon sa ating HRH Master Plan, we also have the National Health Workforce Support System. Ito po yung current nating deployment program, which has been institutionalized to support the current local health systems in addressing health workforce needs, lalo na po sa ating mga GDAS or the geographically isolated and disadvantaged areas. This is governed by the AO 2020-38 guidelines on the deployment of HRH under the NHWSS. So medyo may nabago pa dito with with Mandano's ruling and then the release of the DTP. There are certain criteria and there are certain cadres na hindi mabibigay or hindi na qualified ang isang LGU based on their income classification. So another thing that we have is the updates on scholarship and training program, including return service agreements. So currently meron tayong JAW, Joint Administrative Order between the Department of Health, CHED, DOST, TESTA, and PRC that governs the expansion of health profession and health worker scholarship, and increasing the required return service agreement for those that have availed of the scholarship. So if before it was 2 years, ngayon 3 years na po ang ating RSA to ensure lang din that commensurate or yung the investment provided to create or to produce more health workforce makukuha natin through their services po. Alright? Further, we have the National Health Workforce Registry. Ito po yung encoding natin no, ng ating mga existing human resources for health per facility. So this will enable us to collect accurate and up-to-date HRH data. This is between the DOH and the PRC naman. So itong registry na to is tasked or this registry or the NHWR is tasked to collect, process, and generate up-to-date report on the number of HRH practitioners and their location of practice nationwide. So this is another prescription sa atin of the law. That's why we already have this. I think this is the national NDHRHIS ang tawag siya, National Database for HRH Information System. So eventually, itong registry na to will be expanded to accommodate other HRH-related data such as production and migration to align with the National Health Workforce Account para alam natin ano ba talaga yung clear picture. Gaano karami ang HRH, ang ating, gaano karami ang ating nurses, doctors, and other health allies ang nasa labas ng bansa, gaano karami ang misplaced in other sectors. Okay. We also have the primary care worker certification. So this started in this started in 2020 but was implemented in 2021. The primary care worker certification is a prerequisite for the licensing and accreditation of primary care facility. So sa pag-certify ng primary care worker, kailangan ma-declare ang ating mga health professionals in primary care facilities as competent in 5 individual-based and 2 population-based competencies. So itong mga competencies na to can be found in the JAW of DOH and PRC. Currently, there has been issuance of provisional certificates to health professionals during the transition period, which is from last year to this year. And then full implementation of this certification is by 2023. Okay, and so we have registry to know nasaan natin mga health workers. We have primary care worker certification to ensure that current personnel natin are reoriented on primary care services and primary healthcare concepts. And lastly is continuous production of our primary care oriented and primary healthcare oriented and public health oriented health professionals. So we have the reorientation of health professional education curricula and training programs to primary healthcare, which was this is institutionalized through the same JAW between DOH, CHED, and PRC. So that's JAW 2021-001. Baka actually marami pong 2021-001 na JAWs. Iba-iba lang po ang mga signatories. And again, this can be accessed po at the notes section of this presentation. Okay. So this is the picture of the current HRH support system deployed in the country. We are still processing po yung request for the same numbers of HRH to be deployed for next year. But for the Puerto Princesa City, let me just check, no? Sorry, hindi ko na siya na-update. Hindi ko pinakialaman ko talaga yung slide ni Dr. Lester. But for Puerto Princesa City, we have 4 NDPs, we have 4 PDP. I think this is the pharmacy deployment program. We have 8 na midwife, so it's under the RHMPP, and then 2 PRDP. So kung mapapansin niyo po, napakaliit ng support napakaliit ng HRH support based on the NHWSS kay Puerto Princesa City. Gaya nga nung nasabi po namin with the DTP na bago yung pagbibigay, may sinusunod po tayo ngayon na based on our, what do we call this? income classification, doon magdedepende kung gaano karami at anong kadre ang pwede pong ibigay as support to LGUs. Okay, so ito na yung some of the changes po no in how do we ensure safety, quality, and affordability and equity in our health facilities. So ang bago po natin dito is the institutionalization of a licensing and regulatory system in the department for primary care facilities. So dati hindi siya kasama sa nila-license. Ngayon po kasama na siya. As of June of this year, we have 159 primary care facilities that have been licensed by DOH. And I think this will, DOH licensing of primary care facility will play a part in the accreditation ng ating pong mga konsulta din. Okay, to ensure affordability, mandated po sa atin ang transparent pricing of health goods and services. So meaning kailangan doon sa mga highly visible locations, naka-post ang prices per services per commodities natin po. An independent price negotiation board was created to negotiate prices on behalf of DOH and PhilHealth. So para ma-ensure na we get the necessary commodities at the lowest price possible. Okay, so another is going to equity. I think may nakita rin akong PhilHealth circular supporting the same, but this is also part of DOH Administrative Order 2021-15 mandating or regulating the number or percentage of basic accommodation per type of health facility. So for government hospital, at least 90% ng kanilang beds are for basic or ward accommodation. Sa mga specialty hospitals natin, like the lung center and the heart center, at least 70%, yes, sige po, at least 70% ang atin pong, yes po, Doc Rap, sorry, sige, I'll wrap this up na. Ang atin pong dapat na basic accommodation with 10% for private facility. Okay, moving towards health technology assessment, this will be the regulating body or the body that will identify health technologies to be financed or procured by the government. So they give us recommendation, no? Gaya ng anong vaccines ang dapat bilhin, anong gamot ang dapat suportahan at pwedeng ibigay ng government to the population. So this within the 5 years of its establishment, since it has been established as early as 2020, this will be transitioned as an independent entity separate from DOH but attached to the OST. Okay. Going forward, health information system, the UHC law mandates that we use an integrated health information system. So for the government side, we have the iClinic SIS for primary care facilities and iHome is for hospitals. Though private health information system or EMR provider is allowed, ang kailangan lang po dito is ma-ensure that their system is interoperable with the different systems po ng PhilHealth and DOH. So there are several guidelines released for this. And then, of course, we want to ensure that the use of digital technologies for health is being maximized to deliver services, especially sa mga malalayong lugar. So we have telemedicine, and if you're familiar with it, ang ating pong Pulyan Sanitarium has signed an agreement with the Children's Hospital here in the Manila for telemedicine services po nila. Right? So that is for health information system. And then, ito po yung sinasabi natin. As part of the requirement for the city being the ones providing population-based health services, we have to have a proactive health promotion program and campaign. And this is guided by the health promotion framework strategy with 8 different health promotion playbooks available for us to copy and implement in the city, covering the 7 thematic areas for health promotion. Okay, and then last update that we have, or second to the last, is that we have available capacity building through the e-learning modules. So we have 12 UHC modules under the UHC Implementers Act. And again, this comes with CPD units. You can access this through the DOH Academy platform, that's learn.gov.ph. And these are the themes for the 12 e-learning modules. And then lastly, the module, this e-learning module has been interpreted has been interpreted into a book. It is the Universal Healthcare in the Philippines from Policy to Practice. This describes the reforms stipulated in the UHC law as well as compendium of operational guidelines to implement these reforms. So the references for this three is available through the link provided in your screen. That's https://bit.ly/UHC in the Philippines. And I think that's it for me on the updates on our UHC implementation in the country. Thank you po.
Thank you po, Alfred Rosales. Okay, sa ating virtual po na overview.
Questions po na i-raise na ngayon kasi
Once again, we would like to acknowledge po the presence of Dr. Susan Zambrano of City Health Office. Sorry po, hindi ko pa kanya pwede po akong tumayo sa din. Si Ma'am Jonami F. Nasil and Ma'am Cathy Hoffman are the third one at City Health Office. And also, Central Record for the City of Dr. Kenneth. And also the presence of Dr. Jean Palangka, our Assistant City Health Officer, PC po. And also the presence of Dr. Elaine Salazar, CR, and Dr. Ronnie Salazar of Dentist. Welcome po, Doc. And also Dr. Evelyn Modelos po of the Dentist. Welcome po. Okay, so as we continue in our first session, we will be seeing a pre-recorded video. Okay, so let's proceed po dun sa ating next presenter. Okay po, in the next section, it is an honor for us to have our next guest speaker who really lent time for us to be here despite of his hectic schedule. So he'll be presenting the orientation on financial integration. He is currently the Senior Vice President for Health Finance Policy of the Philippine Health Insurance Corporation. Let us welcome Dr. Israel Francis A. Vargas. Thank you. Good morning po. Salita, alam niyo naman.
Well, currently I'm assigned on, I have a special assignment on UHC policy development. I've been with the group writing the UHC law, and of course it's IRR. And until now, it's guidelines and specific guidelines. So, para po dun sa mga interesado, we just came out and published yung pong from policy to practice ng UHC. So meron po yun. So for those who want to be oriented. Plus, yun po lahat ng mga updates on the policies, AOs, guidelines general it may seem, because we are still writing more of the specific ones right now, with the other government and local agencies. Yun pong compendium ng 60 policies, yun po yung dalawang volumes. It's already out also. So you are all guided from the design of the healthcare provider network down the line, nadudul po lahat. Pati po yung mga PhilHealth policies on UHC. Of course, we will have to update it as we come out with new policies. But so far, we have achieved and we have written around 60 of those. But most again of those are actually general, and the specifics are still being written. So from the UHC, I guess you are now more familiar with the managerial integration and the technical integration. And so I was asked to provide an orientation on the financial integration. So yun po yung tatlong integration areas pagdating sa universal healthcare, aligned with, of course, the dimensions: population, the service, and of course, the financial goals. So yung integration po, yun yung malaking area na kailangan natin trabahuhin. And well, I guess financial integration right now, we will have to focus, of course, with the special health funds. But I will also be touching, and I will have like 1 or 2 slides with how we will actually pay. Because as you all know, the UHC is not just about PhilHealth. It is a reform in the whole health system. And technically, PhilHealth is just one of the payers. Although we are a major payer and a major player, but our payment will actually on the individual-based health services. As already described earlier, there are 2 health services: population and individual-based. Okay? So doon po tayo. So saan papasok ngayon yung sa PhilHealth? Last, ano ba ang mangyayari pagdating sa special health fund? Ano ba ang magiging relasyon nito with the public sector? Paano kung mayroong private? We all know that the presented healthcare provider network models, tatlo siya. We have the public, we have the purely private, and of course, we have the mixed. Paano ang flow of funds? So we will try to discuss all of those. But I will focus my discussion on the joint memorandum circular on the special health fund. Next slide. So this will actually correspond to the 3rd dimension of the UHC, which is the financial coverage. Again, the first is the population, the second is the service, and the third would be the financial coverage. Next slide. Now, financial integration actually happens at the national and at the local level. How did it happen at the national level? Kung makikita po ninyo ngayon, ang pondo to sustain the universal healthcare, integrated na rin po siya as one. So, ibig sabihin, yung po mga pondo, all for health, ay pinagsama-sama na rin. Kung dati po ang pondo para sa ating universal healthcare ay nanggagaling sa una, especially sa pondo from PhilHealth, is nanggagaling sa una, revenues coming from the sin taxes, coming from the General Appropriations Act, coming from your premium contributions, or coming from national subsidies. Pero ngayon po, na-integrate na rin yung ibang sources of funds para po masustain yung universal health coverage. And the 2 na malaking sources are those funds coming from PAGCOR and PCSO. So for the PAGCOR, it is like 50% of its charity fund and 40% for the PCSO. Just recently, we have signed the joint memorandum circular with the PAGCOR, PCSO, DOF, DBM, Europe Treasury, DILG, PhilHealth, DOH on the mechanism on how to transfer the money from PAGCOR to PCSO. And I think, kung makikita nyo po just recently also, I think September, yung initial fund or initial turnover of around 2.5 billion was given by PCSO to PhilHealth. So yun po yung simula. At ang nakasulat sa batas is that the money coming from PCSO and PAGCOR shall be used to expand and enhance benefit packages. So nakaspecific po yun sa batas. Doon po siya gagamitin. So at the national level, makikita nyo there happen to have a financial integration. But at the local level, paano mangyayari yung financial integration? Okay. Next slide. So at the local level, financial integration shall happen kapag nagbayad na yung PhilHealth with regard to the services. But again, health services are now divided into two, population-based and individual-based health services. Accordingly, one of the principles one of the objectives of the UHC is to have an integrated and coordinated care through a systemic approach provided by delineated roles. And so, one of the roles delineated ngayon sa batas ay role ng DOH at ng PhilHealth. So the DOH now is responsible for giving and financing population-based health services. So alin ba ang mga population-based health services? So yan po yung mga promotion, epidemiologic studies, vector control. Lahat po yan. And ang sinasabi ngayon sa batas, individual-based services shall primarily be financed by the social health insurance or PhilHealth, together with your private health insurances. Okay? So doon papasok ang PhilHealth sa individual-based. So ano mga individual-based health services? All those services directed towards a person. Drugs, medicines, laboratories, procedures, confinement, surgeries, lahat po yan. Directed towards a person. So ibig sabihin yun po ang i-cover ng PhilHealth. Next slide. And as part of the change or reform in the health system right now is the provider payment mechanism. It will also go with the way we actually engage with the providers. So sa mga providers po natin, in section 18.2 of the IRR and the law, ang sinasabi doon is that PhilHealth shall now contract with healthcare provider networks. So, malaking pagbabago pagdating sa panahon ng UHC because one, instead of accreditation, it will now be contracting. Instead of individual facilities, it will now be with networks. That's why it is very important that there is a healthcare provider network happening or established in a citywide health system or in a province-wide health system. So, sino ba ang available to have a citywide health system? Puerto Princesa ba ay pwede to have a citywide health system? Yes. Because kayo ay HUC. So, nasa batas na ang citywide health system are those for HUCs and ICCs. Highly urbanized or independent component cities. But for other type of cities, part sila ng province-wide health system. Okay? So, a local health system, citywide or province-wide, paano ngayon i-deliver ang health services, ang population at individual-based health service sa local health system? I-deliver daw yan through an integrated and coordinated manner. Paano magkakaroon ng integrated and coordinated manner? By the establishment of healthcare provider networks. At alam niyo naman, ang pathway ng healthcare provider network ay primary, secondary, tertiary care. And outside the network is a referral or apex hospital. The patient pathway follows the healthcare provider network. And that is also one of the major changes and reforms in the UHC. From a specialist hospital-centric care to a generalist primary-centric healthcare. That's why, in most of the cases, lahat ng concerns natin ngayon, primary care level muna. Kung kailangan ng confinement or specialista, it's the primary care who will navigate, coordinate to a specialist or to a level 1 hospital for confinement. Kung kailangan ng mas mataas, they will navigate also to a secondary or tertiary care. And after the episode of care, it will now go down again to the primary care. Except, of course, in 3 cases. Emergency, seriousness, or ano yung isa? Physical impossibility. Nandito ako sa Palawan, pero ang primary care ko is Manila, so pwede ako dumiretso sa ospital. Because I don't have to go back to Manila para lang magpa-check up kasi dito ako inabutan. But, kung nasa Manila ako, primary care muna ako. Gone are the days na didiretso tayo sa espesyalista. Yun po yung nilalayon sa reform. Such that most of the concerns now will be seen at the primary care. And more of the specialized ones sa hospital, and then to the apex or to the referral hospital. It is very important for us to understand because with the network, it will follow the engagement of PhilHealth because we will contract with the network. And the payment of PhilHealth will follow also the partnership. So we will also pay the network. So kung dati po, ina-accredit natin individual facilities at nagbabayad tayo to the individual facilities, pagdating sa reforms ng UHC, we will contract with the network of facilities and we will pay to the network, not to the individual facilities. So ang network na po ang kausap natin. Okay. At ang pagbabayad natin is this one. This is the provider payment mechanism. It is actually how we purchase or how we reimburse or how we pay the services that we are actually giving to our members. In that case, to all Filipinos. Kasi di ba, under the UHC, population coverage, every Filipino is automatic member of it. So para sa lahat na yan. Okay? Next slide. At ang isa sa pagbabago pa rin sa UHC is under Section 18B is that now PhilHealth shall endeavor to shift to a new provider payment mechanism, prospective payment mechanism at that, which is 1, performance-driven, 2, closed-end, prospective based on disease or diagnostic-related groupings, validated costing methodologies. Again, for you to be incentivized to provide the quality of care needed. But because I understand there are a lot of doctors also here, nasa batas din po without differentiating facility and professional fees. Okay? So, ibig sabihin, yung current provider payment mechanism natin, babaguhin to a prospective one as stated in the law. Section 18B. Now, what are the types of prospective payment mechanisms we are contemplating under the UHC? We have two areas, inpatient and outpatient. Identified na sa batas that it should be validated costing method through a validated costing methodology. That's what we are doing right now, costing the services. It should be a diagnosis-related grouping. And so, for inpatient, we are looking for DRG-based inpatient payment mechanism. And for the outpatient or the primary care, we will be using the capitation. I think you are familiar with the capitation because that's what we are using already right now. Okay? Ano ba ang ginagamit ngayon ng PhilHealth? Case rate for inpatient and capitation for outpatient. Ano ang pagkakaiba ngayon ng DRG with that of the case rate? Basically, ang prospective payment, may dalawang areas po yan. One is, the rates are predetermined, closed-end. So ano ang case rate? Predetermined yan, di ba? Alam niyo na kung magkano ang rate per package. Di ba? Pero ano pagkakaiba niya ngayon sa DRG as specified in the law? Okay? So ang tinitingnan po natin ngayon, ang pagbabayad natin is a global budget. Inpatient plus outpatient equals global budget. And the global budget is now going to be paid to the network, to the healthcare provider network. Be it purely public, purely private, or mixed. Sa network natin siya ibabayad. Okay? So, nandun pa lang tayo sa pagbabayad. So, yun po yun. Now, DRGs is actually classification of cases wherein it has the diseases have similar characteristics and the treatment costs are almost similar or resources being used are almost similar. It is also a fixed payment method para pong case rate. However, the rates are actually adjusted with the attributes. Ibig sabihin, meron pong modification factor. So halimbawa, para lang mas madali po natin maintindihan. So halimbawa, patient attributes, age, sex, gender, length of stay, diagnosis, procedures, facility characteristics. So, in simpler terms, halimbawa po CS. Kung after the validated costing methodology, halimbawa lang to since the doctors are here, but tayo bilang pasyente or members, lumabas na ang cost ng CS across all halimbawa lang ay 30,000. For non-complicated, it's 30,000. Pero kung CS with hypertension, CS with another procedure, CS with complications, CS with serious complications, meron pong mga adjustment factors yun. So, ibig sabihin, dadagdag yun doon sa fixed amount ng isang uncomplicated case. So, kung halimbawa, 30,000 plus 12,000, depende sa adjustment factor. So, ganun po yung DRGs. So, dependent on attributes, may adjustment factor. That is the more simpler way para lang po maipa-differ ko sa inyo or differentiate ko sa inyo kung paano natin i-appreciate yung DRG pagdating sa ganyan. So, kung ganun po ang mangyayari, ibig sabihin po, magkakaroon ng mga classifications and all. So sa ngayon, ano ng estado ng DRGs? So right now, we are writing the implementing guidelines for the DRGs. And for the global budget, we are writing the governing policies. This is being done together with the stakeholders, the medical societies, the associations, para po consulted din po sila. And later on, we will of course have trainings on this. I have given several lectures on the DRG sa PHA, PHAPI, PMA, medical societies. Now, so kung ganun po ang mangyayari, so yung DRG for the inpatient plus the capitation, global budget, yan po yung ating ibabayad to the network. Ano ang magiging relasyon niya ngayon to the special health fund? And this will be under this outline. And we will focus more with the Joint Memorandum Circular 2021-001. Okay. So ang sinasabi in Section 21 is that all income derived from PhilHealth shall accrue to the Special Health Fund. Okay? And this money shall be exclusively for the improvement of the LGU health system. Okay? So, iklaro ko lang. Ang Special Health Fund po is for the public sector. Ang sabi ng COA, although we are still writing and we are awaiting for the auditing and accounting guidelines coming from the COA, is that basta may government fund, it shall go to the Special Health Fund. So, ibig sabihin, in a purely public healthcare provider network, in a mixed healthcare provider network, PhilHealth shall pay the money to the network, and that money shall accrue to the Special Health Fund or ipapasok sa Special Health Fund. But for the purely private healthcare provider network, we will pay the money to the private network. Sa kanila yun. Hindi yun kailangang ipasok sa Special Health. Sila na yung bahala. Kung paano gagamitin. Kung paano make sure that the services are provided sa kanila yun. But again, for the mixed, it has to go to the Special Health Fund. Okay? So paano ngayon ang arrangements? So yan po yun, no? Of course, again, the technical, I guess, that the managerial, I understand, mukhang meron na kayong HCPN because you're already actually going into the technical integration. Dahil maglalike na kayo ng referral manual. And part of the referral manual actually is a technical integration. So sa financial integration, so yan naman po yung pooling. Siyempre, yung legal basis, it's the RA, it's the IRR, and the JMC. So the JMC speaks of the allocation, utilization, monitoring, and accountability of the Special Health Fund. This is a joint memorandum circular from the DOH, the DBM, the Department of Finance, the DILG, the PhilHealth, and it was out in 2021. Okay. So yan lang po, gusto ko lang banggitin na yan po yung mga legal basis. Now, just to categorize Ano po ba yung LGU funds? Ano po ba ang kinds of LGU funds? And why are we putting in the special health funds? Ang local government funds po or ang LGU funds ay unang-una, one, general funds. But the general funds are those from which they are not specifically obligated or specified ang purpose as declared by law. Chargeable to or payable from. But there are special funds that are deemed automatic, appropriated for the purposes indicated. Katulad po ngayon, meron na po tayong trust fund. Meron din po yung tinatawag na Special Education Fund. Nasa local government code yon. And by virtue of RA 11223 is the establishment of Special Health Fund. By the name itself, it is deemed automatic appropriated for health systems and services. Okay? So, ibig sabihin, with the Special Health Fund, klarado na itong mga pondong ito ay para sa health. Hindi siya pwedeng galawin for any other purpose. So, yan. And this is a pool of financial resources created at the province or at the citywide and as an augmentation of the LGU funds for health. Why it is an augmentation? Because hindi lang naman po itong mga pondong ito ang gagamitin for health. Nasa RA 11223 still and its IRR that there should be a mandatory counterpart for LGU to have the health funds. It may not be 1:1, but there is a mandatory counterpart for the local government. Makikita nyo later, saan ba gagamitin yung mandatory counterpart na yun? Okay? And take note, the Special Health Fund now will be managed, supervised, governed, coordinated by the Provincial Health Board and the City Health Board. And this will be done through an issuance of the resolution. Okay? So kung makikita po ninyo, kung familiar kayo sa local health board, hindi po siya inabolish ng RA 11223. Na-establish na siya ng local government code. Rather, in-expand siya sa RA 11223 or sa UHC Act. Okay. So sa ngayon, ang Special Health Fund shall only apply to those participating in the province-wide and city-wide health system. Sa ngayon po, we have around 71, 58 provinces, and the rest are ICC and UCCs. Bakit po limited to that? Because kung makikita nyo po sa RA, the first 6 years ay preparatory, hindi pa po siya mandatory. In the first 6 years, yung first 3 years is managerial and technical integration. The next 3 years is financial integration. And after the first 6 years, there will be an independent assessment of the initial reforms of the UHC, such that if the result of the assessment is a positive recommendation from the DOH Secretary, then the President of the Philippines will now come out with an executive order mandating everyone to adopt the universal healthcare reforms. So that is the time that it is going to be mandatory. Kaya po yung mga yon, nakikita nyo, yung mga UHC sites, all those are still voluntary. Kaya kahit po dito sa JMC, makikita nyo, meron pa rin recognition na in a healthcare provider or in an integration, maaaring may mga hindi sumasama pang municipality because they are still waiting and watching. Because voluntary pa siya. But later on, again, after 6 years and after the assessment, kung ima-mandate po siya, then that's the time it's going to be mandatory. Okay? So ito yan po, 58 provinces and then the 9 cities, IS, and then the 4. So ang Palawan, I guess, is doon sa 58. No? Now, gaya po ng nabanggit natin, the special health fund shall be managed by the board. And so, kasama rin po sa batas yung establishment ng organizational structures. So yan po, dapat daw at the province or at the citywide, meron dapat na responsible for secretariat to the board or the technical secretariat, and meron ding administrative secretariat to the board. Dapat naka-coordinate yan, and of course, again, in coordination with the local government units. So ito yung managing entity. Still the chair is the mayor or the governor, and the vice chair is the province or the city health officer. Pero, again, in-expand na po natin ang membership ng health board. So under RA ng local government code, we have the chair of the Committee on Health. We have the private sector representatives. We have the DOH rep. And with RA 8371, na-include po yung mga representative ng mga indigenous peoples or communities. And with RA 11223, because it is already a province-wide, andyan na po yung inclusion ng mga components or municipalities. Or, gaya ng nabanggit kanina, kung masyadong malaki ang province, pwedeng hatiin into districts or sub-districts at pwedeng representatives sa mga district and sub-districts. Kasi kung halimbawa, in a province-wide and there are 24 or 30 municipalities, sobrang laki naman ang board na yan. Okay? But again, it is expanded by virtue of RA 11223. By virtue of RA 7160 or the local government code, ito po ang functions ng City Health or Province-wide Health Board. Annual budgetary, advisory on health, and committees to advise on health issues. But under po RA 11223, and expand na po siya. Ito po ang additional functions ng board. It is now the board that will actually set the overall health policy directions, oversee, coordinate the integration and delivery of health services, manage the special health fund, exercise administrative and technical supervision. So expanded po yan. Kaya kung makikita nyo, yung special health fund shall now be managed by the board. That's why it is very important that yung pong magiging sources ng use ng special health fund ay klarado, planado, para guided ang board on how to utilize the special health fund. Now, it is good to note that the special health fund is not just only coming from PhilHealth. PhilHealth is just one of those putting money into the basket. Although considered po na pinakamalaki yung galing sa PhilHealth. But the sources of funds for the Special Health Fund would be the following. Grants from the NGAs, non-government agencies, PhilHealth, donations, and fund sources like LGU budget for health. But again, the LGU budget for health is optional sa ngayon na ilalagay sa Special Health Fund. Pwedeng nakahiwalay pa. But what is mandatory is there is a counterpart budget. Optional kung ipapasok na siya sa Special Health Fund or nakahiwalay pa or retained pa rin so far. Okay. So yan po yun. Saan gagamitin ang Special Health Fund? Diba for specific purpose? Nasa batas, saan lang pwedeng gamitin ang Special Health Fund? Population-based health services. Anin yan? Individual-based health services. Health system costs. Capital outlay, infrastructures. Remuneration of additional healthcare workers for UHC. And incentives for all health workers. Okay? Take note the remuneration of additional health workers. So katulad kanina, they create a managing entity, technical support, admin support. Ibig sabihin, yun pong mga creation nun, pwede gamitan for the remuneration. We will discuss individually examples kung saan siya pwedeng gamitin. Okay, so yan. Anim po yan. So specific purpose, automatic allotment, dyan po lang pwedeng gamitin. Hindi pwedeng gamitin sa iba. Now, accordingly, what are the allowable expenses? Examples. For population-based health services, we have environmental health services, including usong-uso ngayon, vector control for dengue, water quality and sanitation programs and projects, health promotions and campaigns, epidemiology, disease surveillance, services related to disease elimination, disaster preparedness and response to public health emergencies, and all others that will later on be identified as population-based health services. These are some of the examples, and these are actually written in the JS. For individual-based health services, as identified in Section 18 of the Universal Healthcare Act, Special Health Fund is used for ambulatory and inpatient care, so all for those services, medicines, laboratory tests, procedures, and all other services that will later be identified as individual-based. For health systems operating cost or MOOE, support to the management of the health system. Take note, may mga asterisk po siya sa dulo. Kung titingnan niyo po yung asterisk, may mga examples sa baba. So katulad po ng support to the management of the health system. That would include operations of the citywide health system, health board, and operations and hiring of personnel for the example, for the management unit. Gasoline for ambulances, patient transport vehicles, and vehicles used for delivery of health services. Fees that form part of accreditation, contracting, and licensing requirements. Learning and development interventions or capacity building activities This would include registration, participation fees related to the effective delivery of health services, conduct of training, seminar, conferences, or conventions. Again, as long as it is relevant to the management. Okay? For capital investments, health infrastructure, health equipment and instruments. But take note, the health infrastructure shall follow the health facility development plan as provided in your local investment plan or provincial investment plan and as approved by the Department of Health. Health equipment and instruments, IT and equipment, vehicles, mobile clinics, ambulatory health services. Okay, this would actually include facility improvement. Remuneration of additional health workers. Okay, salary schedule based on the existing laws. Salary, of course, shall not exceed. Additional health workers po ito, especially used for UHC. Because gaya ng nabanggit kanina, part of the allowable for the mandatory counterpart of the LGU is yung for the salary of its plantilla position. Naka-charge yun sa LGU, health fund. Hindi sa special health fund. But if there's a need for additional health workers, especially for UHC, then it can be. Incentives for all health workers. And this can include barangay health workers and barangay nutrition scholars. So all classified as health workers. Although, of course, we're still awaiting for the specific guidelines coming from the DOH, the TPM, and the DILG for the benefits and the incentives. Now, for the local government units, what are the mandatory counterpart funding na pwedeng i-charge sa kanila? Again, mandatory expenses. So these are for those not pulled to the SHF because again, it is optional still for now, but mandatory to have a counterpart. So mandatory expenses of the health facilities, offices, and services. So lahat ng mandatory, rent, utilities, waters. Remuneration of existing human resources for health. Physical office and administrative expenses, land acquisition, development, and the like. Now, where are we in the creation of the special health fund? Nandito tayo sa depository bank account. Right now, this is part of your deliverable under the maturity level 1 preparatory activities. Because the next would be organizational and then functional. Now we are still awaiting just what we said earlier. The COA is still coming out with the auditing and the accounting guidelines for the special health fund. And so for number 2 and number 3, gagawin pa po natin yan once these guidelines are out. In the JMC, there are responsibilities. But what is good to note is that there will now be a utilization tracking system for the special health fund. Ibig sabihin, meron na pong tracking system kung saan at paano ginagamit ang special health fund. Why? Because again, kung makikita po natin as part of the payment mechanism of PhilHealth, it should be performance-driven. So dapat ma-measure natin ang performance ng mga services being delivered and Hindi lang ito sa number or kind of performance, but at the end of the day, output. Output of this performance set. Okay? So meron din ng PhilHealth. Now, for transitory provisions, existing mechanisms. So, kung hindi pa kayo nag-adapt ng integration, because again, as I've said, it's not mandatory, existing arrangements will still happen. So, kung paano natin kayo binabayadan, ganun pa rin. Kung hindi pa kayo contracted as a network, then patuloy pa rin natin kayong i-accredit singly, babayadan case rate. But once it is already mandatory, then we have to go through the process. Okay? So kung meron mga LGU na hindi pa nagko-commit to the integration, ganun pa rin. Now, I guess, meron na kayong MOU, a tripartite MOU. And just take note, the release of PhilHealth payment shall commence once the province or the citywide is able to meet the minimum standards set by PhilHealth. So once we have started contracting your network, then that is the time that we will actually facilitate paying to the network, and now you will put that into the special health fund. Now, special health fund, gaya po ng binabanggit na natin, is a whole of government, whole of system, whole of society approach. That's why coming out with its policy, although it is being spearheaded by the DOH together with PhilHealth, all other government agencies involved with finances, like the ILG, DBM, DOF, Bureau of Local Government Finance, BIR, COA, and all others, like local government units and development partners helping us in the guidelines, like USAID, are together in coming out with the specific guidelines. We are also to come out with specific manual for the special health fund, and also the development of the special health fund tracking system that is now being done together with the ADB. At kung makikita po ninyo, yan, this is just a graphical representation of the whole of government approach. Now, ano yung nabanggit na sandbox? Ito. Because 2024 is a pivotal year for PhilHealth. And you have to prepare for it. Because we are looking at 2024-1 to start contracting with the network. Second, paying using the new provider payment mechanism, BRG and Global Budget. And third, coming out with a comprehensive outpatient benefit package. So dapat by then, meron na kayong network para makasama kayo dun sa mga mauuna na makokontrata natin. Hopefully, yung kasama kayo sa mga mapapilot. But prior to that, we will also do some testing and experimentation, which is the sandbox. At yung sa sandbox po na nabanggit kanina, we will try to pilot the initial implementation of the 3 reforms. Contracting a network, paying through to the network for special health fund. And that will start with our primary care. So yung PCPN or yung primary care provider network. But right now, that is being represented by our current primary care, the consulta. Consulta will later on be transported to a comprehensive outpatient benefit package. Alam naman natin that the consulta is limited. It is for like 10 diseases 12 laboratories and diagnostics, around 20 plus molecules, drug molecules. Pero ang sinasabi sa batas, it should be comprehensive. Kasi di ba, aligned with the reform that everyone should first go through a primary care. So ibig sabihin, dapat pagpunta natin sa primary care, kailangang masagutan kung ano ang ating karamdaman. So dapat comprehensive siya. So we are developing that. And the initial step right now is konsulta. So I hope dito sa atin sa Puerto Princesa, meron na tayong mga konsulta accredited providers. Later on, this will be transported to primary care facilities and they will form as the base, foundation of your healthcare provider network. So ano yung sandbox? Consulta accredited providers in a city or province will form a network of primary care. So yun yung una nating isa-sandbox or iti-test. We will contract with them and we will start also paying using the new capitation method. At yun po, pag meron na, ibig sabihin, meron na rin pwedeng ilagay sa Special Health Fund. And that will happen in 2023 as an initial step for the 2024. Para may learning curve din tayo para po doon. So, primary care ang uunahin natin. So for example, according to standards, ang isang primary care provider, doctor at that, maximum of 20,000 patient ang pwede sa kanya. So 1:20,000. So kung dito po sa City Health or Puerto Princesa, anong population ng Puerto Princesa? 300,000. For a 20,000, so ilan ang kailangan natin doktor? 15. Para po mai-register lahat to a primary care para may mag-aalaga. Kasi di ba yun ang gusto ng UHC? Dahil doon ka na dapat magpapacheck up, dapat nakaregister ka to every primary care. So gone are the days na may mga nagkakasakit or namamatay na hindi man lang nakikita ng doktor. Unless of course, hindi kayo nagpapacheck up. Pero naka-assign na kayo or nakalista na kayo sa isang primary care. So, per doctor yun. So, sa isang consulta provider, pwedeng 2 doktor, 3 doktor. So, sa isang consulta provider facility, kung 2 doktor, sabihin, maximum of 40,000. Pwedeng magpa-enlist sa kanila. Or register, as they call it. Pero that's maximum. Diba? So, kung titingnan natin doon sa prospective payment ngayon, using the same consulta network at 500 per person, kung 20,000 or kung halimbawa 300,000 times 500, magkano? Sorry. Kung 300,000 times 500, 150 million in total ang capitation. That's the computed amount. Kasi per person ang computation natin. So kung may register natin sila lahat, magagawa ng first patient encounter, ibig sabihin, mababayaran natin yon. Plus of course, other deliverables. But, again, ang sinasabi sa batas, it should be performance driven. So dapat may set and agreed tayong performance indicators and targets. Pero that's the money that will go around for the primary care from PhilHealth. But later on, sa 150 million, plus, kung magkakaroon ng tayo at mag-develop na ang DRG, i-compute natin ang cases in all the hospitals in your network. Ko-compute natin yung lahat, magkano. At the onset, kung aabutin niya ng 500 million, ibig sabihin 500 plus 150 million, that's around 650 million as the global budget. That's the negotiated amount na ibibigay natin sa network. But of course, pwede naman natin hindi ibigay lahat-lahat. Pwedeng in tranches because again, the law provides it should be performance driven. So pwede because ang prospective payment, one, predetermined. Second, manner or timeliness of payment. It can be provided before the services are given or after the services are provided. What's happening right now? Predetermined and reimbursed. Paid after the services are provided. So what we are looking right now is the other side. Payment before the services or front loading of money. So ibig sabihin, kung magpo-front load na tayo ng pera accordingly as computed, of course it can vary, then ibig sabihin walang dahilan na ang mga serbisyo ay hindi na ibibigay. So later on, also as part of the reforms of the UHC, PhilHealth na actually ang maniningil sa mga ospital or sa mga providers. Nasa na ang binayagan namin na serbisyo na ganito? Kung ang inyong census, for example, ICS, ay 40,000 or 400 pala cases a year at binayagan natin yan. Pero bakit po ang inyong performance ngayon ay 200 pa lang? Nasa na yung iba? So we need to check. So yun, ganun po yun. So ibig sabihin, pwede po ngayon na ipo-front load na natin yung payment. At yun ang tinitingnan natin ngayon at kinakausap with the COA. Because it is now being recognized that it is actually part of the law, the prospective payment mechanism. So once we are out with the guidelines on this and once the COA has actually approved, then we will come out with the guidelines on that one. But as a preparatory, kung yan po ang ating gusto mangyari in 2024, anong slide yan? Yan. In 2024, so dapat in 2022, 2023, yan ang gagawin natin. Pero dapat at the local government unit, you are one, nakapag-integrate na managerially, technically meron na rin, and nakapag-establish na financially. And meron na pong network ready for contracting. Yes, yes, sir.
Sir, can you give a specific patient? For example, yung isang pasyente from Quezon, Palawan, i-refer siya sa network. Ang Quezon kasi level 1 lang hospital doon. Oo, palagay na natin outside Puerto, Princesa. So, primary care lang ang mabibigay nila doon. For example, ang pasyente, chronic renal failure, kailangan ng transplant. So, i-refer siya sa Manila. Sir, mag-out of pocket pa ba ang pasyente? Yun ang one question. Second, sir, for example, naka-incurred ng 3 million sa expenses ang pasyente. Babayaran ba ito ng UHC?
Okay.
Thank you.
Apa. First, establish muna natin yung network. So, ang Quezon is part of the provincial health network. So, hiwalay siya most likely sa city, Puerto Princesa. So, ang sinasabi, in a establishment of a health network, it has to have a primary care, secondary care, and tertiary care. So, doon siya. So, kung meron kailangan at a higher level, it is within the network. Because remember, bayad na yung serbisyo na yan. Now, kung halimbawa, kakailanganin niya for an end referral, so ang end referral hospital po hiwalay siya sa province or sa citywide. And the end referral or apex hospitals shall be contracted separately by PhilHealth. Hindi siya kasama sa contract with the province and this. So iba po yung bayad natin doon. So kung halimbawa dito tapos ini-refer, ibig sabihin bayad na rin po yun doon. Kung saan man siya. Second, payment. The law now provides equitable access to the UHC when it comes to financial protection.
Gusto niyo po hapon kasi gabi.
Because the law now provides a no co-payment policy.
Wala na, pinaalis ko na yung po.
The no co-payment policy, kung dati po kasi merong no balance billing. But the no balance billing is limited, of course, alam niyo naman sa mga indigent and to the government. But the UHC now expanded it to a no co-payment policy and that any Filipino who opted to be admitted in a ward or basic accommodation shall be afforded with a no balance billing, with a no co-payment policy. Inilagay din sa batas under the regulation section that not less than 90% of the beds in government facilities are basic or ward accommodation. Not less than 70% of the specialty hospitals, which more likely are your apex or referral hospitals. Not less than 70% of the beds are basic or ward accommodation. And for the private, it is not less than 10%. Now, what are we doing now to make sure that we actually approximate the payment? Kasi ang isa sa mga issue ngayon is baba naman ng case rate, baba naman ng ganyan. Kaya po kahit sa batas, it is a validated costing methodology. So what we are doing right now is actually we are costing healthcare services. Meron na po tayong first exercise on this, and we are now doing the cost analysis. We will have the second and the third, expanding the sources of cost of healthcare. Kaya po ang lagi kong sinasabi in all of my discussions, especially sa mga medical societies and hospitals, if you are asked to participate in the costing initiative, please do so. Because that is the only way for us to get the cost. Otherwise, kung walang sumasali at walang nagbibigay ng tamang data and tamang cost, paano tayo makakapag-come out with the real cost and pay the hospital or the facilities the necessary or the approximate amount? Kaya po sana, I guess most of you are also in the private, not also in the public. Please do so. Join and provide data. Pwede rin naman po na kung hindi po kayo na-invite pa, pwede po kayo mag-initiative that you want to join, to participate. For example, Palawan Medical Society. Because I got already letters coming from different medical societies that they want to join. So we have forwarded it na para po sa clustering. So pwede rin po yun. So, other than the no co-payment policy, nasa batas na rin po naman is the other side of the coin, co-payment. At ang sinasabi, sa co-payment naman, dapat maglalabas ng polisiya ngayon ng co-payment for those admissions outside the basic or the non-ward accommodation. And this co-payment policy, ang tinitingnan natin ngayon is we are developing a fixed co-payment policy for those accommodations on top of the basic or ward. For example, deluxe, semi-private, private. But of course, we're leaving the suite and all. Because if you want to be admitted in a suite, then more likely you can actually afford to pay. And those and the amenities in those areas are not really needed probably for the minimum health standards that you need for the treatment of care. So yon. Third, to make sure that the cost is being covered and spread across, nasa batas na rin po ngayon that there should be a benefit complementation between the government and the private. That's why we are now establishing a coordinating mechanism between PhilHealth, HMOs, the private health insurances, life and non-life. Because ang sinasabi sa batas ngayon is that the services being covered by the government or by PhilHealth at that should be complemented by the private, not duplicated. So kung ano mga hindi nako-cover, for example, ng PhilHealth, dapat yun ang kino-cover ng HMO and all. Para nagko-complement siya at nagsusupplement. Hindi nagduduplicate. So na ma-maximize ang gamit natin for both. Now, ang tanong, masusustain ba? Kasi baka masyadong malaki. Well, for one, kung makikita po ninyo, nasa batas na rin or isinabatas na rin po yung premium increases until 2025. Second, yun pong pera na galing sa PAGCOR and PCSO are meant to expand the benefits so that we can actually make sure and hopefully we can make sure na ma-expand at may pondo na susuporta para doon. So yan po yung mga mekanismo na tinitingnan natin ngayon. Now, kung ako ay taga Quezon, so I belong to the provincial health system. Kung may kailangan, dito ako sa network na ito i-refer. Kung by choice, hindi, gusto ko sa Palawan, sa Puerto Princesa, outside of the network. Sa ngayon, out of pocket siya. Because remember, your services are already paid in your provincial network. And dapat kasi ito yung mag-aalaga sa'yo. And take note, di ba, in the establishment of a healthcare provider network, it should be complete, primary, secondary, tertiary. Kung kulang, yun yung binabanggit that you can have contractual arrangements. Now, ano rin ang control natin? To make sure naman that the facilities will actually provide quality service and make sure na alagaan tayo. Remember, the registration to a primary net to a network starting at the primary is of choice. So kung saan po ninyo gusto. But of course, syempre convenience yan. Kung nandito ako sa Palawan, ba't naman ako papalit sa Davao? Diba? So syempre dito pa rin. Pero kung halimbawa, ako naman ay taga Palawan, pero okay nagtatrabaho sa taga Quezon ako, pero okay nagtatrabaho sa Puerto Princesa, mas pipili ko siguro dito kasi mas malimit ako dito. And by policy, every year, pwede tayong magpalit. Kung hindi maganda ang serbisyong ibinibigay, hindi ako naaalagaan dito, pili ako ng iba. Doon sa lahat ng mga naka-credit doon sa lahat ng nakakontrata doon. Lilipat ako. So technically, kung lilipat ako, yung pera na payment for me, babawas yan sa network kasi pupunta siya sa kabila. Pero syempre, di ba, may maximum, may maximum. Pero it is actually control also. Because that is also a way for us to monitor. Remember, this is a performance driven. May performance indicator, may performance targets. At may tracking. So what you check, that's why it is also very good that in part of your manual, you're actually also writing client questionnaire surveys. Because that should also be actually be part of the services. Yes, Doctor.
Sir, yung performance driven, ano yung basis doon? Number of cases seen or mortality rate, admission rate, mga ganyan. Anong basis po ng performance?
Other than those po will be performance outcomes. Also, gaano kataas ang infection, gaano kataas ang, other than the mortality, the regular waiting period, that is for your primary care. So lahat po yun, we will try to establish. Kung makikita po ninyo ngayon sa konsulta, yung mga performance indicators natin, halimbawa hypertension and diabetes, 5 or 10% of those dapat hindi na ako confine. Or at least 5% or less than 10% ay dapat hindi na ako confine because ibig sabihin naaalagaan, nabibigyan ng gamot. Other than that, what's the use kung patuloy pa rin hindi na po contain or na-maintain? So may mga ganun pong performance indicators, performance targets na isa-set tayo.
Sir,
Yes, Doc.
sir, meaning walang ceiling ang admission expenses ng isang member ng UHC kung nasa ward siya.
Sa ngayon po, ang sinasabi natin is yes, but because nasa batas no co-payment, di ba? But it has to follow, kung makikita po ninyo, nasa batas din sa section ng technical integration that every facility, every network shall follow the National Treatment Protocol Guidelines na ilalabas ng DOH, and that is part of the job of the technical integration team. So that is also where the referral will come in. When is the best time to refer? What will be the services that should be covered in the primary, in the secondary, or in the tertiary? So there will be national technical protocol treatment guidelines na ilalabas. Second, we are still covered by one, PNDF. So, kasama pa rin po yan. Second, ang sinasabi sa batas is that what we are going to pay as a benefit, not only for PhilHealth, but also for the DOH, is those or are those that have positive recommendation from the Health Technology Assessment Council. So lahat pa yun, dadaan pa rin doon, ibig sabihin. So ibig sabihin po, dapat masunod din natin and we will monitor on those. So if there are deviants from the national technical guidelines or protocols as is, so we will also check on those. Pero meron pa rin po tayong mga controls on those sides such that it is not actually free living for everyone. Pero sa ngayon po, ang binabanggit is kung nandun ka, no co-payment. Yun yung nasa batas. Kung titingnan po natin yung, ano bang, hindi ko lang matandaan, yung issue ng mga, how do we consider special rooms, special beds? Is it a ward? Is it a basic accommodation? In an ICU setup, is there a ward bed? So may mga ganung issue na kailangan din natin i-check. Kasi syempre alam naman natin na napakalaki ng cost for the treatment of those cases. Plus of course, kung makikita po ninyo, nandiyan pa rin yung mga Z-benefit packages ng PhilHealth na we are expanding, even the cost. And that will actually respond to some of those issues too. Pero klaro may tanong ako, sorry. Kasi may private, di ba? Anong setup ng Puerto Princesa? Mixed? Or may public, may private? Anong nakikita ninyo?
Sir, Dr. Carlos Pakan, City Health Office.
Ay,
Kasi po, yun nga po ang ano namin. Now, just to give you a brief overview, meron po kami, ang primary care providers po namin are composed of public and private practitioners, which is sa amin po, in the City Health, part of the City Health, we are forming a 5 primary care facilities located in the outskirts, plus 1 in the center. And then po, we have one medical center po. So yun po. Actually, sir, wala po kaming level 1 dito. Pero tapos po, yung private hospital namin are 3 na level 3 and 1 na public. Ay, level 2. 3 na level 2 and 1 na level 2 na DOH retained hospital, which is the hospital ng Palawan. Again, sir,
sa Puerto Princesa.
yes po. So, yun nga po yung issue namin because the Puerto Princesa City does not have an LGU-owned hospital. That's why we cannot, yun po, the best way to come forward is really to have contractual arrangements po with the private hospitals and hospital ng Palawan for us to be able to create the network.
So mix.
Yes po.
So you just have to negotiate with them.
Yes po.
Because again, a network can either be one, purely public, purely private, a mix, and they can actually coexist in a full health system. So in a Puerto Princesa, pwedeng may purely private, may purely public. Pwedeng mag-coexist yan.
Tapos pwede din pong mix.
Pwedeng mix, pwedeng isa lang. So, kung masyadong malaki, pwedeng 3, pwedeng 4. Pero again, yun. So you just have to negotiate. But, again, for a healthcare provider network, all the services should be complete. So yun ang kailangan pag-usapan. Kasi baka hindi rin naman makakompleto ang private.
Yes po. So yun po
You have level 2. Do you have primary care?
Ngayon, parang level 2 po lahat eh. So,
Tapos ang primary care are all RHUs.
yes, primary care facility.
Unless may mag-invest sa primary care sa private.
ESG.
In the level 1. So they get set up. And then of course, find out apex the parent. But dito natin talaga makikita that the government cannot handle it all. Yun na nga lang kung issue ng 300,000. Kung 20,000 ang maximum per provider, so you need like 12 primary care facilities. I mean primary care provider doctor. Diba? Eh ilan ang primary care provider doctor natin sa City Health? Or sa
yung doctors po namin actually pasok naman po 14 kami sa City Health Office. Pero syempre we also look into it na syempre po meron din po kaming primary care na private providers so that hindi po namin syempre hindi naman namin lahat makukuha
kasi
and
yung 20,000.
it's just a big yes po. Especially if we will be putting it sa mga outskirts and our GIDA area. Siyempre, if they will be assigned there, siyempre mahirap din po na kukuha siya ng 20,000, they would cover at least siguro mga 20 barangay.
Remember, alagaan mo yun.
Yes po.
Remember, UHC is not just for the sick. It is also for the well. Ang trabaho ng primary care is one, to make sure that the sick are well and to maintain well those who are well. Remember, one of the principles of the UHC is it is people-centered. It is not patient-centered. So hindi lang siya nakafocus sa patient. Nakafocus siya sa mga tao. That's why one of the objective really is health literacy. That's for everyone, not only for the sick. So yun ang mga kailangan i-set up. So yun. Tapos yun po, again, sa agam-agam ng private, ang pera nyo hindi papasok sa special health fund. Unless, naka-mixed network kayo. Pero kung kayo purely private, natin ibaba din. Then it's for your own purposes. Question pa po. Siguro I will not delve into the DRG. Alam naman na yan ng mga doktor, global budget and all. So, yes,
Sir, yung question ko lang po, sir, gaano ba katagal mababayaran ng doktor? Is it the same as kung paano nagbabayad ng PhilHealth?
ang tinitingnan po natin ngayon, again, sa ngayon kasi, di ba, the way we pay is reimbursement. Pero gaya po na nabanggit ko, the way we are looking right now under the UHC is a front loading of money. So, ibig sabihin, hindi siya reimbursement type. Ibig sabihin, magpo-front load na tayo ng money accordingly. Part of our contract is a negotiated amount. Makukwenta naman natin yan, di ba? 500 per person, tapos yung pong amounts. So later on, i-adjust na lang natin yan. Pero ganun po yung tinitingnan natin. We are just confirming the policies with the COA. Because di ba, as a national government, ang COA kasi is always government fund is paid only after the service. Kaya lang, recognize na nasa batas na mayroong prospective payment ngayon. And part of the characteristic of the prospective payment is that it can either be paid prior or after the services. So, ang tinitingnan natin is prior. So, ibig sabihin po, kung ang pera ay naibigay na natin sa network or may tranche na naibigay na tayo sa network, then basically, nandun na yung pera. It will now depend on the network on when to give it to the doctors. Because remember, hindi naman yan may bibigay sa inyo kung wala pa kayong serbisyong naibigay. But, the money is there already. Kaya kami na po later yung maningil na nasa na yung mga binayadan namin na ganitong servisyo. So, yun na po yun. Now, for your concerns naman sa mga current natin, yan naman po patuloy pa rin natin babayadan, patuloy pa rin natin ipoprocess kung kailangan mabayadan, kung kailangan ma-process until we shift to that. Wala naman pong maiiwan na hindi natin makakayos. Yes, sir.
Sir, yung system nyo ng payment ng PhilHealth will be a new system or dalawang
Yes.
system na kasi like, ang issue kasi with PhilHealth is that previously is yung nag-change ng system, yung mga backlogs hindi na po binayaran. So kung mag-change ulit ng system yung PhilHealth, paano yung mga backlogs sa mga hospital?
Ay, sir, wala po kaming backlog na hindi nababayaran unless hindi talaga siya pwedeng bayaran. So lahat po ng mga naiwan natin, kaya nga po yung ating pong mga PhilHealth sa ngayon, meron po tayong mga reconciliation na ginagawa because kung meron man po kami hindi pa nababayaran, kailangan po ma-check kung bakit hindi nababayaran. If it is like denied, kung na-appeal ba yan o hindi pa, kung yan po ba binalik namin, tapos hindi pa rin nai-submit sa amin, so yung mga pending na ganyan. Pero lahat po again, gaya ng banggit ko, na kailangan dapat mabayadan ng PhilHealth. Now, paano po later on? Yes, we will have, kung makikita niyo rin po sa UHC, merong health information system section that there should be one health information system that is interoperable and interconnected. So sa ngayon po, yan ay ginagawa ng PhilHealth at saka ng Department of Health para magkaroon ng isang system na gagamitin. Even po sa payment natin, magiging isa rin po.
Ano naman sir magiging role ng mga private units regarding doon sa like you were mentioning around na each parang population we will be enrolled in a specific like doctor for example.
So for example, you mentioned about doon sa City Health na yung 20,000. Yung mga private clinics po, anong magiging role nun?
Dalawa po. One, you can go to a primary care facility. Either you upgrade it to a primary care facility, so pwede po kayong mag-apply as a primary care, so we will accredit that, and you can also actually be part of a network. Kung kayo naman ay specialista, then later on, you will be part of the network also as a specialist. But yun pong mga primary care, yung pong mga pasyente natin kasi will be sa primary care facility mariregister. Ang sinasabi sa batas ngayon is that all healthcare facilities shall be licensed, including primary care facilities. So kahit po sa ngayon, kung meron kayong private clinic, gusto niyo pong mag-participate, you can actually invest and have it accredited as a consulta provider, primary care consulta also, which later on, hopefully will be licensed as a primary care. Or, katulad po na nabanggit natin, pwede po may contractual obligations. Halimbawa with the City Health, tapos may kakulangan na serbisyo, at yung pong serbisyo na yon ay meron doon sa isang farmasiya or isang laboratory or CT scan or MRI in a hospital, pwede may contractual obligations.
Ang concern ko kasi sir, like yung mga secondary hospitals dito ay may mga outpatient department. And most of the outpatient departments na hinahawakan nila most of them are specialists. So kung parang ganun yung direction is that doon sa mga clinics na yun, halos wala nang pupunta.
Meron pa rin naman po. Pero ang sinasabi ngayon lang is the patient pathway shall start with the primary care. Hindi na po didiretso to specialist. So kung kakailangan makakita ng espesyalista, the primary care will actually. So halimbawa, you are in the network, Palawan or Puerto Princesa City network. Ako yung pasyente. Kailangan ko ng pulmonologist. So naka-primary care ako, di ba? Sabihin sa akin, naku, kailangan nyo pong makita ng isang pulmonologist. Ito po ang mga pulmonologist dito sa ating network. Pili po kayo. So pinili ko si Dr. B. So the primary care provider will actually coordinate with Dr. B. Na meron po kaming i-coordinate at i-refer na pasyente dyan from our network. Para po sa inyo makita dahil kailangan may makita ng pulmonologist. Or, hospital, kailangan nyo ng hospital for confinement. Ito po yung mga hospital dito sa ating network. Pili po kayo kung saan nyo gusto dyan. Pag nakapili, i-coordinate din ng primary care para doon siya ma-admit. After the episode of care, bababa po siya.
After, for example, sir, follow-up, doon na naman siya pabalik sa primary care.
Sa primary care na po,
Yes.
because sa primary care na po mag-aanakan. But again, of course, if it is a specialist care, if it's a specialist care pa rin po siya, kailangan lang niya laging dumaan lang sa primary care for the referral and for the, para ma-integrate, para ma-follow up ang pasyente. Because remember, ang trabaho ng primary care is not just a primary care, it is also a navigator, a coordinator.
So, ang understanding sir is that the specialist will be handling yung special
Yes.
cases. Yung halimbawa po, mga general cases, hindi na nila hawakan. Parang ganun na dating.
So technically, ang tinitingnan dyan is you will now choose either you're a generalist or a specialist. So kung generalist ka, at kung generalist ka, at mayroong magpaparegister sa iyo, for example, accredited ka or you're part of the primary care, at mayroong magpapalista sa iyo, so aalagaan mo yung mga 20,000 maximum na yun.
Thank you.
And the specialist will remain as a specialist. Of course, the generalists, but they cannot admit ang mga specialista nila in a hospital setting.
Good morning, sir. Dr. Castillo from MNG. Sir, I have 3 questions. Support ko lang yung, back up dun sa tanong ni Dr. Salazar. Kasi I've attended UHC orientation way back pre-pandemic. Parang nabanggit po nun, the specialist can also be a primary care physician as long as certified by the DOH. So yun po yung unang tanong ko. Sige, sir. Answer mo.
Dalawa po ang requirement ngayon. So kung ikaw ay specialista, pero gusto mo mag-practice sa primary care, pwede po yan. All primary care providers shall now be certified by the Department of Health. It's part of the law and the IRR. Kasama po sa facility, just like the facility shall be licensed by the Department of Health, primary care provider professionals should be certified by DOH, PRC, and kung sino man ang ma-deputize. Because there are competencies in the primary care. Hindi lang naman po yan konsultasyon. Part of the primary care, di po ba nandyan din yung mga health promotion, vaccination, the rest of all those things. That's why the primary care provider professional are not just doctors. Nandun yung nurses, nandun yung midwives, and the rest. And they shall be certified according to competence. So, if you choose to be primary care, then primary care ka, magpapa-certify ka. If you choose to be specialist ka, then specialist ka. But you cannot shift from specialist. You cannot shift from a primary care provider and then I will refer the patient to me also for the specialist care. And admit the same patient also. Yes.
Thank you, sir. Sir, regarding prospective payment, you mentioned before that one of the bases is the data that we submit. For example, how much does it cost in a facility, yung X-ray, you know. But will you also go back to historical data, like what PhilHealth has been paying, like in the last 5 years for the hospital?
We will simulate all, but again, it has to go through a validated cost methodology because we need to approximate the cost of care. Remember, this is the cost of care, not the price. This is the cost of care, so that we can actually approximate the amount that we will need to pay. Because remember, we will exact policy on no co-payment and co-payment. So we will check also on those, but of course, that is the reason why we are doing the cost scheme exercise right now. Because we want to know what really is the cost of care. To make sure that we really approximate and pay accordingly.
Kaya lang, sir, diba, the cost of care is different from one locality to another.
Yes.
So like in Manila, medyo mas mahal siya compared to us sa Palawan.
Yes.
So how can that hindi na pare-pareho siya national guideline?
Well, kaya po pinasimulate din natin siya. That's why there will always be adjustment factors. Kaya kung makikita rin po ninyo dun sa one of the payment sa patient attribute or those attributes na pwede na maging basis for an attribute is like the level of care, urban or rural area, so that we can put aside the adjustment factor appropriately.
So part po yung location pala.
Yes.
Sir, last question. Regarding, I would just like to be clarified dun sa special health fund. Kasi right now, what we're doing is case rates. So yung benefits po o yung reimbursement from PhilHealth, binabagsak sa hospital for the institution and the physicians. Nakikita ko kasi sa Puerto, mukhang magkakaroon kami ng mixed. So it means the reimbursement ba will go to the special health fund?
The payment, because it may not be reimbursement, di ba?
Okay.
Pwede front-loaded. The payment will go to the network. Pero ang sinasabi sa batas, that payment shall accrue to the special health fund. Ibig sabihin, ipapasok ng network to the special health fund. At kung yan ay public sector, yes. Kung yan ay mixed, according to the COA, yes. Because there is a public sector side. Ngayon, anong importante? Ang importante ngayon, kung mixed ang network, even public, kailangan mapag-usapan and maset sa province board or sa city health board paano ang distribution ng pera. From the board or from the special health fund to the specific facilities. Kung ano ang servisyo na ginagawa, kung ano ang nagagastos, dapat napapag-usapan yan. At dapat nagagawa ng guidelines.
So, tapos paano pa po makakascale dun sa individual doctors?
Yes, yes. Because it will have to go per facility. So, kailangan mag-ayos ka. Kailangan may ayos, kaya very important that you actually participate. Especially in the discussion pagdating sa kung talagang magiging network, mixed network kayo. Kailangan pag-usapan paano ang usapin ninyo ng pagbabayad from the special health fund to your facility. And of course, again, just like as it is from your facility, the individuals. Kung paano.
Although, sir, dun sa managing board kasi wala yung individual hospitals di ba? Parang hindi sila kasama.
Nandun po yung sa private.
Isa lang.
Yeah. That is in a setup po kasi yan na purely public. Gaya ng binanggit kanina, for a mix and for purely private, yung purely private, walang problema. Yung sa mix, ginagawa pa po natin ng specific guide.
Okay, sir. Thank you.
Yes, ma'am.
Pero yung dun sa board na sinasabi, di ba meron doon nakalagay, mayor, governor, tapos, di ba pwede sir kumuha ng representative from other hospitals? Kasi, alam naman natin minsan sa politics, napupolitika yung pera. So, pwede bang kumuha ng representative from different hospitals para naman may voice yung hindi siya talaga mamamalay ang pera, ang budget? Thank you.
Actually, kung ang kita po natin doon sa guidelines, resource persons can actually be invited. So kahit po ang Philippines is part of the resource, hindi po kami kasali doon sa board membership. But yes, especially in the mix, or halimbawa, well, it's private kasi, that is run naman and owned by the LGU, so walang problema. Pero kung sa mix, I think, yes, that should be part.
To answer na lang din po, siguro with the part po ng citizen, we took note of that, Doctora, so that for the next local health board meeting, we can discuss po kung if we can add private sector representatives po to the local health board. Sir, may clarification lang ako regarding doon sa primary care. Most of the patients, kasi for example, like at Adventist Hospital, most of our OPD patients, 40% of that are HMOs. So, paano po yung magiging setup natin with the HMO and yung copay?
Yeah. Again, every Filipino, walang ano yan every Filipino should be registered to a primary care. So, ibig sabihin that's a general social insurance benefit for everyone. Ngayon, kung may HMO po, paano? Diyan po papasok yung pinag-uusapan ngayon under the benefit complementation. Ilalabas pa lang, I just submitted the proposed joint memorandum circular to the DOH Execom. Hopefully, masignan siya. So, kung masignan po siya, we will create now the committee between the DOH, Health Insurance Commission, and the AMOP and PAMO, the health insurance, the PILA and the PIRA, the life and non-life insurances. And then from there, we will come out with the guidelines. This is, of course, in coordination and consultation with the Insurance Commission. Yan po yung kailangan natin mapag-usapan on how to complement not only the outpatient but also the inpatient more particularly. Yes, sir.
Sir Dr. Cipriano from question lang po. What will happen to the QFS that is augmenting PhilHealth po? Would this be going to the special health fund to be put, or it will be retained for the hospital to be
Actually,
utilized?
it's not. The QFS, hindi naman siya for PhilHealth, but rather it's really a support
Support for the
yes, for the health system. Sa ngayon po, nandyan pa rin muna siya. But, pag-uusapan kung paano, especially so, later if kakayanin na ng UHC fund.
Hindi ba malasakit, sir?
Yes, actually, I was one of those who with the malasakit when we wrote the law and the IRR. So, ang position ko nga po ngayon dyan is kailangan natin i-revisit now ang relationship ng malasakit with that of the UHC. Kasi at the end of the day, there should be, again, no duplicate. But eventually, kailangan natin ma-i-align ang lahat ng tulong pagdating sa health, not only for the UHC, including all those other funding like MAIT, PFS, and malasakit. Yes.
Thank you, sir.
But so far, nandyan pa po siya.
Sir, ako po,
Unless it will be affected, of course, by the mandamus ruling. Yes.
sir, ano po, may question din po. Regarding po, for example, there's, aside yun po, sa primary care provider, we refer the patient to a specialist on his or her medical outpatient clinic. So, how do you see the payment mechanism po on that? How are we going to pay with, ano po, with the outpatient clinic po, specialist? Are there guidelines na po regarding this?
Kapa po sa ngayon na specific guidelines on that. But yes, we will also come out with the guidelines on what to cover, especially for the specialists.
Hey, sir. Manilin po from Provincial Health
Yes,
Office.
ma'am.
I would like to ask Doc, kasi we have clinics and laboratories here in Puerto Princesa. And then we cater primary health care. I would like to ask kung sa province ba siya papasok or we need to coordinate with the city para kay city papasok yung primary health care. Like the provincial capital employees are one of our mga patients in like the vaccination, sa amin po sila pumapasok sa provincial health office. Pero our office, we're here in Puerto Princesa po.
Again po, it will depend on the patient's choice. Kung saan siya pipili, kung sino ang gusto niyang primary care facility. Now, if the primary care facility belongs to the citywide health system or the province-wide health system. So kung citywide health system, then definitely yung payment po sa kanya will be on the city. Ibig sabihin, doon din siya dapat nagpapacheck up. Doon din po dapat, yun yung nag-aalaga sa. So kung nandun ka naman at ang pinili, halimbawa at the province-wide level, yun yung primary care mo, then sa province po natin ibabayan. I mean, there's a network ng province-wide health system.
Okay, Doc, thank you po.
Doc, tanong lang po doon sa e-claims po, lalo na po sa rabies program.
Saan po?
Rabies po. Sa rabies, sa vaccination.
Rabies.
Opo. Kasi may mga pasyente po kami na nag-start po sa ONP, halimbawa, ng first dose, ang continuation po sa amin. So, sino po ang mag-claim nun sa e-claim? Kami po taga City Health or province po?
I would like to recognize our head of the Palawan office, Wilfred Hernandez. Nandito po siya. Sorry, out of the topic kasi. So, ang isip ko lang. I'll check na lang muna, ha? Fred, paki-check lang, ha? So, ang issue lang nyo is, nag-start yung rabies vaccination with City Health. Okay. Then, are both accredited? We'll check. Sige, ma'am.
Morning, Miss. It was mentioned by the earlier speaker, sorry, I'm asking them what alam ni Hooter, that direct contributors will have additional benefits. What are those possible benefits?
Ang nakalagay po doon, additional benefits for any additional premium contributions. So, kasama po dyan yung pag-expand natin ng mga benefits na binabanggit natin. Although hindi ako nagpakita, but right now, for example, kasama po yung pag-develop natin ng comprehensive outpatient benefit package or yung pag-expand natin ng mga beneficiaries na ngayon. Like for 2022, we are to come out with mental health package. For malnutrition, we are expanding also some of our Z benefit packages. So, yun pong ating dialysis is at 144 for 2022. So yun pong mga ganon are benefits that are being expanded for, especially for the direct contributors. So you would expect more. Yun tala po, wala po akong presentation, but yes, there are a lot. But those are some of the examples. Meron na po kaming benefit development plan for the next 5 years.
My questions pa po from the body. Ito na lang po sure from only questions from our QR or there's a question here regarding the payment of HMOs in the universal healthcare po. Will the health maintenance organization for HMO pay the network or still pay the individual hospital?
I guess hospitals po sila. Hindi naman hiwalay po yung sa HMOs. But what we are trying to come out right now is the benefit complementation.
For the unit.
Between us and between because remember, ang HMO is individual yan eh. Kung sino may kaya lang ang nakakakuha, hindi naman po yan para sila. So they will have their own guidelines, but ang kailangan natin i-set on how to complement the benefits. I guess it's still with the facilities because they have their own MOA with each facility and actually with each doctor yata, di ba?
Okay po, thank you po. Sir, last question from me there. There were news items circulating the PhilHealth decision of funds by 2027 and how will it affect the UHC implementation?
Aquarial type, I guess. Yan naman po ay according to assumptions. Especially so if we are not one, if we will continue not to increase our premium as mandated by law, if people will continue not to pay their premium contributions, if we are continuously not being given the amount as computed or as requested in the GAA. So may mga assumptions po yan. Because remember, our benefits as we expanded should be aligned with our financial viability. Okay? So kung mag-expand po tayo na mag-expand, of course, we need the money to support. So yung po yan, mga yan, ay based naman sa assumption.
Thank you, Doc.
Sir, question again. Sir, if you don't mind, may pera pa po ba ang PhilHealth?
Yes, magkano ba reserve fund natin sa ngayon? More than 170 plus billion, I guess.
Sir, do you invest it to other?
As
Para
allowed-
mag-grow siya, di ba?
Yes po. Meron po sa UHC at sa RA ng PhilHealth, RA 7875 as amended by 9241 and 10606, allowed po kami to invest, but on very specific investment areas. Allowed lang po or identified po sa batas kung saan lang pwede. Other than that, hindi po kami. Yes. Kaya po, some of the money, no, not actually some, malaking tulong, yun pong investment income pagdating sa operations ng PhilHealth. So yes, we do. But again, as identified lang ng batas kung saan.
I guess that's the last of the
I
questions.
will be here until today because I'm flying out na. I can't stay for tomorrow.
It's okay, Doc. Thank you po.
So kung mayroon pa po no, I can still entertain because I need to go to Bohol for the Bohol Medical Society. Medicine Week yata, di ba? Yes. So yun po. Anyways, so thank you. If you still have questions, you can always ask them. Thank you.
Thank you, Doc. Yes, please. Ayun. Thank you po, Doc Ish. Thank you for the opportunity that you've given us. So, ano na po,
May I request, Doc, para po pumunta po dito sa harap po to give the token of appreciation and the certificate of appreciation. Greeting, sign ko lang po, Republic of the Philippines, City Government of Puerto, Princesa, City Health Office, certificate of appreciation is presented to Israel Francis A. Vargas, MD, Senior Vice President of PhilHealth, for sharing his valuable knowledge as a resource speaker during the crafting of PPC HCPN Referral Manual to define Satisfactory survey held at Sunlight Guest Hotel, Puerto Princesa City, Palawan, on 21st of September of the year 2022, signed by Dr. Ricardo B. Panganiban, MD, RNT, the City Health Officer 2.
hopefully po, nasagot or at least na-demystify po yung healthcare provider network and the universal healthcare for everyone. And at least mayroon na po kayong idea. Just like what, nung nag-start po tayo, gusto ko po talaga na before you go and buy in sa healthcare provider network, alam niyo po kung ano po yung mga magiging patakaran at paano po siya tatakbo. At paano po kayo as the primary stakeholders po natin for in caring for your fellow enemies ay paano po makakatulong and paano po yung magiging parte ninyo dito sa healthcare provider network. So, later po sa hapon, gagawin lang po natin yung referral manual. Just simple, we will just siguro run through po yung mga nandyan and yung categorization. The specific instructions will be later na lang din po. So, mamaya hapon po, andito pa rin po si Doc Ish for your questions. If you have any questions, ganun din po yung mga nasa Zoom now. If you have any questions, you can still phone in or you can still ask us. So that habang nandito pa po yung research speaker natin, they can answer directly from the research. Right now, available na po yung food natin. Doon po tayo sa Casa Ricardo sa baba. So, pwede na po tayong mag-lunch. Kailan si Sir na pa. Thank you. Just come back po before siguro 1 p.m. Thank you po.
afternoon. I hope na kayo po ay na-satisfy ng ating pagkain. Gusto mo ba kayo? Hindi mo kami. Okay po, so as we start po, I'm going to present po the status po ng Puerto Princesa pagdating po sa ating universal care. Okay po, so these are the local health systems integration po ng Puerto Princesa CPD. Okay, so sa UHC Administrative Order number 2020, year 029, the UHC representatives speak to the UHC, the LGUs, and help facilitate the development, management, and monitoring of their respective local health systems. Section 19 of the Republic Act RA 1123 of the Universal Healthcare Act and its implementing rules and regulations mandate the UHC, the IRB, and LGUs to endeavor to integrate local health systems to province-wide and citywide health systems. Thus, it is imperative for the DOH to provide support mechanisms that will make integration possible and sustainable. So the DOH representatives, the DMOs are expected to technically assist LGUs in the fulfillment of the said mandate. One of these is provide a tool for the local health system, which is the local health system maturity level. So this is the tool that we are using right now. And in this tool, there are 6 building blocks, no, and 10 characteristics. So sa building blocks ito, it includes the leadership and governance, the financing, the health workforce, the information, the medical products, vaccines and technology, or the MPBT, and the service delivery. So in this building blocks, there are 10 characteristics. So in leadership and governance, we have the unified governance of the local health system, the strategic and investment planning. In the financial is mental management. In the health workforce is the HRH, or management and development. And for information policy, we have the information management system, the epidemiology, and the surveillance system. Sa medical products po, vaccines and technology, you have the procurement and the supply chain management. And the service delivery, you have 3 characteristics, which is the referral system, with what we are doing right now. Then we have the DMA system and the health promotion programs and campaigns. So this is the picture of the local health system, no? Maturity level for the 10 characteristics, which is inside the province-wide and the city-wide health systems. So in this tool, no, there are 3 phases of integration. So first phase is the preparatory work. In this preparatory work, we have the key result areas, 16 key result areas, which is the target na kailangan po nating ma-achieve. And in the phase 2, we have the organization of the province or citywide health systems. And there are 36 key result areas, which is we want also to achieve. And also the phase 3, which is the functionality monitoring, which has 20 areas or the key result areas. So basically, for phase 1 or the preparatory works, basically we need to have the commitment and setting the baseline. Like po sa Puerto Princesa. So dito po natin makikita yung mga KRAs o the key result areas. Hinayat ko na lang po dito yung sa service delivery, which is the referral system. So these are the KRAs na na-achieve po natin in this referral system. So first is the assessment of existing two-way referral system. The groupings, clustering of healthcare providers and facilities, and the identification of potential apex hospitals. So these are already achieved. So makikita po natin dito sa pie chart, no, that we already achieved 94% for the Puerto Princesa, and 6% is ongoing. So basically po, 15 out of 16 KRAs are already achieved. So isa na lang po ang ating kailangan gawin, which is the presence of the pharmacy and therapeutics community that is already, I think, submitted also para sa approval po ito. So, 15 out of 16 KRAs po ang na-achieve dito. The next phase po is the organization phase of the citywide health system, which has 36 KRAs. Basically, ito po na nakalagay yung plan development, organizing the management structures, the special health plan creation, the implementation of policies, plans, manuals, and other support mechanisms, which is ito nga po yung ginagawa po natin ngayon. And establish the network of health facilities and services. So, in Puerto Princesa, so here are the highlights po ng mga achievements po for the key result areas. And on the chart, we can see that 33% is already achieved, while 39% po is ongoing. Ginagawa ko yun ngayon. At 20% yan is not yet started. At kung makikita nyo itong 8% na to, ay ito na po yung hindi na po natin gagawin, which is sold na po ng province-wide health system. So, next. So, these are the other highlights, no? ng achieve KRAs for the organizational level. Yeah. So out of 36 key result areas, 12 of it are already achieved, and 14 is ongoing, while 7 naman po is yung buwang hindi pa nasisimulan. Okay, in the functionality phase or the functionality monitoring phase, this includes the Special Health Fund is managed ng City Health Board or Provincial Health Board. And the citywide health system is already contracted by UHC and PhilHealth. And functionality monitoring and even the improvement in the LGU health scorecard. So here, ito pala po isa nagagawa natin, which is the creation of the permanent TDM systems for the HRH, which is in the health workforce na characteristics on the block, building up. So, ito po yung status po ng bawat IS po ng Mimaropa. So, if you could see the green ones, yan po yung mga na-achieve na. For all the KRAs, we have a total of 72 key result areas. So, makita niyo po dyan, ang Puerto Princesa, may malaking achieve dun sa phase 1, phase 2, and phase 3, which has 28 na achieve na KRAs. Followed by Oriental Mindoro, Palawan, and London. But in the ongoing status ng key result areas na to is merong 37 ang Mindoro, Oriental Mindoro specifically, then Marinduque has 23, London has 22, Puerto Princesa has 20, and Palawan has 20. Ito na po sa preparatory level.
Mag-change siya.
Which Oriental Mindoro is natapos na po yung key result areas nila, and they are now focusing more on
ilang po or ilang yan.
functional phase na monitor tool. And even Puerto Princesa, meron na po tayong 15 at isa na lang po ang kailangan natin gawin. Okay po. So kung napapansin po kanina, wala po service delivery. One, which is the referral system. No? Pero actually ito yung gagawin natin ngayon, hopefully, na
area na specific area.
Which is the presence of technical guidelines for the manual on the referral system, and even sa presence technical guidelines sa customer feedback mechanism. Okay po? So the DOH, no, ang mission natin is to lead the country in the development of productive, resilient, equitable, and people-centered health system for universal healthcare.
Yung guide,
So
yung PPC.
we are hoping that in this activity, is magkaroon tayo ng concrete partnership through the HCPN. Okay, to achieve our vision that Filipinos are among the healthiest people in Southeast Asia by 2022 and Asia by 2040. So this is the status po ng Puerto Princesa City. So yun naman po, marami pong salamat. And as we continue, no, for our activity this morning, this afternoon, we're going to invite Ma'am Annalisa Herrera, no, for our to revisit and revise the HCPN referral mechanism. So, Ma'am Annalisa Herrera is the Population Program Officer of CHO and also the UHC Focal Person of Puerto Princesa.
Maraming salamat, Sir Arthur, King Arthur. Usually po, pag papapakilala ako, magtataka sila kasi isa lang ang hawak ko. Pero they can see me everywhere. Kaya po ang title na nilalagay ko nilang ay for whatever purpose it may serve the defense. Kasi kahit saan. Tatawid ko lang po ito doon sa binanggit ni Sir Arthur. Sa Universal Healthcare, makikita niyo po yung present niya. Yung title ko na present niya, integration ng Puerto Princesa. Pero lumalabas, baka po isipin ng mga private partners, ay, sa city lang naman yan, LGU context. Para bang lumalabas ba na kaya natin in-integrate this? It's for the accomplishment ng local government. Pero this morning, na-present na po sa inyo na mahalaga yung integration. It's not because for the compliance ng universal health care, but because lahat po tayo maapektuhan, especially sa mga implementer, both private and public. Kaya po ito yung integration na sinasabi, it's not only within the city government, but also integrating other partners outside the local government. Kaya po nandito yung mga partners namin. And on the context naman po ng mga partners na na-orient na sa universal healthcare, alam po na familiar na po kayo doon sa partnership na establish natin. Ngayon, sa kalagayan po natin ngayon, ang main objective po natin ay maayos. Paano natin gagawin yung referral mechanism? Considering na Puerto Princesa lahat po ang tumatanggap ng lahat ng referral. Whether nasa ONP siya, dinirefer, or sa lahat ng mga private hospitals natin na minamanage na nasa city proper. Ngayon kasi kahit hindi natin may tatanggi na 60 to 70% na ina-accommodate na pasyente ng mga hospitals natin ay Puerto Princesa. Mabigat, malaki siya yung porsyento. And 10% of that will sa mga private facilities, ang naka-allocate lang for private. Na natatandaan ko yun kay Doktora, nung binanggit niya sa orientation pa lang. Ano yung magiging mode of payment, gaano kabigat, paano po, maraming questions. And ngayon, isa po sa magiging mechanism na ayusin natin hanggang saan, ano yung integration natin, pagdating sa referral.
Sa Q&A lang naman.
Yung unang, yung sa slide na po naman, sa referral.
Okay. Ito na po.
Yeah. Meron pong existing, balikan lang po natin, no? Meron pong nagawa ang ONP, ang Taytay, El Nido at Puerto Princesa na referral manual. It has been written, signed a concept, pero honestly, Doc Odino, it was not properly implemented and coordinated sa bawat isa sa amin. Just be saying, yung process. Hindi siya naging makatotohanan kasi parang ang level, nauna kami, naging compliant kami, di ba, Doc? O nauna kami, yabang. Pero yung totoong buhay, hindi namin na-practice. Yung pinag-usapan. And even to the point na kahit yung kaap, paano niya tatakbo yung pasyente, yung 165, paano niya tatakbo yung pasyente, nakadetalye po yun, but it was just put in paper. Hindi siya nag-manifest sa lahat ng practice namin. Kahit sa mga satellite clinic, to the point, lalo pa na apektuhan yung implementation na nagkaroon po ng pandemic.
At mas naging visible yung fragmented services na binibigay ng bawat isa to the point yung mga pasyente, para na lang hindi magalit yung ospital, pinalalakad, pina-walk in. Kasi pag nirefer ng ganito at dinala siya ng hospital, tinatanggihan. Kasi nga naman, meron talagang may protocol. At ang gagawin na lang, sige ate, kaya mo naman maglakad, diretso ka na lang. Ako, ay,
Bakit siya tinatanggihan?
may mga dahilan po una, Doc, pagka full capacity na sila. Tapos, hindi siya magtutuloy na may category ng assessment. Hindi siya pumasok doon. Tama po ba, Doktora? Na may mga category ng assessment na hindi na agad pumapasok. Tapos, sometimes, nakaka-apekto din po yung attitude ng and coordination. Yan, yung parehong yung nagre-refer at saka yung tumatanggap ng referral. Isa din po yung factor. Kaya siguro matatanong natin on behalf ng OMP, masasagot ni Dr. Sonia yung tanong ni Dr.
Bakit siya na
Umabot sa
hospital supposedly hindi sila tatanggihan?
Sige daw.
Siyempre from the referral system, Doktora, kasi minsan hindi nabibigay yung full na details ng pasyente from the peripheral papunta sa ONP. Tapos yung pag-transfer din nila, minsan, lalo na yung nagkaroon ng COVID, lalo na in that time, talagang full na kami pang ilang pasyente bago sila talaga makapasok sa ONP. Minsan, lumalala na sila doon sa peripheral bago namin ma-accept kasi nga full capacity na. So, yung mga ganong factors.
Kasi ako na-observe ko sa ER pa lang kinokontrol eh. Kasi noong araw 90s, dalawa lang kami nag-duty OB dyan.
Doktora La Peña tsaka ako. Every other day kami, yung buhay ko noon, nag-nursing na ako dahil ayaw ko na yung buhay ko dahil sa isang araw, 7 hanggang, yan ang pinapaanak, pinooperahan. Hindi naman kami bayad doon dahil ONP yun, di ba? Yung charity. May charity kami. Yung on deck kami, pag on deck kami, hindi kami nababayaran doon kasi hindi naman namin yung private patient. Pag private patient lang namin kami nababayaran. Pero nung araw, hindi kami tumatanggi. Kaya walang referral form yan, isa ang dupalo pa siya galing, inooperahan namin sila, pagkailangan sila. Nagulat ako, nitong mga, lalo na nitong panahon nga ng pandemic, di ko alam kung wala talaga ng paglalagyan. Paano ba natin siya masusolusyonan? Kasi government, siya dapat ma-accommodate, di ba? Kung kulang ang OB, kami nga, dalawa lang kami nun nagagawa namin. How much more sila ngayon? Piko sila.
Yun ang main factor daw kung bakit nandito tayo. Kasi katulad niyan, even inter-facility referral, kahit sa simpleng service like wala ang OMP, tapos i-refer mo sa isang like co-op or sa Adventist, walang MRI or walang, may limitations, paano na yung referral natin doon? Kasi ang bottom line, yung operational natin at yung operational cost mag-accumulate. At to the point, dati nga sabi niyo Doc, mas marami kayong pro bono kaysa sa actual na nare-receive yung payment. Pero sa ngayon po kasi, yun yung aayusin natin, yung katotohanan na dapat maayos siya. Yung una, hindi po madadenay ng service yung pasyente o yung kliyente natin. Pangalawa, hindi rin makakompromise yung operation ng bawat hospital. Kasi bawat isa po sa atin, meron tayong pledge of commitment. At the same time, yung sa doktor, meron po yung tinatawag, di ba? Yung oath na binabanggit. Pero mas madalas, nakikita natin na yung reality, hindi natin masyado nakikita kung paano natin ina-apply yung mga pinunit natin. At ito po yung isang gagawin natin ngayon. Gaya ko na binanggit ko kanina, Taytay Alnido, Puerto Princesa, and OMP has already established the referral manual, the manual itself. But the actual operation was not applied. And hindi rin yun po nag-involve
Iba yung
wala po doon ang representation ng co-op, wala po doon ang representation ng Adventist, at wala din po representation
naman kasi sa atin yung
HCU.
Yun na
Kaya lang,
bata.
nakita po natin na nung binanggit po kanina sa Universal Health
Siya
Care,
nakikinig sa
kailangan natin
teacher.
magbuo.
Oo, yan.
At yun yung isang step natin gagawin.
Kanya
Yung
hinihingi
special
yung mga
health fund,
papel.
binanggit kanina yung mga financing mechanism ng PhilHealth, yun na po yung pinaka magiging epekto ng paano tayo nagpa-partner. At yung partnership natin has to be written at kailangan clearly defined kung paano
Pataray
natin
po ba tayo masyado
expect
sa
na
kanila?
deliverables ng bawat isa. Yes po, Dr. Hindi po.
Or ano na.
Kasi mga napapansin ko, baka para ma-decongest natin yung OAP.
Mali kasi siya
Ang
eh.
dami na kasi magagandang hospital like Aborlan, Nara, Brooks. Baka pwedeng lagyan nyo ng bawat specialist yung mga department. Para, kunyari si Aborlan, hindi na magre-refer dito kay Open. Diba? Kasi meron ang luwag ng hospital nila eh. Kaya lang, baka kulang din yung specialist. Baka pwedeng silipin nyo muna yung mga ganyan. In such a way na parang maging sufficient ang bawat isang malalaking hospital kasi nasasayang sila eh. Like yung Taytay, wala kayong OB doon. Kung meron man, di nag-o-opera. So, mga ganun ba? Baka pwedeng lagyan nyo muna sila ng tamang tao para hindi tayo magkakaproblema sa ganito.
Sige, Doc. Acknowledge ko yan. Una-una po, Doc, clarify ko na ako po ay city government employee. Opo, hindi. Second, actually, that's the reason why hindi po nagkakaroon ng interest ang aming local chief executive, si Mayor, na mag-establish ng sariling hospital. Kasi una-una existing lahat ang hospitals natin dito sa Puerto. Pangalawa, ang focus ko talaga is preventive and promoting, which is the population-based services. And then, sa kanilang i-refer. Kumbaga, talagang one way of decongesting all the hospitals by the primary care provider network on the population-based services. Pero yung binanggit niyo po, Doc, we'll go into that. Yung detalye po na nakikita niyo yung gaps, ilalagay po natin yan dyan. Pero makapapansin niyo po, bigyan ko lang po kayo ng existing facilities na city government ngayon. Yun lang muna po yan, sa una. Yung existing facilities, meron po kami 58 barangay health stations. Barangay health stations only provide the basic or essential services like the immunization, prenatal and postnatal care, reproductive and family planning services. Yun po yung lowest level ng delivery of health services. The barangay health station. Ano po yung susunod na category namin? Meron po kami City Health Main Health Center. Yun po yung ngayon yung current. Pero yun po ay ginagawa na rin po kami ng panibagong building which provide laboratory. Meron na po siyang ancillary services, may medical ancillary services, pharmacy, and other extended services para sa public health. Meron din po kami existing na operational na mga satellite clinics. Ang satellite clinics po ng city government na minamanage ay Princesa, San Rafael, Macarascas, Salvacion, Buena Vista, Laksan, Nangingisda, Pinagawa, at Los Linda. Kaya siya na po siya. Out of this line, apat po yung enhance. Yung San Rafael, Macarascas, yung pong Los Linda, at saka po yung Laksan. Current operational status, Los Linda and San Rafael, ang operation and at functional level. Nag-a-accept po sila ng mga normal, spontaneous birth delivery assistance. Yun po yun lang ang capacity namin. Ang aming pong ancillary services like the diagnostic care ay pinaprovide ng aming mga mobile medical technologies at ng aming mobile X-ray laboratory. Services, meron po tayong dinadala sa mga satellite clinic per schedule. As of now, yun po yung limitations and current status ng Puerto Princesa City government managed and owned facilities. Kaya wala po talaga kaming hospital at never po kami magkakaroon ng hospital. As of this plan, wala po siya. Kaya po, With that, mapapansin niyo, binanggit ni Doktora, tama po kayo. Kasi, considering na lahat ng facility and referral facility ay nasa Puerto Princesa, therefore, one way to decongest all those facilities, regardless of management, dapat capacitated sila for the triage. Kasi dapat ang capacity natin, yung mag-spill sa kanila or those specialists na wala na sila, saka pala nga-abot sa atin. Which is yun din po yung context ng universal hospital. Hindi na sila aabot sa atin kung sila na-address at their immediate care dun sa kanilang primary care. Kaya yun pong gusto nyo mangyari na dapat sila din makapacity, which is under the provincial government of Palawan, na sila po yun ang limitations na Manila. Sila po yung mag-a-address ng nakikita natin, which ang input po na ma-identify po natin vaccine ay mapabalik yun sa kanila. Kaya po, ang mangyayari ngayon, nabanggit ko na po namin yung facilities. Meron lang po kaming transport vehicle. Currently siya, PTV lang po siya. Patient transport vehicle. Isa pa lang po yung aming matatawag na officially na ambulance. Which is run na ngayon po ay na-under pa siya ng CDRRMO. Kasi yung pong patient transport ambulance namin, kung mapapansin, just the transport ambulance with the basic oxygen and the basic emergency na Kaya po wala kaming ina-apply na ambulance kasi wala pa rin po kami capacity to use it. Yun po yung honest to goodness na current reality ng city government capacity for the health. Ngayon, titingnan po ninyo next kuya. Ito po yung landscape ng Puerto Princesa pagdating sa mga health facilities and current capacity. Ito, next. Yung manual, which was, I understand, isend sa inyo para for review and input. Pero, alam ko po na napaka-detalyado nito. I would suggest, kasi ito pong manual na to, majority of which ay galing pinal-out dun sa ginawa ng body ng Taytay Almeida with the assistance ng provincial UHC ng Maropa. Nagawa po siya. And most of it ay ginamit din dito sa bagong referral manual. Ano po ang mababago dito? Ito po yung integration ng mga hospitals na privately owned or managed. And yung existing capacity ng OMP. Kasi yung dati po, na ang nagamit po namin dyan ay yung 150 bed capacity pa ng OMP. Without, and minus pa po yung mga specialist yung OMP. Kasi kailangan po natin ma-identify yun dahil sa referral, ano po yung limitations ng gagawin na hanggang saan lang ang pwedeng ibigay namin referral sa OMP, hanggang saan lang ang kaya namin ibigay ni referral hanggang sa mga private hospital. Since ito pong manual na to, na masyadong madetalye at alam ko po na share na rin sa inyo, pwede niyo po siyang as expected po na na-review niya in a way na na-run through nyo, which is majority naman po yan ay base sa mga mandates. Pero yung application po niyan ay wala dyan. Ano po, saan magagaling ang actual application? Sa atin po. Bakit na mahalaga na makita po namin, ma-identify namin kung ano po yung magiging expectation niya sa LGU. At the same time, ano po yung magiging expectation din ng LGU sa lahat ng magiging partner po. Kasi kapag sa integration, kahit na alam ko po na may kanya-kanya kayong internal operation and mechanisms para sa mga referred patients. Definitely, pag nagkaroon po tayo ng integration, maapektuhan po yung inyong internal operation. Yung inyong operation from the acceptance ng pasyente hanggang sa claims ng pasyente and refer back of the patient. Ganun po kahalaga na kailangan namin po yung input. Hindi po namin susuluhin na ito yung manual, ito yung susundin natin. Sa inyo po manggagaling, hihingi po namin yung lahat ng nakikita ninyo na kailangan mailagay dito. At ito po, yung manual na to ay magiging atin. in a way na ito rin po yung magiging Bible natin. O, ito yung na-refer mo, hindi mo nasunod, ano yung magiging implications nito? Kasi lahat po ito dadaan sa local health board at magre-reflective po ito dun sa financial side. Pati yung claims naka-indicate dito. Kaya paano po natin gagawin yun? Yun po ang template po yan ng identification ng gaps.
Okay po.
Gaya po ng binanggit ko, no? Halos majority ng content niyan ay it's more of the narrative. Pero lagyan po natin ng kwenta, yung kwento nun. Kasi kwento lang po siya. Ito yung ano namin, facilities namin, ito yung kakayahan namin. Anong meron dyan? Paano kami papasok dyan? Ito po yung...
Ano po ba yung gaps?
At kuya.
Saan po yun?
Yung ginawa ni Ma'am Joy. Ma'am Joy. Yung binanggit po niyo, Doktora, kanina is one of the identified gaps. Major gaps ng ating current health system. Menti ba yung ginagawa natin? Menti.
Ay, hindi po.
Opo. Hingin po namin yung input nyo dun sa, meron po tayong pin-repair na identification ng gap. Kasi doon po tayo mag-aangkla kung ano yung action steps natin para ma-include po natin doon sa referral manual. Kasi kung kailangan po natin totally i-revise siya or kailangan lang natin baguhin yung operation natin, yung mechanism itself, kailangan po siya mapag-agrihan. Kasi kung ano po yung makikita natin dito, ano yung mapag-aagrihan natin, may lalagay natin sa manual, will be submitted din sa PhilHealth, sa mga concerned agencies, which will be the reference ng ating course of actions.
Fairness, malinaw yung internet.
Ito po.
Ayan. Meron.
Sa Puerto Princesa.
Ito po yung may bibigay din po sa inyong printed forms. Yan.
Laging nag-invite nyo to. Ang
Pwede
national.
pong pa-identify lang ako ng ito po yung nakalagay sa form. Pa-identify yung katulad ng binanggit mo, Doktora, current referral practices. Ano yung observation nyo? Magiging hospital-based po tayo. Tapos iti-check po natin yung common issues. And then from the common issues, baka po meron din kayong common suggestions and recommendations. Kasi baka pare-pareho yung inaani natin. Kaya po hingin po namin yung inyong observation ng existing referral practices, yung current. Yung strengths and gaps and challenges. And then padugtong na rin po ano yung recommended action. Kung pwede po dyan, sa form na may idudugtong. Yan po yung ihingi namin sa inyo ngayon, katulad na binanggit na na-identify nyo na daw. Sina Doktora kanina, ano ba yung limitations? Sa call, halimbawa sa communication itself. Sa coordination, ano yung nagiging method?
Dapat alam din yung ilan ang capacity nila.
Yes, ma'am.
Sandaan.
Yes po, hanggang 150
So yung
lang.
magre-refer, nalaman nila na
Yes,
naka
po.
101 na sila pa.
Apo. May limitations, may ceiling.
May ceiling siya.
Okay. Sige po, kung ilalagay niyo po, wala pa tayong, one of the existing referral ngayon na nakita niyo po ay, wala po tayong na-set na ceiling per hospital. O kailangan niyo ba mag-set ng ceiling for the hospital ng i-refer? At coming from whom? Ililimit na po ba yun sa Puerto Princesa or sa lahat?
Kasi ang katulad ng abort natin na malalaking hospital yan. At may mga doctors, di ba kita sa may mga specialist din sila. Ang tanong, for example, sa OB, bakit sila magre-refer dito sa ONP? Pero pa, ilan din ang OB nila? Yun yung mga questions. Sasagutin ko yung...
Sige, Doktor.
Doctor ng to. Doktor ng to.
OB ng ONP. Sasagutin ko yung tanong ni Doktora. Ang nakikita po kasi namin doon, may mga OB doon, may mga doktor na nag-duty.
Ang problema, hindi sila magkatandem. Kung halimbawa ang nag-duty doon ay isang OB, hindi siya OB siya. Pero kung magsi-CS siya or kung ano man na gynae na gagawin issues, hindi niya magagawa kasi wala siyang katandem na anesthesiologist. O kaya kung may intra-op referral man siya, hindi niya rin katandem ang surgeon na supposed to be na duty. Nag-duty sila pero pa-isa-isa. So, i-refer din nila sa amin lahat.
Yun daw. Yun po yung isa sa gap na nakita po natin meron na agad nakita si Dr. Lafor na ano yung issue behind. Sige daw.
Ang dati ko nang nakita yung cabinet na yan way back 10 years ago. Kinausap ko yung mayor ng Taytay, Northern Palawan Medical Center. Nag-medical mission kami doon. So nakita ko, kunyari 10 days ang OB, 10 days si Pedja, last 10 days naman si Anes. Sinabi ko dun sa mayor, nakalimutan ko na kung sino yung mayor. Sir, sabi ko, mas magandang maging productive kayo ng 10 days at inutil kayo ng 20 days kaysa inutil kayo ng 30 days. Bakit hindi mo pagsamasamahin yung isang team para maging productive kayo ng 10 days? Kasi ang ginagawa niya, para lang malagyan ng doktor, at para masabing may doktor ang ospital, naglalagay siya ng 10 days, 10 days, 10 days, na hindi sila team. Paulit-ulit itong problem na to, parang naman yung mga hindi nakikinig din.
Baka po si Mayor Toto pa yun. Toto Rodriguez. Opo, 10 years ago si Mayor Toto Rodriguez pa. And yun pong management ng Northern Palawan Hospital ngayon ay ang NPPH po ay under na ng provincial government. Ano na siya, nasa under na po ng administration ng governor's office ng provincial government. Pero hindi natin siya i-deny na nakaka-apekto po siya kasi nag-a-add siya ng burden sa end referral facility. Tama po yung observation nyo. And honest to goodness, Doktora, tama din yung hinati-hati kasi sa hindi po non-medical, hindi nila nakikita yun. Sa kanila kasi pare-pareho yung doktor. Basta doktor ka. Regardless of your specialization and yung cover na meron pala kayo, dapat bubuuin team. At hindi po yun siguro malina doon sa mayor.
Ay, sorry sir, nag-double set up ako. May meeting din dito sa kabila.
Meron ka,
Sa UHC.
meron kaming doktor.
Apo, politiko.
Meron ng function.
Politiko.
Ano yan?
perspective po
Puerto
kasi
Princesa
na
Referral
meron
Manual.
siyang representation ng doktor. Yung hindi na siya ghost facility. Meron naman kaming doktor, pero yun nakalimutan nila, may ganun talaga silang dapat na i-provide. Ngayon, doktora, yun po yung isa sa gusto ko pong makita natin na ang problema ba ay kailangan natin localized lang yung health systems referral natin? Lumalabas
Parang di kaya.
pa lang na kailangan natin, which is not ang
Oo, nahirapan din kami.
taga-PHO.
Kasi busy sa Pinas Lakas.
Definitely magpi-feedback.
Siyempre yung Pinas Lakas may gina-encode din yun everyday.
Sa observations ng gaps and recommendations, ito consolidated po namin. Makikita po natin yung
Tapos I think kasabay pa ang GDA profiling.
Your rights and
Sabay-sabay.
where our rights starts. Kasi meron pong limitations ng city government sa pag-address. Pero binabato po
sobrang
namin
talaga
sa kanila
sila, field
na
sila araw-araw
yung
halos.
ginagawa ninyo ay nakaka-affect
Mga
sa
primary
amin.
care facility.
Opo, yun nga. Actually, bigyan ko pa kayo ng concrete example. Yung lahat ng report ng mortality and morbidity, it's the place of occurrence. Kahit na hindi siya nagre-reflect sa place of origin, nirefer ng taga-South, namatay sa Puerto, it's Puerto Princesa. Yun po yung isang malaking burden ng Puerto. Not only the services itself, but yung outcome. Maraming namatay sa inyo sa dengue, pala iba-ibang probinsya, iba-ibang munisipyo, na nag-seek ng last touch dito sa Puerto. Dito, yung reporting of case, nandito po sa Puerto. Kaya po, it's going beyond dun sa burden ng actual service provision, but also dun sa actual number na nagko-contribute, dun sa, kasi nagre-reflection, ano ginagawa ng Puerto? Kasi namatay din sa inyo. Ay parang wala pa kayong ginawa, hindi naman nila masabi. Kahit meron kang report na this case came from and referred by the Northern Palawan Hospital, hindi naman yun, hindi nila yan pina-accept. Kasi nga po, base sa WHO and UHC guidelines, it's the place of occurrence. Last touch. Kaya po yun yung isa na kailangan, bakit natin sila tutulungan? Hindi natin sila tutulungan dahil gusto natin sila i-consulting. Tutulungan natin sila kasi may epekto sila sa atin. At matutulungan natin sila in the first place kapag paalam natin, these are the gaps and observations na nakita namin. It's us ang nagtatanggap ng inyong mga kakulangan, which is reflected naman po yun. At kailangan po ma-identify ngayon, at mahalaga po yun kasi baka sabi out of the LG context, alam namin po yun. Pero mas importante makita nila how the private facilities and referral facilities like the OMB feel dun sa nangyayari ngayon sa atin. Kasi at the end of the day, papasok na naman po ulit tayo. Para tayo maghahatian ng bayad niyan. Nanggaling sa inyo, dinala nyo sa amin dito sa amin na lumala. Diba? Yun po kasi din. May epekto talaga, kaya nga po sabi ko sa inyo, yung internal concept ng inyong operation has to be reflected sa amin. Una, para alam po namin hanggang saan kami. At alam din namin kung paano kami makikiusap sa inyo at hanggang saan ang pakikiusap namin. At the level naman po ng LGU, alam din namin kung paano namin sila ibabalik hanggang sa mga facilities namin na nagdadala sa inyo. Kasi po, gaya po ng orientation is meron tayong primary care, yung ating point of care service, which is basically sa mga satellite clinic, from BHS to satellite clinic, and then satellite clinic, hanggang saan kami sa hospital. At kaninong hospital. Sabi mo nga, Doc, naalala ko nun, may limit. Tinanong mo din po yun, may limit ba? Baka naman na po paborito mo lang, co-op. O di po kay co-op mo na-refer. Paano naman yung ibang hospital? O po yung distribution. Yun po ang hihingi ko sa inyo, Doc. Yung actual observation yun ng current reality natin para mag-isama po natin doon sa development ng referral mechanism po natin. At kung gusto niyo pong maglagay dyan, nung mas masama, mag-reflect dyan yung inyong internal operations ng acceptance ng mga referred patients, much better. Mas maganda po. Kasi para po makita din namin at the LGU, ito lang hanggang dito lang sila. Is there a way na pwede ba siyang ma-iron out at ma-extend? Kaya po yung mga forms na binigay ko sa inyo, pakikisuyo ko po, we'll give you 30 minutes po para i-process siya, and then we'll collect it, and then ipapa-impose po namin siya sa amin para makita rin po natin yung commonalities. Kaya po, we'll give you time para po ma-fill up yung ating mga forms. So, yes, Doc. Oh.
I think it is needed, no, kailangan ma-identify natin yung mga primary health centers na talagang primary health centers lang sila, and then those na magiging referral hospital. So halimbawa, kung ang ano nga yun yung Doktora Taytay? Kung ang Taytay is referral hospital, then it should act like a referral hospital, di ba? Kasi dapat as a tertiary care center or as a secondary health care center na may referral hospital, dapat capable siya essentially, meaning to say masasabi niya na kaya namin ito gawin doon. Kasi kung hindi niya kaya, huwag siya mag-identify sa kanyang sarili na referring hospital. Magiging primary care hospital lang talaga siya para ma-avoid yung confusion. Kasi kung sabihin niya na tapos pagdating sa kanya, i-refer niya rin pala sa Puerto, edi ang baka na hindi lang yun, yung bayaran doon, mag-aaway ng lahat. Diba? Lahat naman, bottom line ito, magiging bayaran hatian.
Diba? So I think it is mandatory na i-identify at sila mismo yung mag-identify sa sarili nila. Kami, referral hospital lang. Oh, lahat ng primary care na pasyente, i-refer namin sa inyo balik. Oh, tapos yung lahat basta gano'n. So if pag inako nila yon na sila ay referral center, then they should be able to give that services na nire-require na or expected sa kanila.
Noted po yun. Ibig sabihin, one of, katulad po na sa amin, naka-reflect kung ano yung mga facilities namin at binanggit ko po yung mga limitations, yun po yung hanggang doon na kami. Yun po yung isang indication. And then at the end, binanggit naman po ninyo doon na mahalaga na manggaling din sa hospital, ano ang meron sila. Which is parang kung magkakaroon ng inventory of services and capacity na mga hospitals and facilities. Tama po. Para at least alam natin, ay, itong hospital na to, hindi siya makakapag-provide ng comprehensive services kasi wala pala siyang MRI, wala siyang CT scan. Parang lalabas ko doon, ang pasyente lalabas naman siya. Tama po ba yun daw? Sige po. Noted po dyan daw. Siguro dito nandiyan yung specialist, yung team. Oo. Kung gusto niyo naman po mas maging si Dr. Paul, sinusulat din na, mukhang marami na si Dr. na tawag dyan. Dok, hugot ba yan, Dok?
Understanding ko, Ma'am Ann, ang city would have its own healthcare provider network separate from the provincial. Tama?
Tama po.
So ang mangyayari po niyan, based dun sa primary health facility, i-refer sa secondary or tertiary.
Yes po.
Now, kung wala pong tertiary or i-refer sa APEX.
Opo, sa APEX Hospital.
Ganun po. Lahat tayo dito sa Puerto Princesa are mostly secondary hospitals po. Kung wala tayong apex tertiary, tayo mismo, whoever from your primary facility, i-refer nyo na sa ONP or sa co-op or sa Adventist. Kung hindi po kaya doon, definitely ang magre-refer po nun, hindi i-refer or doon kung kanino naka-apex hospital. Tama ba?
Tama daw. Tama po daw. Sige, Dr.
Just to give you an overview po of the healthcare provider network. Ganito po kasi siya. Dalawa po, sa island po ng Palawan, meron pong dalawang provider network. That would be yung gagawin po ng provincial government and yung sa city government of Puerto Princesa and yung sa provincial government of Palawan. Essentially, yung sa provincial government of Palawan, they can at least siguro maghati pa. Yung healthcare provider network nila, iba sa north, iba sa south. Pwede po nila yung gawin. Parang sub-provincial healthcare provider network. Kaya po nila yung gawin. Pero po sa atin, ngayon po kasi, ang scope natin would be City of Puerto Princesa. Pero I understand na syempre po, dahil it affects all of us, yung mga operations po outside Puerto Princesa also affects us. And it's quite understandable naman po. Pero yun po. So kunwari po, ang magiging buod po nung sa Puerto Princesa network would be the primary care facilities which are composed of the primary care facilities owned by the city government, which are yung satellite clinics po na tinatawag, as well as yung medical outpatient clinics po ng mga doctors na pwedeng gusto mag-apply as primary care provider. Bali yun po yung magiging primary care provider network. And then, after that, kung di po ma-manage ng primary care providers natin, doon po papasok yung primary care provider. At the level of the primary care provider, dapat po alam niya na kung kanino niya i-refer. Is it sa ONP, is it sa co-op, is it sa Adventist, is it sa whatever. Tapos, kung alam po kasi natin, kung alam po namin sa level ng primary care provider na ay hindi po ito makakaya ng lahat ng ospital, kami na po diretso na i-refer sila sa isang hospital. Ang iniiwasan po natin dito ay mag-shopping po yung pasyente at magtalon-talon. Parang kung kailangan po ng pasyente ng isang procedure na hindi po naman na magagawa na mapro-provide po ng either of the 4 hospitals, we direct them to the Apex Hospital diretso. Para po, yun po, para hindi na rin po mag-congest yung mga hospitals natin. And hindi na rin po mag-incur ng additional pa na time, na mga ganun po. Marami kasi siyang effect. Currently po, so naintindihan naman po natin yan. Tapos po, yung sa Apex naman po, ang Apex po kasi natin ngayon, ang binigay po ng Department of Health is RITN, Philippine Heart Center, Lung, and MTTI. So basically, pagdating po sa primary care, kunwari po may patient nga, kailangan niya ng specialist level procedure na sa pang MTTA levels na siya, so i-refer namin siya directly. Mga ganun po. So, yun po yung provider. Yun po. Yes.
Healthcare system.
Yes. Basically po.
I came across an invitation from Asian Health Office na pagkaganito din.
Opo. That is possible, and that is really possible po, especially in our setting na hiwalay po talaga sila ng network. Ang aanin lang po natin is kung ano po yung mapagkakasunduan natin dito, we will really talaga pong magbibigay kami ng feedback sa Provincial Health Office kasi we don't want one is mag-conflict and two, pag-duplicate pa. Kung ano po yung, at least para kung meron na rin po silang idea kung ano po yung napag-usapan natin dito. Kasi yun po yung magiging natin is, kung ano po, parang nauuna lang po kami talaga sa city with the provincial, pero essentially, i-invite din po kayo ng provincial, may kikinito din po. Kasi in effect, gagawa rin po nila sila ng HCPN na separate from city government. Yes po sir.
On the way I see it kasi parang tayo lang dito sa city ang may level 2. Ang province hospitals walang level 2.
Yes po, level 1 lang po yung education ng city.
So basically dito lahat nila ibabato pa din sa atin.
Yes. Ganun po talaga. Basically, kung makikita po, in the future makikita niyo po, dapat sa mga tanong po si ma'am, yun po yung mangyayari, yung parang magkakaroon po sa referral network, siguro yung level 1 po nila like FPPH and SPPH, and then yung level 2 would be Puerto, Princesa. That is possible po. Magiging problem nga lang din po ay yung hatian naman kung paano yung magiging mechanism. So, kailangan lang po uniform yung, kasi po uniform yung magiging, kapag uusapan natin uniform po with the province para po wala ng conflict at para tuloy-tuloy na lang din po. Para wala na po issue. Yes po. So,
allowed sila sa mga emergencies. Like yung rin po ba kahit level 1, naggagawa sila doon ng mga major operations. Pero pag elective, yun na yung nagkaka-problem. Pero pag emergency, kayang gawin ng level 1, yung mga emergency cases.
Apo. Nakaano naman po yung doc sa referral mechanism. Pag emergency po ang cases, patients can go directly towards level 1 and level 2. Kahit hindi na po sila dumaan sa primary care as long as it's emergency or as long as kailangan nila magpa-check up. Pero walang, katulad po na sinabi ni Doc Pargas kanina, if wala po sila sa lugar ng primary care provider nila, tapos kailangan nila magpa-check up, hindi po kailangan na lumipad pa sila. Pwede na po, yun po yung mga exceptions po for those kinds of referrals po. Yes po.
A question, what happens to the outpatient department of each hospital?
Yun po yung yun po yung dapat rin talaga nating pag-usapan. Kasi pwede pong, the way I see it, kasi po talaga yung healthcare provider network would set the standards or would set the rules. Kung gusto niyo pong tayo po yung mag-uusap, pwede po na, yun nga po katulad po ng sinasabi kanina, pwede po na primary care, tapos kailangan po nila ng specialist consult, that's when we refer them. Pero kailangan po may referral pa rin. Pero kasi kung dapat po yung OPD ng mga hospitals will be special and subspecialty na po. And hindi na po nag-offer ng primary care. And yun po, tinanong ko nga kanina, paano po yun? Paano yung bayaran? Wala pa daw po silang guidelines regarding kung paano yung magiging bayaran pag ang referral mo ay outpatient na po na medical specialty. So that's also on the work. Yes, but
Kasi ang laki ng pera niyo, 150 million ba?
Opo.
Pag nalalagyan niyo yung bawat isang malalaking hospital, ikumpleto niyo yung mga equipment. Kasi it will follow magiging level po din yan. Pagka enough yung specialist mo, equipments mo, laboratory. I-upgrade niyo rin siya. Pakalaki ng pera niyo para isasayang nilang sa mga ganito. Gawin niyo lang equip yung bawat isang lugar. Konti ang magiging problem natin.
Opo. Doktora, pwede po yan. Ang special health fund po naman, pwede siya for capital outlay, pwede siya for remuneration of their personnel. So kung katulad ko kanina, actually kung kanina yung nakikita kong sagot po doon, pag sa UHC po ng Palawan, pag magkakaroon po sila ng additional funds, pwede po nilang gamitin yun pang po na pwede na to the point na pwede na mag-tandem yung specialists nila. Kasi po, kung kami 150, ang Palawan ko nasa 800,000 ng population. So, times 500 po yun. So, yun po yung pwede nilang makuha sa primary care. So, pwede po sila, pero depende pa rin po yun sa kanila. Depende pa rin po yun sa provincial government on how they would, gagamitin po yung pera na makukuha nila from UHC. Yun po, kaya po ganito, yun nga po, kaya rin po namin sila in-invite talaga para po nandito sila. And pagdating po, kasi pag nag-document na po kami, bibigyan din po namin sila ng, ng kopya. Kasi po, yun po, nauuna lang po kami with them, pero eventually, gagawin rin po kasi nila talaga dito itong healthcare provider network.
Dahil mo na binanggit mo ako raw, kung gusto nyo mangyari na magamit equip, it will happen. Kaya po kung nakita nyo na gaps na kaya hindi ma-deliver itong services na to kasi wala kami capacity ng equipment or kulang ang tao namin. Like, alam po, challenge po yan sa co-op, kulang ang kanilang human resources. The special health fund can be used for that. Pwede pong pambili ng capital outlay, which means equipment, and then pambayad ng tao. Ang kailangan po namin, identify sino may kailangan nun para ma-equip siya. At yun po ang isasama natin magiging usapin natin sa distribution ng special health fund. Kaya po, eventually, nabanggit po sa akin ni Dr. kanina na meron pong nire-request na representation ng mga hospitals sa membership ng local health board na kara-reconstitute lang po. Ang member lang po kasi na ad hoc member doon ay ang ONP. The rest of the hospitals ay wala pong representation. From here, as a secretary po ng local health board, hihingi ko po yung inyong, ngayon parang hihingi ko na po yung inyong suggestion kung ito po ba ay magiging per hospital, ang magiging representation sa local health board, or isa lang magiging one hospital command lang. Kasi yun po yung direction nun eh. Yung mag-represent, pag-uusapan yung management and distribution, utilization, kasama po yun. Kasi kung manggagaling po sa inyo yung need that there's a need for us to include as a regular member yung mga hospital representatives, ilalabit din po namin yan sa local hospital.
Kailangan silang i-member yung outside.
Within
hospitals kasi outside.
Okay, individual hospitals po may kanya-kanyang representation.
Ang lalaki ng hospitals nila. Parang ang laki ng hospital pero hindi nag-function ng maximum.
Sige po.
Kasi nga nire-refer lang nila. Kasi ang galing reason ay wala kaming anes. So, nare-refer ko na talaga kasi wala akong anes.
Noted, Doc.
Pero lalagyan mo talaga yan at lalagyan mo ng duty yan. Siyempre, ma-identify mo na bakit wala kayong anesthesiologist and
Meron naman.
number ng specialists.
Again, noted po yan, Doc. I'll take on the suggestion na each hospital has to be represented. Meron siyang representation sa local hospital. Sige po, yun yung nabanggit sa akin kanina.
Kasi kawawa din ang ONP, tambakan talaga.
Totoo po. And going back po doon, tama po kayo, Dr. And going back po doon sa nakita po rin yung gaps, may dito po sa atin, kasi sa referral, binanggit po ni Dr. kanina na we have to assess. Masasama po sa assessment yung capacity ng human resources as well as the capacity on the equipment side. Dun sa technical side. Dr.
Siguro sa amin din po, we'll set na lang din po before the province makes their move po sa healthcare provider network, na-creation din po nila. Is we will make sure na we will talk to them para po ma-raise na po yung question na to beforehand, para magawa na po nila ng solution beforehand.
Pwede mag-comment. Yung problema na yan sa province, especially yung mga ilan yan hospital, 17, 16. 16 hospitals yata yung established. Kompleto siya sa kompleto siya sa equipments. I-equip siya. Definitely. Siguro ang ilalabi na lang namin sa Palawan Medical Society is kung meron yung willing na mag-duty dun sa may mga areas kasi na kailangan din yung mag-duty. Although mahirap, sabihin natin mahirap, pero probably merong mechanism na pwede siyang gawin. No? Kasi equipment-wise, ipapag ng facilities. Tapos isa pa, parang yung itong mga hospitals na to, meron silang primary health care unit. Hindi lang dun sa RHU. Meron din silang i-require din sila na magkaroon. Yung binabanggit ng Dokodi kasi yung OPD, paano yung OPD? It's part pa rin yun ng primary health care unit. Although sabi nga doon, ito dali sa kanila kasi kung nandun na, pwede na i-refer ka sa kanila kagad sa secondary level. Pero ang alam ko, meron unit talaga para sa primary health. So, para mas madali. Basically, yung RHUs, sila yung anong tawag dyan? Gatekeeper ng mga patients. Tapos, yung plans na gagawin for the province ay, ewan ko, nandito sila kanina pero nawala na. Pero, na lang namin, ipasok na lang sa Provincial Health Board. Total, nandun naman si Dr. Karen, nagaling din. Siguro lalabas din yan. Lalabas din yung problem niya. So, mapag-uusapan din yan. Siguro yung ayusin natin ngayon ay within the city. Tapos, i-park na lang natin kung whatever yung mangyayari sa with the province. I-park na lang natin siya. Kasi, syempre, malaking katanungan yan. Wala naman makakasagot ng tanong. So, ngayon, willing ba na, sabihin natin, kanina nag-uusap na yung Adventist at saka yung ONP kung anong gagawin nila for the yung coming na mga medical students siguro. Pero, willing ba na yung healthcare provider network kasi kailangan nakalink ang bawat isa sa atin. Bawat hospitals, bawat clinics, nakalink siya sa bawat isa. Yun lang yung gusto dito, especially within the city. Kasi yan yung makita dun sa kaya casting ng PPC Healthcare Provider Network. So yun po, para at least alam natin kung sino yung ganito na kailangan ng ganitong service, sa kanya ipapasa yan kung kasama siya dun sa network. No, yun yung nakikita ko na kailangan na gawin natin dito. Yung mga lack of specialists na sinasabi dyan, saan yun sa province? Pero within
within the city siguro nandiyan na lahat, no? Tama ba? No? So siguro pwede natin alisin yung gap na yan kung sa city. So yung pag-anuhan natin dyan, yung policies and guidelines, kung paano siya bubuunin. No, within the network. Tama ba? Tama ba ako, Dr. Itong ano?
Yes po.
Limit na lang po muna natin yung scope na lang siguro po within Puerto, Princesa. Oo, within the city. Yung the province will take it as another step. Opo. Opo. Opo, na we understand po na talaga pong bulk ng congestion po ng hospitals dito is because of the referrals pa po ng galing po sa labas.
Hindi lang sila nababayaran ng tama, kaya nagre-resign. Pero kung titignan din ng government na hindi ko doctor yan, nakakabuso pa sila. Hindi ko nababayaran sila. So, ilang doctors ang nagre-resign sa mga private kasi hindi nila nare-receive yung salary. Pero kung titignan nyo din yan, maliliit lang yung nabagal pero mako-correct mo somewhere yung mga problem.
Ayun po.
Doc, inform lang po natin ang lahat po ng participants. No? Nakahook po si Doc Bob Marcene from CHD Mimaropa, DOH po. At nag-comment po siya kanina sa mga pinag-uusapan po yung regarding sa province. Ang sabi po niya, I agree po, once Palawan province has access to their SHF, kasi po sila rin po ay magbubuo ng province-wide health system, they can use it for equipping and upgrading their hospitals po. Kasama na rin po yung manpower. Yan po.
So ayun po, basically, tapos na po ba tayo sa ating pong mga output? Sa ating pong output. Medyo mainit-init na usapan, pero wala pong tamang oras na pag-usapan yung hindi ngayon kasi nga po patungo na tayo sa UHC. Kung hindi po natin pag-uusapan ngayon, kailan pa kaya? So, I agree po sa mga comments po ninyo, and rest assured kami po in the part of the city government will be documenting everything so that we can give it to the provincial government so that they can take action po. Pwedeng magano, no? Kasi nandiyan na yung referral mechanism, strengths. Kung iisipin mo, nandito na yung mga hospitals, so secondary, primary, meron. So, ang pag-uusapan na lang natin ay yung policy and guidelines. Kung paano yung network. Tama ba ako? The manpower nandiyan, transportation and communication meron dyan. So, siguro, ang ano na lang dyan yung technical working group na magbubuo ng policies and guidelines na yan. Kasi it should be represented by the hospital para sila yung mag-uusap kung pwede ito, ano pa ba? Kung ano paano yung compensation mechanism o paano sila kukuha dun sa special health fund, no? Paano yung mga ganon? Paano kung mayroon ng special health fund? Paano yung referrals kung kanino i-refer, sa MMG ba, sa Adventist ba, o kailangan ba sa Apex Hospital na ganon? Kasi yung binabanggit nyo kanina na Apex Hospital, parang gusto rin nila isama ang Batangas Regional Hospital, which is access-wise, mas madali siya kung ano. Lalo na sa yung tawag dito, yung mga aeroplano na maliliit lang. Kasi doon sila dumidiretso para mag-land. Kasi hindi sila makaland sa Manila, malaki. So, diyan po siguro sa policies and guidelines. Kasi kung strengths, diba?
alam naman natin, hindi yan yung
So, siguro po, ang dapat na pag-usapan na po, o willing po ba yung hospital na magkaroon po ng para committee na technical working group side by side with the city government and also siguro with the province na lang din para isang ano po tayo kasi we know na kahit po mag-spend tayo ng 2 days ngayon, kahit po hindi po ito matatapos sa sobrang laki po ng scope. So yun po siguro yun na lang yung una po natin yun na lang po yung talakayin po natin. Medyo fluid po tayo, dapat bukas pa po kasi yan. Pero I think po para hindi na rin po we'll squeeze as much we'll squeeze as much topics as for today para po tomorrow hindi na rin po. And I know all of you have very precious po yung time ninyong lahat. So at least po para mas isa po na ng topic today para bukas baka pwedeng kalahating araw or less pa po yung makonsume natin. Pero basically yun po. Today siguro yun nga po yung una natin.
Kasi lumalabas po na, una po binanggit ko, babalikan po natin kanina, binanggit ko po na kailangan po natin i-integrate sa sistema na bawat ospital, yung gagawin po natin sistema. Or ilalabas ninyo yung sistema ng ospital sa gagawin po natin network. Especially sa referral. Kasi po, hindi namin alam kung paano nyo i-accept yung pasyente o hanggang saan nyo i-accept nyo. Yung existing nyo po, pwede namin makita. Kung pwede po. Ang alam ko po kasi ang ONP, merong ganong operational guidelines para sa mga referred patients. Baka po yung mga private hospitals natin, may ganon din po guidelines. Ang po ba, Doc, meron ganoon. Na ano yung process flow, Doc Cole?
Actually, ma'am, sa Coco, basta may bakante naman tinatanggap. Mag-iiba-iba lang siguro yung policies per hospital. One, because of the pandemic, may mga ibang hospitals, bago ma-admit, antigen muna. O kaya pagdating, dapat dito antigen. Pangalawa, nag-iiba rin po yung rates kasi. So, ni-refer sa co-op, pagdating, ayaw namin ng rate ng ganitong room. Lilipat yan ng ibang ospital. So, minsan doon nagkakaproblema kasi pag binagsak na doon sa ospital, iniwan na doon, tapos pagdating sa rates, hindi sila magkasundo, lilipat, yung pag-transfer to another secondary hospital, yun yung isang problem. So, yun yung isang kailangan natin solusyonan kasi I think hindi talaga magpapare-pare. Okay.
Sige po, Doc. Noted po yun. Pero ibig sabihin po, just to verify and validate, wala pong existing written mechanism for the referral acceptance ang wala po. Okay.
As long as
May vacancy. Okay. Yun po yung ano natin. No written po ang co-op para sa mga referral. Accept no written. Umaga, one supply last.
Pero hindi pa po.
Based on weekend.
Hindi ko wala nang problem sa private hospital. Walang tumatakbo yung private hospital.
Sige.
As long as afford niyang mag-budget.
Apo. Same din po ba, Doc, sa inyo? Wala dito. Sa ating sa Adventist, wala dito referral, ano?
Nag-agree yung exam. Unless we can.
Okay. Apo, but just validating, wala pong existing written mechanism sa Doc Kenneth.
problem kung capacity na yung mga special
Okay.
Which is malabo din.
Ako, ma'am, ang problem lang namin, we have difficulty accepting psychiatric Kasi hindi kami wala kami sa amin.
Kasi walang
Sa amin yung
psychiatrist na case meron na pala.
Sige po, klaro po na ang may existing referral mechanism lang po sa yung written policy ay OMP. The rest ay as long as available or vacant siya. And then binanggit po na yung especially sabi ni Dr. Kenneth kanina, yung special units limitations. And then yung psychiatric ward naman for the MMG. Ito po yung mga isang na-identify po natin. Which means, base dito sa initial assessment po natin, kinakailangan po talaga natin mag-establish ng referral mechanism, especially kung gagawin po natin, maiwasan yung binanggit po ni Dr. Paul na hindi na siya nilipat kasi hindi niya kinaya yung rate. Yung sabi din ng Dr. kanina, mamamaleke siya kasi ganito yung naging status. On the side ng hospital, challenge siya kasi parang may first touch ka na, may pinrovide ka na, tapos wala, hindi ka mababayaran. On the side naman ng pasyente, nagpo-prolong yung agony at nagpo-prolong, lumalala yung case, yung sakit niya. Yung instead na emergency siya, nag-antay. May mga mas nagkaroon ng komplikasyon. Yun po yung mga ma-address natin. Pag nagkakagawa po tayo ng referral, standard referral mechanism between and among the private hospital as well as the government hospital. Whoever the recipient is, kailangan standard ang referral natin. Yun po yung kailangan pag-agrihan. Ngayon, ang kailangan po natin, pangalawa po natin i-agree, are we all going to include na tayo ba yung gagawa or may i-recommend kayo na mabuo na isang technical working group to write or put in behalf of you or facility yung mga gagawin natin. Ano po magiging agreement? Sabi nga po ni Dr. Rao, kanina, which is mahalaga po na bawat hospital or bawat facility, including the PIDOVO, the lens ng DLH, in private and then sa ONP. Kailangan yun sa technical writing and then the inputs. Actually, the writing itself, yung narrative, isa po sa pinakamadaling gawin, basta nandoon yung sulat. Katulad po nito, mahalagang concept po ito. Initially, nakita na natin, ito pala yung wala. Yes, Doc, Peter.
Alam ko parang may balak na si Dr. T maglagay ng psychiatric ward din kung ano. Wala ng space, di ba? Yun ang space. Actually, maganda yan na napag-uusapan, tama yung binabanggit mo. Tapos, hindi ko lang alam baka later on ay yung tama yung sinasabi mo, standard na actually yung standard. Para pagka sinabi niya na hindi kaya yung rates, para meron hindi ko lang matiyak, pero baka kung isipin natin, lahat yan ay regardless kung makakabayad siya o hindi, tatanggapin mo siya because of the system. So, ganun po siya. Siguro, ano kaya yung sa ng ONP, ng OD? Kasi halos lahat ng di ba sa inyo, yung lalo na yung mga kasi ganito yan ang mangyayari diyan, di ba? Ang city ay ka-group niya ang Aborlan district, di ba?
Or congressional sense.
side. Meron
Conventional.
pa sa operations po kasi na ng UHC. Sa Satisfactory
Sige, no? Oo, sige. Sige.
Congressman ka, naiintindihan siya.
Magkikita po tayo pag bumoto na ng congressman.
Yun na nga eh. Kaya lang, dapat pala sama mo si Congressman dito.
Hindi po. Yun daw.
Hindi, iyan muna, yung sabi nga kanina, mas maganda yan, may technical working group na mag-aayos yan. Para
Ang word din malaki. Ang sikip na ng ONP.
oo,
Sige daw.
Sa technical working group, dapat I understand, kaya tayo nag-invite ng specialist per department.
Yes po.
Kasi pwedeng sa level ng top management, sige, pero bawat specialty pala may requirement, sa OB dapat, na-IT muna yan bago transfer. Kaya,
Ganun po.
so baka kailangan talagang involve natin yung per department. Yeah, may ganun yung release na committee.
Lalabas po ba, based sa suggestion mo, Doc, kinakailangan ba bumuo yung per facility ng kanyang technical working group and then the representative of that group will be the one to be involved? Ganun po ba? Within the hospital. Kung ang ONP, kailangan nila i-revisit yung kanilang existing referral mechanism or requirements. Meron na po kasi sila. Baka po gusto nyo i-share. How do you do it in hospital? Yes, Dr.
Ganito po kasi, di po ba nagkaroon na ng HCPN din dati. Initially, meron tayo nung South, meron tayo nung North. So, meron na tayong nag-exist na written referral form. Which is meron na tayo nag-usap na dito kung ano yung ano pa yung mga sakit, kung saan dadalhin, na-identify na rin namin on. So, I think hindi na natin kailangan isa-isahin po kasi meron na nag-i-exist na ho ganyan.
Okay.
Existing na po, North and South. Yung sa North niya, yung sa Red Cats ba yun? Or
Ano po
RFC po and
Oh, yun.
Meron pa po kayo na barbecue.
Oo, na barbecue. Yung sa Red. Oo.
RFC yung
Yes, no.
Meron na po.
Portland, Rizal,
yun po. Yes po, Doc, Dr. At yung nakikita niyo pong graph, meron po kayo kopya pa kada isa. Yung graph po na yan is based po sa Taytay El Nido, ONP Puerto Princesa na referral manual. It's actually, yan po talaga yun. And with just some tweaking lang po na nakabase na po siya sa universal healthcare. Katulad po nung, yan pong manual na yan, ang hospital, expectation po dyan, yung hospital, they have primary public health unit already. Kasi yung public health unit po, based po sa Administrative Order 2020-0019 is that all hospitals should have their public health units that are equipped with a HEPO, disease surveillance coordinator, as well as a care navigator, or which is either a nurse or a social worker and an admin assistant. So basically, yung nakikita niyo po ngayon ay basically yun po yung 10. Ang ano lang po niyan ay yun po, nakabase na po siya na yung mga gagawa po noon, naka-ano na po siya na expected po na yung mga hospital ay meron na po public health unit. So, yan na po yun, ma'am. And basically, yun din po yung magiging itatakal natin this afternoon. Kaya po in-invite yung mga specialists is that we have to agree na yun pong mga case categorization, what we call yung sinasabi niyo po na diseases na pwede or not. That's case categorization, and that's also part of the manual already. But what we want is for you to agree on it. Ngayon po, para ang gusto ko po sana namin ay kaya po may specialty representative yung isa't isa. Kung may disease po na ganito, like for example, kailangan po niya ng isa pong pregnant na turns out to be GTN. So hindi na kailangan po sa na kailangan sa tertiary. Pero which hospital, kayo po kasi yung mga specialist, kayo po yung nakakaalam kung OB from Adventist. Sabi niya, ay, di namin kaya mag-opera ng ganyan. Okay, so no. Sa ACE, ay, di rin namin kaya yan, so no. So pag sa ONP, hindi rin namin yan kaya. Tapos sa co-op, hindi nila kaya. That's the time na pag lahat po kayo, hindi kayo capable, that's the time na we will be referring it directly to the Apex Hospital. That's why we invited din po yung specialist. Para po yung isa-isa hospital, masabi po nila na no. So that, sa referral po natin, pag ito po yung diagnosis ng doctor, we will go, the primary care provider should, by rule, should refer them agad po sa Apex Hospital. Yan po. Pero basically, ma'am, yun po ay nandiyan na po sa referral manual. So, ayun po. So, mamaya po, itakal po natin din yan. So, itakal po natin yan later on.
Actually, sige. Yun pong detalye na binabanggit ni Dr. Nofor ng mga symptoms sa mga case categorization, included yan na binanggit po ni Dr. Yun po yung expanded version ng referral manual na binanggit ko po kanina na ginawa ng Title El Nido and ONPN for the Princesa. Pati po yung referral slip, meron na po kaming ginawang form. Pati po yung contents nun, meron na rin po kami. Siguro, tanong ko lang, Doc, kung naisama siya, pati mga forms. Apo, nandyan po siya. Kaya po, kung makikita niyo po na may kailangan siya i-add na na-miss during that drafting, baka pwede niya na po i-update base po doon sa status ng inyong, sa level ng inyong specialization. Kasi per case po siya. And then yun po yung nandiyan na, pwede niyo pong i-check. Tapos mamaya po, i-discuss with Dr. Route naman yung content niyan, which is the case categorization. Bigyan ko na po kayo ng, sige po, Dr. bago ko po magbigay ng isang...
Yung sinabi ni Doc, Ram, BTN. Actually, kung meron kayong specialist doon, hindi mo na kailangan ng ONP. Isa yun. Second, kung halimbawang na-hysterectomy na niya yun, refer sa medical onco. Kasi wala naman talaga tayong gynae onco sa Palawan. Wala. Yun lang yun.
Sige po.
Tapos ayun pala, pag nagre-refer, kasi minsan nangyayari, nurse nagre-refer. Tapos pupunta sa ER. Siyempre mabubwisit yung taga-ER kasi walang alam si nurse. Kung pwede sana yung referral, doctor to doctor, para nagkakaintindihan sila.
Thank you po, Doc. Yun po, kung gusto po natin na doctor to doctor ang referral, yun po yung pwede natin ilagay dyan. Kasi po, yung manual po, draft po talaga yan. Hindi po siya set in stone. Kung ano po yung mga gusto niyo pong kasamang rules, katulad po kung doctor to doctor ang referral, pwede po natin yung ilagay dyan, i-comment po natin. Para po, pag na-agreehan po natin, dapat po, pag na-agreehan po ng lahat po ng stakeholders, we will abide to that.
Kasi hindi talaga nag-refer.
Opo. Tapos po, ganun po, Doc, for example, yung GTN nga po na, hysterectomy na, tapos kailangan, kung lilipat na siya sa med-onco, tapos med-onco po yung nandito. So, pero ang ending pa rin po noon, PCP pa rin po. So, med-onco, refer back niya pa rin po sa PCP. Tapos kung may complications po sa primary care provider, i-refer niya po sa med-onco. Mga ganun pong pwede naman po yan. Pero ang basically, what we wanted po is sana, yun po yung referral is makita natin kung ano po yung mga nakita nyo na hindi tama or yung mga palagay nyo ay hindi po nararapat po para sa ating referral. Yun po yung natin today.
Yun, Doc, yung katulad na may mga standard na may nare-require po kayo, that's SOP, hindi doktor, ay hindi nurse, hindi doctor to doctor lang ang referral po. Tapos meron ba kayo isa-suggest na time Yun na po yung kailangan yung ano ba yung magiging arrangement sa mga specialist. Pwede niyo pong ilagay dyan. Kung ano yung nakita niyo pong kulang or kailangan i-revise, i-refine, pwede niyo po ilagay dyan sa manual. May hawak po kayo manual. Okay, sige po. Si Doc, kayo po.
Yes po. Just clarification lang, no? Halimbawa, nirefer ng primary care practitioner sa surgeon. Inoperahan ng surgeon, cancer. Ibabalik pa ba ng surgeon sa primary healthcare bago niya i-refer sa oncologist?
Yun po, pwede po natin that's ano po Pwede po, ang referral po talaga, kasi po, kunwari, i-refer po ng surgeon. So, primary care sa surgeon. Pero ang referral po ng med-onco should be coming also from the primary care provider po. Ayun po, dapat alam na po agad ng yun po.
By that idea, what if kung ang pasyente has multi-diseases? Pagkadating niya sa onco, sasabihin na onco, hindi kita ma-chemo kasi may kidney problem ka. Babalik na naman siya ulit sa PCP. Tapos pupunta na naman siya ulit sa kidney problem. Kita ngayon ng kidney specialist, ay may complication pa na sa heart. Balik ka naman ulit sa PCP, pupunta naman siya ulit sa heart, parang ganon.
Sige, Doc, I understand your concern. Dr. De La Paz and Architect Villari. Architect Veridiano from HSDB, the Health Facilities Development Bureau from the DOH Central Office is with us on Zoom. So we'll pass the question para po yung answer will be coming from them na po from the Central Office. So if just to po yung question nyo is if multi-disease or needs multiple specialties, does the patient need to be referred back to the primary care provider before being referred to the other specialties? Tama po yung pagkakaintindi ko. Sige po sir, we'll get back to you. We'll just po dun from the HFDB para wala na pong tayo.
Hindi. Sasagutin ko na yan. Hindi mo kailangan ibalik sa primary healthcare. Kasi nandun na siya sa specialty hospital Dapat within the hospital na doon na magkakaroon ng referral.
Pag in hospital po, wala pong question. Pag kunwari po yung pag outpatient, baka doon po kasi Pero pag inpatient po, no questions po yan, yung primary care provider is hands off na po sa patient. Ang magiging main doctor na po would be the patient, ay yung doctor niya po sa hospital.
Kaya nga, hindi na kailangan ibalik sa
Primary care. Yan po.
Kasi kaya i-refer mo, kasi ikaw primary ka, hindi mo na, dapat i-manage niya doon sa taas. So, kung ano yung management na doon sa taas, kung ano na yung sabihin natin, yung progress doon, hindi na ibalik.
Ganun po ba yung pagkakaana, Doc Emery, yung sa lang po? Within the hospital po ba yung natin? Or outpatient?
Kung minsan kasi, like for example, pumasok, inoperahan. So, pinauwi na ng surgeon. Bakit? Kasi wala naman siyang
complication.
Wala siyang biopsy or histopath during the time na inoperahan. Buko na ang tinanggal So, paglabas ngayon ng biopsy, nakauwi na yung pasyente. Di ba? Cancer pala. So, sino ang magre-refer? Yung surgeon na kasi pupunta yung babalik yun sa surgeon ay cancer pala ito. So, anong sasabihin ng surgeon? Balik ka muna sa sa primary provider mo, siya na bahala mag-refer sa iyo sa oncologist, radio-onco, mga ganon. Kasi ganon yung progression Kaya lang, ang tanong ko lang doon, does the PCP has the knowledge na para na ma-manage ito ng maganda, kailangan i-refer siya sa radio-onco at saka sa med-onco so that this can be properly addressed. Diba? Yun lang yung susunod ko actually tanong. Kasi kung balik, punta dyan sa care, tapos na ako. Punta na.
Actually,
babalik na naman
Actually, Doc, yan Pag nag-refer back ka dun sa PCP, may note ka dun nababalik siya sa'yo. Diba? Yung referral system kasi pagka binalik mo siya doon, may nakalagay doon sa ano mo, sa referral o yung instructions mo, nababalik siya sa'yo. In case na lumabas yung biopsy, no? May mga ano ba may mga instruction na para po hindi na mahirap po. Yeah, okay.
So, let's be clear about this.
Sige po.
Acknowledge natin yung response si Dr. Bob.
Okay po. From CHD ni Maropa po, Dr. Mercene po of the H2 would like to say something.
Yes po, good afternoon. Hello, good afternoon.
Plug and clear.
Opo. So regarding this ano po no, this concern, so I think this is a very valid concern. In cases like this po no, when the patient needs further specialty care, so pwede naman pong direct yung referral to another specialist. But the thing is in the UHC, the primary care provider should be informed of the further management of the patient. There has to be a mechanism po na nalalaman niya kung paano further manage yung patient. So yun po yung I think yung pwedeng isipin po nung health HCPN nyo po no, kung paano magagawang ma-involve yung primary care provider in cases like this, because in the end po when all management, for example, hindi talaga kinakaya na and palliation na yung kailangan, babalik pa rin siya kay primary care provider and he has to know po yung naging management, yung management history ng patient. So yun lang po yung input ko regarding that. Thank you.
Parang hindi masyado, ano yun, pupunta yung pasyente o tatawag mo lang, kailangan sa refer.
Ano yun, hindi na siya kailangan pumunta kay primary healthcare provider. I-inform mo lang siya, tatawagan mo. Sir, inire-refer ako ni Dr. Surgeon kasi CA po, cancer po yung sakit ko. Kailangan ko po ng additional chemo o radiotherapy. Hindi na niya kailangan pumunta kay primary healthcare provider o enough na yung tinawagan lang niya.
Hello po. Actually yun nga po, at least inform po no in the progress kasi ang basic idea dito dapat po meron kayong electronic records, electronic yung system talaga para may immediate feedback po no, natatrack din nung primary care provider yung yung history ng pasyente.
So yun po, ang sagot talaga ay ang ating medical record. Yun actually, that's also one of the requirements din of PhilHealth as stated earlier, na dapat po merong interoperable electronic medical records within the facilities in the healthcare provider network. Doc, may additional po kami na question, Doc Bob. What if po, yung mga family physician, how do they, pag mag-admit po sila, paano po yan? Pwede po ba yun na primary care provider sila and then at the same time they can admit for inpatient care?
Regarding po no, family physicians, if they own po a primary care facility, primary care provider, pwede naman po yun. And at the same time, kung affiliated sila sa hospital, kung yung management niya na na inpatient, pwede rin naman na siya pa rin yun. Basta so long po as siya, kung i-manage niya as primary care, dapat ma-meet niya yung requirements ng primary care provider.
Pero po kasi, sabi po ni Dr. Parkas from PhilHealth po kanina, Doc, ang sabi niya po, we have to choose either you become primary care physician or specialist kasi you can refer to yourself. Parang ganun po yung words kanina ni Dr. Parkas from us.
Okay po. So kung ganun pala po, so it's already answered naman pala kanina.
So, Doc, so yun po yung susundin po namin, Doc.
Na ano po?
Yung kay Doc Vargas po.
Opo, kasi it will depend pa rin talaga kung how it will be financed later on.
Okay. Thank you
Oo.
po.
So,
Sige.
oo.
Thank you. Thank you po, Doc.
Oo.
Medyo mainit-init nga po yung usapan. And marami po talaga tayong dapat lansyahin with the healthcare provider network. Ma'am, ano po kaya?
Opo, nabagin po kanina na ang isa pong mahalaki makakatulong sa atin para hindi pa balik-balik physically. And then yung concerns ng mga doctors with the same patient, ay kailangan po natin mag-establish ng referral system na interoperable within us. Which is parang lalabas po sabi ni Dr. Kailangan po ba sa pabalikin? Hindi na po. Ang sagot po ni Dr. Bob, and based sa guidelines, hindi naman physically kailangan pabalikin si pasyente. Kailangan na po ma-inform si referral facility na ito ang ginawa naming management sa kanya. And we don't have, sabi ni Dr. Natat, kailangan pa bang tawagan? Ang sagot po dyan, kailangan meron po tayong system. Yes po, meron na tayong system. Halimbawa po, kahit sa patient actually sa initial referral pala, it's not only the paper that the patient is going to bring. Pero kailangan naka-integrate na sa system na ito yung kanyang case from the initial assessment ng primary care provider. Yun din po magre-reflect sa inyo. Tapos, base sa inyo, i-update nyo naman yung case niya. Base sa inyong assessment, ito na yung case ng pasyente mo ngayon. Ng pasyente na natin ngayon. Kasi ikaw na nag-co-manage and then ito pa, lumaki pa. Sabi ni Dr. kanina, nagtatlo na yung kanyang na-identify ng mga diseases which requires multi-specialty specialist. Kaya po, doon pa lang siya, sa system pa lang, magre-reflect na po yun. And supposedly, that information, magre-reflect back din po doon sa system na hinahawakan ng unang nag-handle ng pasyente. Yes, Doc.
Tinanong ko rin yan because remember sa PhilHealth, kapag ako ang nag-opera, na-refer ko sa iba, hindi sila babayaran ng PhilHealth, ako lang. Diba? So ngayon, ang punto ko lang is, papaano ngayon ma-properly rated ang lahat ng mga doktor na involved sa kaso na yon na isa, and how is it possible? Kasi sa PhilHealth system ngayon, isa lang na tao yung babayaran niya. Wala siyang makialam kung ilang test yan nagtingin eh. Di ba?
I think, Doc, the best person to answer that would be Dr. Vargas kung it's the remuneration and ano po ng mga co-managing specialties po. And he's just nasa meeting daw po. So we will just ask him later po. I will just park the question and ask him later po for that issue.
Eh, binanggit kanina kasi si Dr. Vargas, for example, ang case rate ng CS is 40, tapos nagkaroon ng mga medical complications, ni-refer sa ilang doctors, may additional na 12,000. I think that 12,000, yun yung paghahatian ng hindi primary physician, primary attending physician. For example, yung 30,000 na sinabi niya kanina na case rate, yun yung papupunta sa OB. Yung additional na 12,000 for the medical complications, yun yung paghahatian ng mga other doctors na medical. Pero yung 30 na case rate kasi hinahati yun sa surgeon saka sa anesthesiology.
That's also in the concept of disease-related group. Kasi po pag may comorbidities, may risk factors, and also the geographic location of the patient, it will add po sa pwedeng makuha po yung pwedeng pong payment for the patient po. Ayan po. So, ayan Yun po. So yun nga po, with the payment, it's really with the PhilHealth po. So we'll be waiting din talaga for the latest guidelines of PhilHealth. So maybe later, pag makakaya po si Doc, we can ask him po. Baka meron po siyang insight regarding.
Pero Doc, settled ka na po doon kung paano yung pag-handle ng patient na hindi na siya kailangang pabalik-balik physically or ikaw, kailangan mag-coordinate ka pa katulad ng sinabi kanina na tatawag mo ba ba, inform, gano'n. Pero with using the interoperable na system po natin, how from the referring facility to the end referral facility, kung ano na naging yung status ng pasyente, doon pala po magre-reflect na hindi nyo na kailangan i-ano sa amin, ipabalik yung pasyente.
Opo, kaya lang, siyempre, additional na trabaho yun kasi ang mangyayari, if you miss na ma-inform at saka nga hindi siya ma-acknowledge as part of the attending doctors, hindi magsisisihan yun. Yung kumulay din parate, yung responsibility kung sino ang mag-a-assume ng responsibility.
Noted yun, Doc. Actually, ilalagay ko din natin yan na isa yan sa maging concern, hindi lang siya current issue and potential na lumaki yung issue kapag ongoing na yung ating yung sistema ng referral. Sige, Doc. Noted on that. Pero with the case na yun po yung sa pag-handle ng patient itself. Kasi magre-reflect siya how you will divide yung remuneration. Sige po, Doc. Noted. Doc Rao? Yes, Doc.
So, tama diba? So, ang gusto natin is meron tayong system na yung yun sa pasyente parang EMR, tama pa to?
Opo, Doc. Actually, hindi lang po yung gusto. Requirement po talaga siya ng PhilHealth.
Meron na bang system? Kasi kanya-kanyang hospital, kanya-kanyang system. Parang ang hirap.
Opo. Actually, napag-usapan po nga yan last time. Based po sa binaba po sa amin ng KMate or Knowledge Management Information Services po ng DOH. They're still on the, kasi po ang timeline nila is up to 2026. So they're developing the system. Ang end all po, dapat po yung application would be interoperable in the Philippine Health Information Exchange. So pag nasa Philippine Health Information Exchange na po yun, pwede pong doon na lang po yung talaga. Pero basically, ngayon po kahit sa PhilHealth, it's still the IPNP and the hospitals na yung iHome is yung meron po. Hindi pa rin sila talaga ganun. Meron na pong connection yung iClinic with iHome, pero nasa beta stage pa ata. Parang sa Aklan pa lang po nila. Somewhere in region 6 yung pilot na area nila for that. Pero basically po, Doc, yun. Ito po talaga ay isang exercise na in the work and medyo malawak po siya. And hindi po talaga natin siya matatapos. Kahit kung matapos natin yung 2 araw, hindi po natin matatake lahat ng issues na meron tayo. So, yun po, always po, ito ay in the work and we really need yung input po ninyo. And very fruitful po yung afternoon natin with all your insights. And I'm very thankful po for the mainit-init na balitaktakan natin ngayong hapon.
Bigyan lang tayo ng background, Doctor, sa may 4 po tayong primary na kailangan i-work on, which came from our partners. Una po yung standardized na referral mechanism and the flow. And then yung pong technical working group for the inputting, which is actually currently ongoing para sa content. And then yung interoperability ng ating system, na binanggit naman ni Dr. Ralph kanina na yung iHome and activities ay kasalukuyan pa lang po nila din-developer. Minimary nila yung both systems. And then po yung process of inclusion ng all providers na nagre-reflect naman yung para sa remuneration for the PhilHealth package. Ngayon, tinanong po kanina ni Dr. Kenneth yung chance. Alam ko familiar si Dr. Kenneth sa TBIS for yung kina Kevin B. Na ang magiging introduction is for the TB. And TB information system which is localized for the Princesa TB. Isa po yun sa isang project namin na naka-apply yung budget sa isang project namin sa city. Yung tuberculosis TB information system ay i-develop locally na isang provider. At yun po, nung in-introduce namin sa kanya na this system will be used eventually for the universal healthcare, nakita po niya yung need na the entry of the patients will be like the TB patients. Pero, since i-enroll natin sila doon sa ganong mechanism, gagamitin din po natin doon, magkakaroon siya ng modular. Yung system na yun. Module from this arrangement, TB muna siya initially and then lalawak siya. Lalawak at yun po yung i-share namin sa inyo. Actually, magkakanda ko ng orientation si Kevin by the last day, sa Friday morning, para po doon sa TB information system. Though it's primarily for the multi-sectoral coordinating committee, pero invited po yung whoever is interested. Kasi si Kevin po is a local developer na ginagawa niya po yun sa Puerto for the TB program muna. Paano yung referral ng actual TB patients from the primary care provider hanggang sa specialist and refer back. Yun po ay i-handle ng mga consultant na hinahal po ng city. Pero yun nga po, introduction lang siya kasi gusto namin gamitin yung TB information system na ma-expand for the universal healthcare without waiting pa or while waiting doon sa ginagawa ng national government agency. With the same capacity na in-expect na i-deliver ng LGU. Yun naman po yung ginagawa, yun po yung ni-integrate namin ngayon. Using the TBIS program as an entry point for the UHC, yun po yung nakita namin isang pasisimplihin muna, isang sakit lang muna. Nakikita natin kasi yung referral flow. Okay, paano pag dumami na yung sakit na i-refer cases na ilalagay dito, magkakaroon din po siya ng segmentized or ang tawag na nga doon drop-down route, yung sa bawat manual ng system, modules. Magkakaroon po siya ng bawat modules, bawat case. Ito yung baguhin, which is localized po yun, i-develop. Kaya po by Friday, kung available po kayo, you can also listen to the explanation ni Kevin. Yun po yung isa. Kaya po yung interoperable system, most likely we'll be having our own localized system. Ipapakita din po namin sa inyo how it will work. Ang kasama po namin yung consultant doon ay yung sila Dr. Kenneth, Dr. Chua, at saka si Dr. Miguel. Kasi sila po yung sa mga specialist namin for the TB. Pero lalawakan na po siya using the same system as platform. And then yung process for inclusion, ilalagay din po namin doon. Gusto ko pong malaman doon, ano po yung pwede ko pong mahingi yung recommended action nyo para doon sa sinabi niyo po na process of inclusion ng all providers na magre-reflect po siya na equal or sila din ay ma-recognize for remuneration. Ano po yung nakikita niyang possible na recommendations? So we can include it sa referral po natin. And then, pwede din po namin ipa-akyat sa taas yung consideration na yun. Kasi kung nakataga sa bato yung policy ng PhilHealth, sabi dyan, hanggang dito ka lang, tapos ito lang ang bayad. Tapos sabi niyo nga po, yung primary handler lang ang makikinabang. Paano na yung iba na nag-provide ng services? Pwede ko pang hingin, Doc, yung inyong recommendations on this aspect. Para at least, hindi na po siya na-identify as gap. Pero definitely, ano po yung magiging suggestion niyo para maging equal yung recognition sa services na na-provide sa patient.
Well, essentially, hindi naman yan magiging equal, but at least lahat will be properly remunerated according to the services they rendered. Na yung sagot diyan actually is yung sagot din ng PhilHealth, no, kung paano nila i-remunerate. Ang importante lang naman sa on the part of the doctors is ma-recognize yung kanyang input sa pasyente. Ibig sabihin na kung nag-render siya ng service, dapat kasama siya doon sa mababayaran actually ng PhilHealth. And then, ang tanong lang is, saan manggagaling yun yung coordination na yun? Doon pa ba sa kanyang primary care provider o sa doktor, sa attending doktor na nirefera ng primary care provider na nag-refer sa other specialties?
Dok, tanong ko lang po, yung binanggit yung coordination to and from. Yung coordination kanino? Papunta po kanino?
Pakaintindi ko kasi, halimbawa, kung operahan yung pasyente, from the primary care provider, may idea na siya na i-refer niya sa surgeon kasi mukhang may bukol. Pagdating na ngayon sa surgeon, papauwiin na siya ng surgeon kasi natapos niya na tanggalin yung bukol. Kaya lang, madidelay yung biopsy ng mga 3 to 4 weeks. So, ima-manage siya ulit doon ng primary care provider. Babalik ngayon, pag dumating na yung result, siyempre, ibabalik yun sa surgeon. Cancerous. So, ngayon, ibabalik ko pa ba muna sa primary care provider na kailangan siyang, parang i-recommend ko, please refer this to the oncologist, or ako na ba ang magre-refer na I will refer you to the oncologist, and how will it be coordinated na pag may refer sa oncologist, mapapasa na yung responsibility na babayaran yung oncologist at kung sino pa man doon yung doktor na yung magiging involved in the complete treatment ng pasyente.
Okay, Doc. Noted po. Nilagay po namin siya para magbigyan po siya ng complete picture. Yung from first referral to nagkaroon na po ng specialty referral and multi-specialty na po. Sige, Doc. Noted po dyan. From the source of coordination ng primary provider to specialist to subspecialist and other provider na na-involved hanggang sa makompleto yung services. Noted on that, Doc. Bubuuin po namin yung picture na yan para pag inilatag po natin yung sabi niyo nga, paano siya lalabas at paano siya mag-acquire ng payment for the service na pinag-provide niya. Sige, Doc. Noted po dyan. Gagawin po namin isang picture talaga yan siya. Kasi most likely, yan po yung talaga yung case scenario na nangyayari ngayon. At lalabas na magiging challenge po siya pag hindi natin establish. Noted po daw. And then, lumabas din po kanina yung binanggit po ni Dr. Dr. Paul kanina, Doc, yung sa HRH, yung human resources, paano po natin ilalagay? And then yung pong binanggit ni Dr. Management and Special Health Fund. Pagdating sa sharing of resources. For the equipping, ito po yung equipping ng facility and then yung equipping both sa HRH at saka po doon sa equipment. Sige po. Nabanggit din po kanina yung mga listahan ng mga inventory of capacity. Binanggit ni Dr. kanina na kailangan po natin makita. Ano pa po yung kailangan natin ma-include dun sa, kasi most likely there are areas, these are the areas po na hindi namin na-isama dun sa current manual. Kaya for updating and revision po talaga siya. At gusto po namin yung nabibigay ninyo kasi hindi po yan nakikita ng LG. Siyempre, ang magiging level lang po namin is either the referring facility or kami mismo yung i-refer as patient. Yun po yung limitations. As a provider, hindi po namin nakikita yung process na to. Meron pa po ibang kailangan natin i-include sa policy or guidelines. Parang sa ano to, Hospital ng Palawan, basahin ko na po no, yung kanilang strength. Yung existing referral practices ay base po, siguro Doc, mailagay na lang natin yung existing referral practices ay meron kayong existing na referral mechanism. Funded sila ng UHC, government-owned facility. Ito po yung na-identify din nila, yung gaps and challenges. Written guidelines lang, pero sila din yung referral facility for the whole Palawan. And sa manpower, departmentalized. It is following the, ano pa din doon, Doc, no? Sa civil service. Yung population ratio. Sa atin, sa UHC guidelines. Population ratio din. Ang human resource. Gaps and challenges. Doc po, hindi ka po nag-iisa sa exodus of nurses. Lahat po meron yan. Keeping nurses na na-hire. And then sa specialist lacking. Siguro po, Doc, sa gaps and challenges, kung makikita mo niyo po dyan, na-identify natin ang gaps and challenges. Possible, ma-identify rin po natin kung ano yung underlying cost. Diba? Mababa yung salary grade na in-offer, and then the benefits, Doc, o din po, may mga ganong issues. Then transportation and communication, 5 po yung functional ambulance, 3 doon IPTV, isang GLS, at tapos isang advance. Tapos sa Kakan 168 po ba? 165. 165. 168 na parang alagandahan ko yun sa may yung dating Masway, 168 po yan dati. Yung Masway po ngayon, 168 po yan. And should have the initial data of patient. Tapos yun pong in place, no balance billing, no out of pocket. Gaps and challenges, crowded, lack of space, comfort. Doc, sa client satisfaction survey itself, yun po bang, lumabas din po ba yung yung service provider attitude? Wala, meron. Sa gaps and challenges. Okay, yun po yung sa Ospital ng Palawan, ano? Pwede, dito ba? Sa A, sige, bibigyan ko pa ng kasuyo na lang yung mic kay Dr. Kenneth. Para sa ACE Hospital, and then si Dr. po para sa si kumakain lahat yung taga-ONP.
So yung problem sa food specialists in each hospital sa Caborlana, Northern Palawan, to Congest, maganda sana na mayroong mga team, surgical team, OB team, COVID team sa mga hospitals. Tapos, put a ceiling on number of bed capacity for each department, proper endorsement and coordination. Siyempre, equipment din important. So, possible solutions, hire more specialists. Siyempre, kailangan ng budget for that. So, yun nga, what doctor lang, dapat team ang always on standby para kayang gawin yung services. Tapos, kung yun nga, inform ER na kung kaya pang mag-accept, mamaya puno na pala. May referral forms din and check equipments and available beds in each hospital.
Nakihalo na ako. Yun sa
Sa amin po, we don't actually have a written policy on referrals. Pagdating sa manpower, complete almost yung specialist. Tapos, mga gaps and challenges. Actually, sorry, hindi ko naintindihan na this is only for co-op. So, nilagay ko dyan, sa challenges. Wala kasi yung specialist sa outskirts ng city. And then, sa amin, we lack nurses. In the last DOH visit, we are being asked actually to decrease our bed capacity. Parang hinahabol yung ratio ng nurses to patients. Kaya, so ang mangyayari, bababa lalo yung aming authorized bed capacity, lalo hindi kami makakatanggap ng patients because we do not have enough nurses. So yung strength, marami na tayong avenues for communication. Diyan yung internet, tapos siyempre yung tawag. We also, because of audit, we realized we need the DHF, UHF radio. Kulang lang kami ng repeaters, pero we can communicate with the base. Siguro, better kung meron tayong mga sat phones, bawat facility. Medyo mahal lang, pero that's one way of doing it. Yun lang, walang signal nga kasi sa ibang lupalop if the referrals will be coming from remote areas. And minsan naman, the problem is electricity. Walang online kasi walang kuryente. Client satisfaction in place already, pero actually, hindi siya na-monitor monthly. So minsan late yung corrective mechanism kasi late na monitor yung client satisfaction. Thank you.
Thank you, Doc. Noted po doon, Doc, sa sat phones. Pinagay niyo po, Doc, yung radio frequency. VHF po yun, ano? Tatawag. VHS. Kasi kung napansin niyo po na nagkaroon ng audit, wala tayo lahat communication kasi we all rely sa internet. Pero ito yung na-miss natin. Yung ating dati tawag natin walkie-talkie. Yung over and out, tapos yung sat phone. Pwede na po tayo. At dapat we have to go dun sa updating ng ating mga ginagamit. Although, binanggit din po ni Dr. Paul kanina na consistent and available yung communication platforms, which is the Viber, yung social media. Yan, nakita po natin yan sa internet. Pero we're totally dependent sa internet nga po. Pero may papansin po na sabi niya rin, within themselves, may lack of monitoring and evaluation. And because of that, nagkakaroon ng delayed response or yung redress mechanism. And among us, ito po yung isang malaking between and among us sa mga nagre-refer and referral facilities. Wala pa tayong feedback, official feedback doon sa mga status ng mga patient. Sa current status po natin. Ito po yung totoong buhay. Halimbawa, kahit sa satellite, nag-refer, yung halimbawa po yung na-aksidente na tinakbo ng City Hall doon sa Barangay Manalo, tinakbo sa Adventist. After na ma-refer doon, wala na pong update kung ano yung nag-refer, ano nangyari doon sa pasyente. Unless na magtatawag ka, which hindi na rin po ibibigay ng pasyente. Tinry ko po kasi na mag-update. Ma'am, taga City Hall po ako, kami po yung nagtakbo ng pasyente sa inyo nung yung po may baby na namatay yung isang pamilya na na-aksidente. Ano na pong status ng mga pasyente? Ay, ano po, hindi po kami makapagbibigay ng status ng pasyente. Yun ang response po sa amin. Kahit na sinabi ko po na kami yung nagtakbo ng status sa pasyente, tawagan niyo na lang po yung kapamilya. Ganun po yung response sa amin. Parang ito, blinded po tayo. Ano na nangyari doon? Especially kung tayo po, that is emergency. Pwede po natin, yung cases na parang paano siya i-handle, wala po tayong ganun feedback mechanism doon sa status. Para at least, yung buhay pa ba tinakbo namin, may pasyente na nanganak, yung baby tinakbo ay medyo ano na, kasi delayed yung pag-handle. Tinry na mag-normal, pero hindi siya naging komplikado. Wala na, pag maliban na lang magsabi yung pasyente, namatay po anak ko. Saka lang nalalaman ng facility. Kasi between na mo ang wala pa tayong kita. Yung pasyente mo, kasi yun din po, gaya ng within the hospital itself, nakikita natin kung ano yung redress mechanism natin. And for us, kung ano yung naging epekto noon, alam din namin na may kulang kami. Capacity-wise, alam namin na kulang na kami, pero within the referral itself, ano na-miss? Yung delays. Kasi, di ba, meron po tayong mga delays sa tinatawag, yung primary delay, which is on the patient side, delay na nag-seek ng services. Second delay ay nasa mag-transport ng patient. Third delay ay nasa facility na pero hindi siya nabigyan agad na actual needed services niya. That's the third delay. Kaya hindi po natin nakita ngayon saan area yung naging. Ngayon po, itatawid na natin ngayon dun sa, siguro ito yung mga contents na yung sa i-write up na i-update doon.
Sige po.
Meron pong 5 primary concerns and then the rest ng mga pinisod po nila para maisama po natin sa updating ng referral natin. Meron pa po bang gustong pahabol bago ko po i-turn over kay Doc Rob? Or meron na po?
I-recognize ko lang po. Dito ulit si Doc H. Vargas po. PhilHealth. So, Doc, my question po kasi kanina regarding po, bigyan ko po kayo ng case. There's kunwari po, a patient who has cancer and then the patient is referred to by the PCP to a surgeon. And then the surgeon, syempre po, parang tinanggal po yung pinapirahan. So yung mass, wala pa pong result yung biopsy. And then, it turns out na may cancer po siya, pero na-refer back na po siya. Na-refer back. Tama po, Sir, Doc Emily. Na-refer back na sa PCP. Tapos, so lumabas nga po na cancer. So, sino po yung dapat mag-refer? Is it the surgeon or is it the primary care physician? And paano po yung magiging ano nila? And the second scenario po is, a patient needs multi-specialty care. Kunwari kung meron po siyang cancer din, tapos nagkaroon ng kidney failure. So, ang nangyari po, kailangan siyang i-refer to other specialties. So, a nephrologist, gano'n. So, a medical oncologist. So, surgeon, gano'n po. So, sino po yung main na dapat mag-refer? Is it the primary care physician or is it the attending physician? And paano po yung, pinaka-ano po is, paano po yung hatian with the specialist? Kasi nga po, nag-refer na, and kung yung pabasihan po natin ay DRG, paano po yung magiging hatian po nila noon? Yung base po ba ng DRG ay doon sa main main attending, tapos yung additional ng DRGs, yun po yung mapupunta sa specialist. Paano po yung nakikita natin?
Outpatient to or
Yung first case po is outpatient, yung second is yung sa inpatient po.
so it's always the primary care, diba? Actually, first navigates and coordinates. Doon naman sa second, gaya ng binanggit ko, walang differentiation. Ang ibabayad natin for PF and hospital. Pero kasama siya sa leave. So ngayon, yung the way it will be divided, depende yan, pag-uusapan yan ng network. Pag-uusapan din yan ng facility. And how it will be distributed, pag-uusapan din po.
So, a bottom line po, it will be the network or the facility kung paano po yung hatian nila will be distributed para ganun po. Okay. So, yun po, Doc Emily, I hope that answers the question. Wala pong tao na tatanggap ng isang like ngayon yung policy ng PhilHealth. Pag yung ano to, yung ano yan, yung RUB code says 10,000, bibigay yung lahat sa attending.
Lahat po ng policy natin yung magbabago. Kasi pagdating na po sa DRG and all, it will be paid. And again, the whole it will be a global budget that will be paid to the network. So ngayon po, doon nag-uusapan po ilang percent, yeah, the facility will have to decide on.
Okay. Now the next question now is, paano kami i-tax?
Yan po yung kasama sa pinag-uusapan ngayon with the COA and the PIR. Kaya kung makikita po ninyo doon sa presentation ko kanina, doon sa whole of government specific guidelines, kasama po doon ng PIR. Because kailangan po na paglabas ng guidelines, kasama po ang paano ng taxing. Yun po yung hinihintay natin. I can't speak on that.
Sir, you mentioned kanina, for example, yung cesarean section with medical complications. Sabi niya kunyari, example, yung case rate niya is 30,000. And then, plus 12,000 for the medical complications. If ever lang. Sample lang, sir. Theoretical lang natin. So yung 12,000, hindi po ba ang maghahati nun? Yung medical na kasi medical doctor ang...
Remember, it's not just about the people. Because yung pong add-on as an attribute is the use of the resource for the treatment of any complication. So kasama din doon yung gamot na binibigay mo for hypertension, yung mga binano for... Kaya po kasi diyan ang issue natin ngayon eh. Pag CS with complication, binabayaran lang CS paano yung paggamot ng iba. Pero ngayon po, it will be part of the complication as an attribute. So yung pong add-on, hindi lang yung PM. It's really for the resources used to manage and treat the other attributes na nadudoon sa sakit or nadudoon sa condition ng pasyente. Other than the regular CS na, but with complications or with other diseases, kasama po yung use of it. Samples lang po yun. Kaya nga po we are doing the costing. And we need the data. Otherwise, wala naman magsusupply sa amin ng data. Kung ano yung dadating sa amin, that would be considered.
Yes, we do.
Hindi nag-ask about society, example po, PCN. So, usually naman sir, may represent na kami po.
Pero iba yung kasi, society ng moral but the treatment itself, resources used in the hospital. That's why it's very important that part of the exercise really is the presence of the hospital. Because again, the discussion here is not just about, it's really the definition of the cost. Kaya nga po yung ibabayad natin, EF and hospital fee, all the services. Yes, societies, associations. Hindi naman. Because in costing, you have the financial, you have the services. Sama sa financial yung salary, sama yung TF, kasama yung so all those data kung ano natin yan. So even the salaries, para sa mga employee, kasama yun yung PF ng certain disciplines, kasama din yan. Kasi kasama yan, coming out with rate. Yan po yung kaya nga po, diba, meeting na natin. Kung halimbawa, dyan pumapasok yung pasok ng UHC. Kasi, in a regular case, na-cost mo na siya. Ibig sabihin, hindi na siya regular because there are probably complications, diseases, or others. So, yun yung adjustment. Kaya kung mayroong adjustment factors, kaya halimbawa, CS, pwedeng sa CS, marami. Regular CS, CS with hypertension or any medical disease, CS with other procedures, CS with complications here, pwedeng iba-iba yan. Because there are several factors.
So, yung i-clarify ka lang kung kayong sabi ni Dr. na regarding sa halimbawa, from the primary care facility, they-refer sa surgeon. Nung kailangan ng surgeon, dinaling kayo pinamit na yung pasyente. Nung dumating sa surgeon yung biopsy, cancer. So, yung surgeon will just tell the patient to go back to your primary care provider and then you see the result na cancer, bahala siya mag-refer sa kanino o magbibigay ng recommendation surgeon. Please refer this to medical oncologist, please refer this to radiation specialist, please refer this to pain specialist, please refer this to psychiatrist. Parang ganon.
After the episodes of care, it is always the primary care. It is always the primary care to actually navigate and coordinate kung kanino or kung ano yung susunod. Because it is with the primary care, ano yung listahan ng mga specialista na meron sa network. So pag galing na pasyente, kailangan po ng problematic ka na. For example, naging cancer naman siya. And the case, for example, a medical oncologist, not a surgical oncologist. Ito po yung listahan ng medical oncologist natin. At nurse, or daily po i-refer. Again, that's part of the job. Navigator, coordinator. As at the same time, of course, primary care. Physician po siya yung ganun din, if the patient needs others like rehab, ito po yung mga rehab doctors natin in our network. Dito po kayo.
But who will determine kung kanino siya dapat i-refer?
Yung primary care. But of course, the primary care, di ba yung lahat po kayo is in a network? Di ba lahat kayo is coordinated, integrated? The primary care can always check with, di ba, ipang unang nilagay. Di ba, nasa iyo aking dali yung biopsy. The primary care can always check on you. Ano, with this po, ano po yung next? Para po ma-refer namin yung i-navigate. Because again, it is always the patient's choice. Kung kanino siya binumulak.
Parang mahirap din yun kasi, for example, ako yung primary year, favorite chick lang. Sa'yo mo dati yun. Mawawala ba yung ganun?
check po natin yan because basically, kung hindi kasi kailangan yan sa mga performance targets and indicators. Siyempre, meron yung mga patterns. Makikita rin natin. Bakit lagi sa kanya? Or kung may kailangan admit, kailangan na-admit dyan. Makikita rin po namin yan. And those are part of our performance checking and outcomes too. So, makikita rin natin yan. So, kasi syempre, naiisip na rin natin na pwedeng i-gain yung chances na. Lagi naman pwede. So, yun yung mga bagay na kailangan din natin.
If I may add lang po, siguro in the part of the network, that's also one part na sana man-pass natin sa manual, yung provision na fairness to all the referrals. Like, pati kunwari sa hospital, actually yun po yung kinanggit ni Doc Salazar during the pre-workshop is, paano yun? Kunwari, yung advantage, di naman kami nakakatanggap ng maraming referrals kasi doon sila laging sa ganitong hospital. So, and siguro po yun din yung pwede natin i-ano is also, ang referral natin would be equal po kung, or not just in the hospital, but also on the specialist.
That's why it is always
Yes.
also. Not the primary care providers. So, basically, ang paglalabanan dyan, how are you actually providing the service? Because kung maayos ang pagbibigay mo ng servisyo, by word of mouth, sabihin ng pasyente, ay doktora, ano, sinuway. O ganito. Ayoko dyan kasi, things like those. So it is also a check on our Yes. Remember, nasa batas po ang definition ng provider. Dapat feeling or professional. At ang professional is it can be a doctor, a midwife, a nurse, identified. Because again, the primary care provider will have to be certified according to this or competence. So it's certified na according to their competence. So ang mga midwife, may sariling competence here. Ganun din ang doktor. Ganun din yung mga nurse. Kaya yung mga trabaho ng nurses, primary care, identify at doon sila isa-certify. Hindi naman sila isa-certify or consultation.
Ko lang. Yung sinasabi ka rin ng from hospital, from one hospital to another, para nagkakaintindihan. For example, bakit mo siya i-refer? For example, kung hysterectomy, literal fracture. Kailangan, ang nagre-refer from, kunyari, galing outside Puerto, ang magre-refer doon, yung OB nila, dito sa OB sa Puerto. Hindi yung medyo sa iba yung sinasabi ko yung
check ko lang na. Check ko lang. Again, outside Puerto, ibig sabihin may ibang network. Because Puerto has its own network. So, kung meron sa Puerto ng service nation as a network, bakit siya i-refer sa Palawan?
pero wala ko yun. Yung mga travel.
So, paano siya naging healthcare provider na?
Yung sinasabi siya na dapat outside.
Correct. Kasi di ba may healthcare provider network, you have to have the primary care, secondary care, especially.
Kasi dapat yun mo nag-equip kasi para ma-lessen yung problem.
You have to check. Or otherwise, kung pula, contractual. Because again, remember, kung saan ka nakalista ng network, doon ba yan ang solution? So if you're referred to another network, walang bayad. Because kompleto na nga ang services yung network na to, kaya nga nagkontract. Ang hindi na nakasama dito are services provided by any referral or cables. Just like, kung dito ako naka-refer or dito ako naka-lista sa network ng Puerto Princesa, wala akong operahan. Eh, paborito kong doktor, wala sa network ng Puerto Princesa. Nasa Palawan network province. Doon po gusto mo operahan. Pwede naman. Out of because those services are paid in the Puerto Princesa.
Out of pocket.
Dito ka kasi nakaregister. So dito ka nakabili ng dito. Yes.
For instance, ang bawa yung pasyente, yung parents na completely work ng fever. Then, may fever lang, one day, gusto mo admit yung anak ko. Kailangan bang, pagkakita ko sa private hospital, kasi andun yung gusto kong doktor, mag-out of pocket na lang yung parents. Tapos walang share ang PhilHealth doon.
Yes.
So,
Kasi remember, everyone has to go through the primary care. At bago ka, hindi pwede mo dumiretso sa hospital unless emergency, serious, proximity. If there's a need for you to be admitted, the primary care is important to the hospital. Or to see a specialist, the primary care. Kung dinimidiretso na kayo to the hospital or what's outside the process. Siguro naman pa, hindi kayo dumaan sa proseso. Yes. Because you are because again that's daily. Yes. Identify as yung 3%.
Clarify ko lang po yung question ni Dr. Corenas kasi kanina I asked, pero wala ko kayo kanina, kung pwede yung isang hospital maging part ng dalawang network. Hindi.
Sure, you're only one that
Kasi po like sa outside po,
except prepare.
outside po of Puerto Princesa, wala pong level 2. So pwede sila, pwede sila mag-network yung mga level 2 in the province also.
Contractual obligation.
Sure.
Contractual obligation.
Sure.
Versus sa contractual obligation, ano po ang boundaries niya, anong scope?
Kung ano lang po yung service, hindi ko kontrata sa inyo. Kung ano yung service na kulang sa kanila. Halimbawa, MRI.
Kung lahat po, kasi level 1 lang yung outside ng Puerto eh. So, lahat ng level 2 capabilities, doon sa hospital na yun. Pwede kong gano'n.
Private.
Private, then government.
So technically, yan yung ginagawa natin ngayon as a policy for mix. We have for the public, because there's always level 1, level 2, level 3. Sa private, pwede. At saka sa mix. So yan po ngayon yung hinahanapan natin ng polisiya dito sa natin model. Kaya po yun yung ginagamit natin. Na definitely yung healthcare provider network model for a private and for the mix. Yun ang ating tinitingnan ngayon sa paano. Di ba nabanggit din kanina na ilalabas pa lang yung specific guideline. Kasi yung lumabas sa atin, although tatlo siya, but really, ang meron na is the purely public. So, maraming pwedeng lumabas na model pagdating sa next.
Sure. Basically, as Doc Paul was saying, ang Palawan kasi has no level 2 hospitals. So, as you were saying, that through the network, yeah, both po, just level 1 po, level outside Puerto Princesa. So basically, ang mangyayari po sa atin yan, if they will refer the Palawan network, after level 1, if they want to have a level 2 or level 3 referral, dito pa rin babagsak sa amin. Ganun po ba yun?
Sana meron dito.
Level 2 po lahat, private and government.
Kaya yung level 3.
Wala pa po. Wala pa po.
Meron kayo level 1.
Meron po.
Outside of Puerto.
So kung titingnan mo, Puerto Princesa, hindi rin kayo makakabuo. Una, wala akong level 1. Wala akong level. Ang Palawan, hindi rin. Dahil wala silang level 2. So, ang ginagawa na sa kanila.
Pero Doc, that's the problem. Kasi kapag hindi na sa bayan, pupunta pa sila sa munisipyo para mag-level 1. Para pumunta sa level 1 hospital. Kasi po wala silang city center yung level 1. Kung paano gagawin.
Make sure, because again, tama ito eh. Ang pasyente, mas kailangan kung refer ko na yun. Ito yung bagong pera niya. Eh kung dito sa atin lang sila, si Ben sa atin din nakikinig. So do you have the plan in there? On health, you plan to improve on some of your primary to be popular. Or level 1 to become level 2. Dapat sa kanila titignan natin. Pero again, kasama sa pinag-aaralan ngayon would be the models on how we can actually, because areas like, I don't know if we can consider Palawan as a Gina, probably it's an island, so may mga preference kung pwede mong karen. So those are probably special considerations. But in a regular setup, yung pinakita natin is still this one.
Sir, when you say level 1, these are the clinics,
Primary care.
primary care, okay.
Secondary activities, primary care, secondary care.
Second, what I meant was, we don't have level 1 hospitals here, but we have level 2 hospitals. In province of Palawan, they have level 1 hospitals, and the RHUs or the clinic.
That precisely is my point. Kung susundin ang design, hindi makakabuo ang Puerto Princesa. Una. Kung hindi makakabuo ang Palawan, kulang. Outside Puerto Princesa, kulang din sila. So kung titingnan mo, di ba, parang the most visible that we live in the things.
Yun yung tinatanong ko. Para makabuo ng level 1. Pero ang problem kasi yung outside Puerto is level 1. Ang Puerto is level 2.
Again,
Hospitals.
so, hindi naman kayo ang sinasabi province-wide and city. Ang city-wide, HUC and ICC. Pero kung ayaw ng city-wide, pwedeng isang buong probinsya naman siya. Pero kung gusto ng city, as HUC or ICC, at kaya nila, kung hindi kaya, ay as one network, pwede po yun. So, ibig sabihin ng yun, pag gano'n, ibig sabihin walang mawawala involved. Lahat ka rin natin kasama pa rin in one network. Aayusin na lang kung paano mag-refer, saan mag-register, paano pag-usapan, walang iwaliwan. So, pwede ka pag-usapan. Pero syempre, kung may gusto na siniwala, pero promise pa rin, kasama na again, kailangan natin mag-check because we have to again follow the integrated and the comprehensive care approach na dapat rin.
Sir, ano po yung possibility or chance na magkaroon ng special consideration sa set-up ng Puerto Princesa and the province? Kasi HUC kami, and then all the health facilities ng secondary ay nasa Puerto. And 70% ng nag-access ng services sa facilities na yan ay taga-Puerto. Yung mga referral po nila.
Kailangan tignan yan not just for Puerto. Tapos maaaring hindi lang kayo may ganyan. Gimaras.
Yeah.
Marinduque. Mindoro. So maaaring hindi lang kayo may ganyan. Okay lang. That's why nga po, tinitingnan natin what would be the best model. Para mangyari or para mag-shot. And yun yung tinitest. So, yun. Kaya, well, wala ko sa naging indication masyado yung urban areas. Hindi medyo competitive. Pero doon sa mga hindi, yun ang mga kailangan. On ano yung mga pwedeng mangyari or paano yung mga isa. Kaya tayo mas mabilis. When they did the manual of meron silang issues and the hospitals nila ay developed. Even the provincial hospital nila is now second level. So, contractual sila for a second level. Pero meron silang sariling network. Tapos, to complete the network, transfer with referral hospital nila is in Ilo and yeah, in Ilo or secondary.
So, Puerto walang primary, contractual sa primary tapos.
Actually po, primary po ay yung PCF, which is yung, meron po yung clinic na po ng private physician. And yung mga clinic po ng City Health Office. Pero yung yun po yung primary care po, level kasi yung secondary care po yung level 1 hospital.
Hindi naman ako maniniwala na walang primary ang ibang outside private business.
Yes po.
There are issues. You just have to elevate.
So, Doc, i-clarify ko lang po, pwede through contractual arrangement, pwede po mag-overlap yung Palawan. Assuming na hiwalay po yung Puerto, Princesa and Palawan, pwede po sila mag-overlap with the hospital through contractual arrangement.
Alam mo, ako kung tatanungin na, wala pang policy for the mix and the timing. Kung ako ang tatanungin, pwede. Kasi, bakit naman natin ipagbibiin na hindi pwede? Eh wala na.
Hindi mapilit.
Hindi lalo na walang pupuntahan ng mga pasyente. Until such time na meron mag-invest. Diba? Kaya, pag may mga ganang arrangements. But, again, there should be contractual arrangements kung baka.
So, clear
Clear
delineation sa lahat ng kung ano yung bayaran, ano po yung function, ano yung
Clarify lang po na yung
kasi remember, ang pasyente ay nakaregister sa primary. Not to your level 1 or to your level. So it is always, so klarado naman yun kung nasaan kayong primary care, province man or citywide, klaro kung saan.
Yun po, so, aakla po ako doon sa statement nyo, sir. Yun pong binanggit na primary care provider, hindi siya nangangahulugang level 1 hospital.
Primary care provider po are primary care.
Yes po, the facilities like, yung sa amin po kasi what we are going to trying to have ay yung existing satellite clinics namin na primary care provider na nire-register po namin sa PCM. As PCM.
Ano po yan?
Hindi po, attention time.
Yeah. Basta po ma-license siya sa primary.
Yes po.
Mapapasa sa DOH licensing.
Yes po. Kaya po, i-clarify lang po namin na yung level 1 na hinahanap po natin ay not necessarily yun po katulad dito kahit sabi nga ni Doc Odi. Doc, pakita mo naman yun. Sige na.
For point of clarification po, ang pinag-uusapan namin ang primary are not level 1 hospital but healthcare facilities.
primary care facility.
Yes. Ang level 2 or secondary na sinasabi in those hospitals.
Yes po, level 1 and level 2.
Level 1 and level 2. And then, yes, secondary care. And the tertiary care, yan yung level 3 or the apex hospital.
Iba pa po yun.
Iba pa.
Tertiary, which is your level 3, and the apex or end.
Yes, po.
Because remember, hindi lahat ng level 3 are apex or end. According to the law, apex or end referral shall be designated. So hindi lahat ng level 3 are apex or end. In a network, it should be primary, secondary, and tertiary. So primary, your primary care facilities, secondary is your L1 and L2, tertiary is your L3. Sa labas ng network and referral for each.
Just to clarify din po the HCPN network, ang requirement po talaga niya is 1 level 1 and 1 level 2 for secondary care. So sa secondary care, sa primary care, secondary care po, meron po talagang level 1 and meron pong level 2. And then tertiary, apex.
Para po mas pag-guided kayo. 8
Sa 2020,
2019,
sa 001.
00,
2020, 001.
2020, 001,
19.
019. Yun po yung design ng healthcare provider. Nandun din yun sa compendium. Para guided po kayo. Now, isang kailangan maging klaro. Because you're doing the referral. Hindi ko kasi alam kung may lumabas na referral guide for the national protocol treatment guidelines. Kasi yun yung kailangan isunod. Kung kita nyo yung licensing ng primary care facilities sa mga services na doon for primary care. So at least klarado na outside of those, ibig sabihin, need to be referred. So when is the best time to refer? So yung mga ganun part, so yun po yung kailangan natin na or from level 1, ano ang services covered by LMH? Or ano ang services dapat meron sa level 2? And ano ang services dapat meron sa level 2? Because remember, those have to be checked also. Kasi baka mamaya, the level 1 hospital is continuously treating patients for cases hindi naman talpas na. Kaya lalong nagmamahal. Eh dapat na-refer na niya dun sa higher level in that particular network also. Because that will also provide cost efficiency dun sa network. Because mas pagpagaling yung may kakayanan kaysa doon sa wala. So nag-a-access ng resources dito. Remember, everyone will suffer. Kung merong isa na facility in your network na hindi mas-perform ng maayos. Because they will use and utilize more resources. Ibig sabihin, mas marami silang gagastusin. Instead of all of you taking it more efficient. Pagdating sa operations. Kasi di ba, pag nagbayad na tayo at may pera skills, making things more efficient, mas maraming pwedeng ibigay as incentives, maraming pwedeng gamitin for extra costs. Otherwise, all of those will be used for operations. So, meron din po check and balance between the primary, the level 1, the level 2, and the level 2. Especially so, kung halimbawa, yung mga primary things. Akala naman nila, pag hindi sila nagre-refer na dadagdagan ng kita, eh di ba capitated amount naman yan? 500 per person. So treat siya ng treat kahit hindi na para sa kanya, para sa specialista niya. So talagang mauubos yung 500. Well, in fact, dapat natin na siya sa second level of treatment na may ibang package. Or dapat na confine na siya. Pero hindi na confine dahil, it's, or, check din naman natin, it's a primary care. pero refer siya ng refer. A specialist or for confinement. Makikita rin naman natin yan sa case discussions. And basically, kapagin yun ng board. Because mas marami yung magagastos nun. So makikita pa rin financially kung paano gumagastos yung facility. So it's also a check and balance amongst each and every. Because you will be working as a network. So lahat kayo mag-work to make things more efficient, operationally and cost efficient. Ang advice ko lang, hindi nyo naman siya matatapos. Because marami pang policies na ginagawa. Basically, ang magagawa natin as a manual are all the generals. Yung medyo specifics, we will have to wait for some of the policies. Pero at least may framework na tayo kung paano. But the basic thing is dapat klaro kung paano natin i-organize yung network of facilities and paano tayo mag-integrate at the local level. Kasi yun ang pagmumula ng referral natin. Like, how do you talk about referral? Wala namang pala kayong facility. So, paano mo siya i-refer? Wala naman pala. So, kailangan muna natin mapag-usapan. Ano ba ang framework ng integration natin? Ano ang framework ng network natin? Para maipasok natin yung referral protocols. But at least you're starting already. Meron na tayo schedule. Pupunuan na lang natin siya as we move forward. So it's really a good start. I understand, meron daw din ang PHO, magkakaroon ng province-wide October 21. So, mas magandang usapan yun. Because buo siya. Together with the LCs. So, magandang usapin yun. Because we can see the whole picture. So, saan natin
Doc, maiba po. Meron pong question kasi it was regarding question din. How about the OPDs po ng ating mga hospitals? Pwede ba silang magtanggap ng undifferentiated cases, yung for primary care, or ano po yung magiging estado na po ng mga OPD ng ano po natin hospital?
Ang hospitals should not be providing primary care services. Talaga hindi po sila sa baba. So secondary care, that is also again, making sure that the hospitals are actually utilizing its potential to treat more complicated cases. Because yung mga hindi komplikado, kaya yan sa China. So nalilito sila sa primary care. Ang kailangan lang, na mapagpunta sa hospital, kailangan mga. So even, kung titingnan natin, normal delivery, they are part of the primary care. That's why the midwives. Pero ngayon, they are actually utilizing most of the resources in the hospital. Ito yung normal delivery siya. Na pwede nang gawin sa line. And pwede gawin mo midwives. And of course, OB first. So nasa batas po yun that primary care shall be done by primary care recipients. So ang hospitals, meron mag-OPD, emergency, serious, and specialist.
So basically, yun po, no, OPD for special, para ang mangyayari, talaga po for specialist na talaga na outpatient. Yes po, opo.
So mga specialist na dugo, sure yun, di ba?
Opo. Apo. So, bali, hindi sila makakapunta doon sa medical arts building kung wala pong referral coming from the primary care doctor or kung emergency or ano po. Ay, out of pocket. O pwede kang dumiretso sa specialista as long as out of pocket. Ganun po. Out of pocket din.
So it's not just a reform in the health system, pero mas malaking reform with the health seeking behavior and the health rating behavior.
So, sir, my question lang dito. We have concerns like for residency training, like sa ibang they have OPD rotations. What will happen to those residents? Would they be rotating sa primary care or mawawala ang sa
Good. Yan po yung isa sa mga inaayos natin as part of the curriculum together with the training for the primary care. So, yan po yung isa sa mga kailangan part na ayusin. I had several discussions with the PMA because ang sabi ko sa PMA, with the way we are changing the healthcare system, the landscape of the healthcare system in the Philippines, baka kailangan i-check na rin natin one ang curriculum and how we actually train our doctors. Dapat naka-align na rin siya on how the UHT goes. So, agree naman si Dr. kanina. Pero yes, tama po kayo. Dapat ayan ay isa sa mga ipapasok ngayon. Kasama po yan sa mga HRH plan natin, master plan, kasama sa training and activities, kung paano po siya dapat.
even with the colleges po?
Yes, even with the schools of medicine. Kaya kung makikita po ninyo, di ba ngayon, even our schools of medicine are already shifting to primary care. It's a preventive health nila. That's already started. Yes.
For example, sabi nga na yung primary care facility does not necessarily a doctor to be present.
A primary care facility po will have a primary care provider professional.
Yes, sir.
A provider care professional can either be a doctor, a midwife, a nurse, and one like that.
Yes, sir.
Pero a primary care facility, once it is licensed, will have the following services. And all of those are present as part of the service. So ibig sabihin, in a primary care facility, may doctor.
If you look at it po, sa DOH, sa licensing standards for care facility, it's required to have at least one full-time doctor for a primary care facility. One full-time doctor, one full-time nurse, full-time na midwife po. They cannot provide it. They can have contractual arrangement for them to provide the services po.
Or she arrived to that diagnosis, hindi nakita ng doktor.
I cannot answer that.
Pwede po, one is pwede pong, kung in the part of City Health po, pwedeng phone consultation. Yes po, parang ganun. One is, yun po talaga, one naman po is yung the utilization of telemedicine na rin po nowadays. Pero, yun po, Doc, pwede nga po natin yan maging kasi ngayon po, yun nga, required na may full-time doctors po sa aming primary care facilities and we're shifting to that. Na dapat po, lahat po ng primary care facilities namin ay, once na they are licensed po, they should have at least full-time doctor during the 8 to 5, and then on-call po sila sa gabi.
As required, primary care professional has to be certified. according to this competence. So kung ano lang yung competency, so kung hindi kasama sa competency ang consultation, hindi niya dapat gagawin. Unless it is part of your protocol that they can do that in the absence, but either as instructed, verbal by the doctor, and everybody commands.
Yun po, pwede po natin nga, katulad kanina, yan din po yung issue ni Dr. Canela. Pwede po natin siyang isama sa manual na if really, kung kailangan, kung doctor to doctor po, pwede po yun. As per us naman po sa City Health, ganito po, yung barangay health stations, those are manned by midwives, and supposed to be the primary care facilities in the City Health Office should be manned 8 to 5 by physician, and then nurses po kung wala yung physician. So, ganun po yung ano natin. So, kung hindi niyo po kung napag-agrihan po ng lahat na dapat doktor pa rin, then it should be the doctor pa rin po. As long as it should be agreeable to the network po. Yes po.
Just like in the hospital. If there is an order to doctor, passing niya dapat so kung may mga ganun kayong protocol as part of your manual, sulat na siya para we can check. Para later on, wala rin doubts on the side. Remember, pagkandi ang activity. Hindi lang pala pa siya. Kahit po nasa in most of my discussions, the fear is paano ba yan, mawawala na ako ng passion. Pero kung titignan niyo po, every Filipino will have to be registered to you. Naaalagaan mo yan. So kung ngayon, actually, kung titignan mo nga, 7% of the population is hypertensive. Baka because of the registration and all, bigla siyang dumami. Kasi parang nagiging active case finding siya. Kasi tinitingnan mo siya, inaalagaan, pinaprofile. So basically, sa pagdami ng nakikita mo, sa pagdami ng pwedeng i-refer na pasyente to special. And how many are we? 110, 120 million. How many doctors do we have? 60,000. So hindi ko fear yung mawawalan ka ng pasyente. Basically, nadadagdagan. Because it has to be active now. And you have to see all the patients. No, actually, you have to see all, everyone. So yung mga hindi na di-discover na diabetic, di-discover na. Yung tinitingnan natin na early detection, for example, of cancers, pwede na mangyari. Because, dati nga, wala naman nag-check up sa kanila. Pero ngayon, dahil meron na, naka-assign ka na sa isang primary care, titingnan ka na ba? So sa ganang paningin pa na lang, para sa mga doktor, this is actually, and this will actually be a big challenge for everyone. On how to actually cater the 110 million people and growing. We are a very productive population. Ibu ba? So, tingnan din natin siya sa gano'n.
Salamat po ulit sa pagkakiyatigit sa amin.
Anyways, sige po. I'll stay na lang.
Thank you, Doc. Thank you po. So, Ma'am Ann, may na po pa kaya?
Maraming salamat po, Doc. And we are very thankful for having you with us. At least first-hand information and responses po yung narinig ng ating mga partners, local partners sa Puerto Princesa. And one thing na na-settle po natin with the response po ni Dr. ay yung ating agreement na una kailangan natin ma-institutionalize, ano kailangan natin establish for us to have this manual at ma-integrate natin doon kasi yun po yung pangahawakan ng bawat isa sa atin. Kung ano po yung kailangan natin pag-agrihan, gaya po ng binanggit kanina, isa po, just a recap, na kailangan po natin na magkaroon ng standard referral system kasi there are areas or there are hospitals na wala talaga silang existing referral system, yung acceptance. Off lang po off lang. And then yung pong technical working group for the inputting, which is now, actually, na ginagawa po natin. And then yung process of inclusion ng providers na reflected yung pinagin po, sinagot na po ngayon ni Dr. Kailangan din po natin yung may specify na kung agreement na in respect sa referral itself na M2 to MD, although kinarify po na the primary care providers are categorized according to their professions and they are being accredited for that. Kaya po yung mga sa City Health ngayon, nag-a-apply na po sila as primary care provider from midwives to the doctors. And then yung management po ng special health fund. And then yung membership ng mga hospitals sa local health board. Kasi meron po mandatory members sa local health board, but then nakalagay din po doon isang provision that can be expanded depending on the local context. Ngayon, ang po sa nakita natin ay yung mga areas na kailangan po natin i-integrate within the existing or the current manual na ginagawa po na meron na tayo pero hindi siya talaga actually na-implement and hindi siya na-monitor how it was being implemented. Kasi this was crafted 2018. Diba, Doc? 2018, lumipas sa 2019 yan, 2022 na po. Kumbaga sa isang ordinance, kailangan na rin talaga siyang i-update and i-revise. And with us now, we have the UHC law na kailangan talaga siyang i-update and align doon sa requirements ng Universal Healthcare Law. And then lumabas nga po na pati yung payment mechanisms, and it was very clear, yung statement ni Dr. na hindi lang dapat tayo nakafocus doon sa rates ng ating PF, yung sa pagbabago, when it comes sa patient management, but the totality of the management given to the patient. Yun ang titingnan ng para po sa sharing and sa payment mechanism. Pero beyond that, yun po establish natin na referral system within the Puerto Princesa. Kailangan po natin maging malinaw kasi lahat po tayo na nandito sa Puerto will have the burden ng accommodating especially sa mga level 2 hospitals. Tapos, mabigat po yung magiging implications nito, lalo na sa mga private facilities at private practitioners, considering na yung aakyat na mga pasyente with limited capacity na mag-avail ng mga services since magiging out of bucket nga sa kanila yung epekto. Hindi wala ng charges sa PhilHealth kapag nag-direct po sila ng access ng services sa ating mga private facilities and sa ating mga private specialists kung hindi sila dadaan doon sa network. And since this is, yun po yung ating ng takbo ng universal healthcare, it's good for us to start it in the right way. And we have the right guidance kasi hindi naman po tayo pinababaan as integration site ng universal healthcare. Mas gusto po namin, sabi nga po namin na Doc Rob, mas gusto na po namin pag-practicean. Yung kami ang maging pilot para pag-aralan, makita namin kung hanggang saan at ano yung kaya at limitasyon. And at the same time, this will also be utilized. Yung nangyayari sa atin can be used as a reference na may mga LGUs pa lang may mga ganitong sistema na para bang Kasi binanggit niya po, there are standard for overall na para bang blanket approach. Pero meron palang mga may kanyang dynamics sa bawat areas like sa atin, sa Puerto Princesa, yung level 1, level 2 issues, and then sa outside Puerto Princesa, paano siya ikakapacity since at the end of the day, ang takbo ng lahat ng referral ay nasa Puerto Princesa. Kaya yung cases natin, yun po going outside doc dun sa referral mechanism, the burden of the reporting is at the place of incident or occurrence, hindi doon sa place of origin. Kaya kung yung ni-refer po, binanggit nga po namin kanina, yung ni-refer ay medyo complicated na, tapos namatay dito sa Puerto, it's kumbaga last touch, yung report nasa Puerto Princesa. Kaya yung pag-address natin, yung ginagawa po nating referral, gagawin natin ngayon na updating and revision ng referral manual goes beyond dun sa, ang impact niya goes beyond dun sa system itself. Pero, but also, yung outcome niya magre-reflect din sa how the LGU or the local government or the Puerto Princesa City health system works. Kasi hindi siya pwedeng fragmented. Kaya po ngayon, yung papasok po ni Dr. Ralph para sa, pero natutuwa po ako kasi meron pang ginagawa ngayon, I know na yung pong pinag-uusapan natin, magagamit po nila sa national level as a reference. May ganun palang issue sa local government, which is, hindi pwede nila maging reference na there are areas na pwede natin i-consider. At natutuwa po kami doon na marinig yun kasi this is one way of giving back to the national government or feedbacking to the national government. Ito pa yung reality, yung current reality ng mga LGUs pagdating sa UHC. There are maganda yung guidelines, maganda yung papel na inilabas, pero there are areas na hindi po siya realistically may implement sa ibang LGUs. Kaya yun naman po yung take away namin na pwede namin masabi na siguro naman narinig nila kung anong meron tayo at magagamit nila as a reference na hindi siya pwede palang itagalin sa bato. Kung bibigyan ng leeway ang mga LGUs na gumawa ng sariling mechanism on that specific level, mas magiging maganda po yung partnership. Kasi we know kung ano po yung real context ng bawat LGU. Para sa amin, friends kami, tapos kung gagawa namin siya ng papel, mawawala yung friendship level namin. Parang ganun po siya kasi naging masyadong technical yung hinahanap sa bawat isa sa amin. Pero kung wala yung technicalities, we can call everyone as a friend at easy. Kaya parang ni-organize ko yung IITF, walang kahirap-hirap, hindi nga na-disband with IITF kasi parang we're still working on it. Parang gano'n na po siya. Pero kapag nilagyan mo siya ng bawat papel at hinimay-himay mo, ito lang sa'yo, ito lang sa'yo, ito lang sa'yo, parang mas magiging komplikado yung dating. Just to simplify it, ito po yung ginagawa natin ngayon. To have for us a working document. This is a working document. Live document nga po siya. Kasi considering na binanggit po niya, we only have the skeleton. Ilalaman pa lang po natin yung iba yung local adoption natin. Pangalawa, yung po mga galing pa sa specific guidelines na magagaling po sa kanila. Kaya po, hindi po natatapos, sabi nga ni Dr. Ralph, it will not end here. Meron po tayong nare-recommend na sana magkaroon po tayo ng recommendatory na technical working group that will work closely sa City Health Office. As convener lang po kami, ang totoo. Hindi namin siya i-lead kasi we're just a convener. Facilitator lang po kami, but at the end of the day, it's all us working together. Kasi po kahit sa local health board, pag-akit ng issue na to, pag-akit sa endorsement, ang magiging action din ng local health board, pinag-usapan nyo ba to at pinag-agrihan on the ground. Kasi hindi naman po siya, especially kapag napaka-unfair, kung strictly implement, tapos hindi naman, wala namang agreement talagang nangyari, parang naging mandatory, mahirap po kasi yung compliance level. Kaya po ngayon po, from at this end, hihingi ko po yung commitment ng bawat hospitals for the inputting yung content and review. Kasi ito pong pinag-usapan natin ngayon, integrate na po namin sa ginagawa, sa hawak niyo po ngayon. Yung hawak niyo po ngayon is the first version, yung second version with this input, and then ipapadala po namin sa inyo. And then yun po magiging member ng review. And I hope yun po nandito ngayon. Kasi yung lahat po dito ngayon ay nakarinig ng mga pinag-usapan ng dineliberate. The document will be sent na lang po siya sa emails. And then, kung prefer nyo naman po ang printed copy para may kuris-kuris po kayo, mas maganda rin po yun. At ibabalik nyo sa amin yung mga kuris-kuris. Okay lang naman po yun. Or you can even do the editing or inputting doon sa document sa Google. Ako po kasi mas prefer ko yung pag-kuris-kuris sa papel yun pong magre-review at magpi-feedback para sa version 3. Kasi yung version 2 po with this input. Yung version 3 with your input. And then, kung meron na po tayo mabubuo, gaya po ng gagawin ay it's a live document. Pag-aaralan po natin how it will work. Kung hindi po, kung wala po siyang it ends here. Parang yung sa amin kasi it ends here. Tapos hindi na rin namin na-implement. Kasi it ends there. Diba, Doc Odi? Yung referral manual namin, ay natapos din. Kaya natapos talaga, hindi namin na-implement. Hindi namin na-monitor how it was implemented. Yung ganun pong scenario, yun yung iiwasan natin kasi working towards talaga tayo sa integration. Yun po yung kailangan natin ma-realize. Parang we don't have any other choice but to accept each other's commitment pagdating sa universal healthcare. Kaya po, siguro hindi na ako hihingi ng technical working group. I-share na lang po namin so whoever is present now. Para at least yung continuity ng pinag-uusapan, alam po, hindi na siya pa, yung iba ay nag-represent ngayon, sa susunod, iba yung hawak ng document. Para mas makikita po natin yung the whole scenario. Yun po. And ito po meron po bang queries, questions, or other inputs bago po natin ito i-wrap up? And bago ko po i-endorse kay Doc Ralph, Doc Odi.
Ma'am, suggestion lang dun sa regarding dun sa referral system na siguro maganda may isang program from the IT na mag-develop ng that would be shared to different hospitals. Na parang standardized sa lahat.
Okay.
Just like what IATF is doing, di ba, meron tayong sa referral.
Ako, Doc. Yung para sa sharing of information.
And plus sharing of information.
Yun po, Doc. Ano po ba yung gusto niyo, Doc? Yung sa orientation itself? Or?
No, for the whole process ba?
Sige po.
For yung sa referral system.
Okay. Sige po, parang para siyang isang document na pag-uusapan. Sige po. Pwede po natin i-gawin, Doc. I-guide nyo na po kung ano specific na kailangan para doon siya. And then how it will be shared to the members po. Okay, meron pa po ba ibang input mula sa ating mga private hospitals? Doc Peter from Pilodho. Okay na, Doc? Sa ating pong mga participants sa Zoom, meron po bang from the CHD? Wala na po. Okay, kung wala na po, Doc Ralph, I'm calling Doc Ralph for the next steps po para sa case categorization, or Doc will just wait for the new guidelines na ginagawa po nila ngayon. Opo, para hindi na magulo yung, parang yung itong response na to, maseta once and for all, na hindi ka lang yung response. Para po doon sa next na case categorization orientation. Or we just wait for, yung sinabi po kanina ni Dr. na.
Yung treatment protocol ko. Yun ang hindi ko
We'll just wait po.
kung yung sa national treatment protocol. But I think pwede naman pong intayin yung National Treatment Protocol Guidelines na yun po yung sinasabi ni. Yun po ba yung gusto po ng consensus po na yung intayin yung National Treatment Protocol Guidelines para po sa
Hindi po, gagawin na natin ngayon yung basic.
Papa.
Pero yung ibang ilalaman doon na ibang muscles, saka na lang po natin ipapasok habang ginagawa natin yung internal guidelines. Kasi sa kanila, it's over and above us.
Papa. Sige po. Pwede naman po, ma'am. Kung ano po ang ano. Pero basically po, yung sa atin po kasi, yung if you can see po, yung workshop 3 and workshop 4 are actually procedural and yung case categorization. So, ang naisip po talaga kasi namin, yun nga po, we would like to ask every hospital if they are capable of treating those diseases. If not, we will refer it to the Apex Hospital. Ganun po yung parang, yun po yung parang ano natin. So, yan po yung nakita niyo po sa referral manual, those are the cases po that are identified na before pa with the Taytay and Nito PPC referral manual. And then we just, so we want na sana po, yun po, to comment if they can. And then, wala na, due to the limited time, pwede pong hinga na lang po namin kayo ng when po kaya namin makukuha sa inyo yung, yun pong, yung output po for that. Kasi para po ma-collate and consolidate natin for the manual.
Parang, Doc, kung ibabalik ko lang dito, i-relate ko siya, Doc, para siyang inventory of services, yung capability of services.
Separate, ma'am, actually separate pa yun. Actually, during the pre-workshop, we asked na po the hospitals to provide the capabilities po. Pero kasi, services po kasi na yun lang po yung parang procedure. Pero, it's not necessary na meron po silang procedures na ganito. They can do, they can treat na the disease, if ever. Pero, yung actually, ano na yung nakapagbigay, ano na po yung nakapagbigay sa atin? Co-op, no? Yung ano nila, services. Okay, so yun po, may services na rin, ma'am. Pero basically, yung services po, ang pagbabasehan natin doon is parang cross-cutting. Magkano po yung, kunwari, magtatanong po yung patient, magre-refer. Ito yung kailangan gawin sa'yo. And cross-cutting, almost, kung titignan namin mga hospital, ganito po yung presyo. Saan mo gusto? Ganon. Saan ganon po? No balance. Opo. No balance. Opo, pero ayun po, kasi ang ano nga po ay, ayaw na po natin na pupunta sila sa hospital, doon pa lang nila malalaman na hindi nila kaya yung presyo ng hospital. Kasi po, pero yun po, ano po nun ay, syempre, ang gatekeeper po nun, dapat yung primary care provider lang yung nakakalam. And yun po, may na-disclosure na dapat yung primary care provider lang po yung nakakalam ng prices, mga ganun. Or, I don't know kung open na yung HFPA po ng fair price na with the HFPA. Pero, yun ma'am, ano po ang sa palagay ko nila? Kasi pwede po na i-take home nila as long as po mabigay nila tomorrow. Tomorrow po sana. Just, yun lang naman yes or no lang po yan Opo, kung pwede or hindi. So, if sa mga wala po dito and sa iba pong hospital, meron po yung nasa link naman po yan ng HCPN bit.ly/HCPN. I-ano na lang po namin later din. Sa mga para makita niyo po, even if wala po kayong hard copy. Yung sa workshop or ganun din po, nasa procedures na rin po yung, nasa manual na of procedures din po yung, procedural lang din po kasi yan eh. If you can see, Part 1 is standard referral communication process, pre-transfer preparation and stabilization.
Yung mga recommendations niya.
Opo.
Opo, ang kailangan na po actually, lumalabas kasi Doc na among the hospitals, it's only the ONP ang merong referral, written standard referral mechanism. The rest of the hospitals ay wala. Paano sila in-accept? Sabi nga nila, kung nandiyan na yung pasyente or i-refer sa amin na pasyente, hindi namin tinatanggihan. Pero with this, kailangan po natin establish that we have to have a standard referral. Kaya po yung binigay nating manual sa kanila, it will help them, it will guide them kung yun ba ay acceptable sa kanila o hindi.
Opo.
So,
So,
po yung binigay namin. Kung acceptable po kayo doon sa ginawa ng Taytay Alnido PPC na and ONP, doon sa ginagawa po namin ngayon na existing, or may kailangan pa po kayo idagdag, or kailangan nyo ng, sabi nyo hindi na to applicable kasi dapat ganito na. Or we can even use the telemedicine in some point, or yung mga ganun pong, pwede nyo pong i-input dyan sa hawak nyo pong manual. Kahit na ano lang po, side comment, kung gusto niyo po dun sa live document, which is i-upload po mamaya, pwede niyo pong gawin yun doon. Yung pagko-comment. Na ito, sa ONP side, hindi na po namin ito ginagawa. Tapos i-update na po sa ONP, 300 bed capacity na po kami, dati 150 lang. Yan ang mga ganun po. Pangarap ba yun daw? Yung 300 bed. 400, tama, 400 bed. Yun. Yung mga ganun po updating. Para at least alam po namin paano namin i-update yung current manual para sa version 3. Kasi ito po version 2, yung i-integrate. Pag-upload po nito with version 2 na integrated, yung version 3 po magagaling na sa inyo yung input. Doc Ralph?
opo, yun po, ma'am, basta, yun po, doctors, yung manual po, basically, it's working document na ginawa lang po namin siya at first para po meron tayong structure, pero gusto po talaga namin makuha sa inyo yung ideas on what you wanted inside the referral manual. So, nandun na po yan yung parts, like yung standardized referral communication process, pre-transfer preparations, hospital transfers, post-hospital transfers, and back referral. With all the knowledge that we have na nakuha po for today, I hope yun po makatulong po siya in commenting po kung what is good for your respective hospitals din po. So,
Meron pa po bang gusto mag-input before we consider this part as a version 2? Yung integration nito sa version 2. Meron pa po bang gusto? Na magdagdag or i-antayin na lang po namin yung magiging updated version ninyo sa live document. Kung magagawa po natin para po bukas, makikita din po natin na we can provide you the version 2 sa uploaded po. Either bukas ng umaga, magawa po ng PPC. Wala na po bang questions, queries, or for expansion ng ideas? Wala na po. Hearing none. Doc Ralph? We're proceeding to the synthesis.
ayun po, just to wrap it up our session for today, medyo hindi po tayo talaga sumunod sa ating program just to give way po for our questions and our Q&A. Katulad po nung pag-start po natin kanina umaga, ang gusto ko po talagang, ang goal po natin today is para po kayo mismo, you know kung ano po yung what is the healthcare provider network, what is the citywide health system, in order for us, para po mag-buy in or para po ma-engage namin kayo and you're not just doing this just to comply with the requirements. So, sana po yung lectures na binigyan po ni Sir Art and Dr. Ish and yung kasama po namin, would like to mention lang din po Architect Meridiano and Dr. De La Paz from the Health Facilities Development Bureau of the DOH Central Office. And Doc Bob Mercene from Health Facility Operations Development Unit of PhD Mimaropa, and also Ma'am Badge dating Ginoon, Sir Arthur Rosales from CHD Mimaropa FHAP, Field Health Operations. And Doc Peter from Pidoho, and our friends po from Palawan, Provincial Health Office, and kayo po from City Health Office, and our thank you po talaga. And yun po, hopefully, for ang nag-gather po natin today is really how we will be doing it. And siguro, siguro hindi naman po kalabisan na sabihin ko meron kayong nakuha regarding how the payment mechanism will be with the healthcare provider network and how it will be, how the universal healthcare changes the landscape of the healthcare provisions here in the city, actually nationwide. So, yung workshops po natin ay nag-fuse na, and then yung workshops 3 and 4, yun po assignment na lang po natin. That would be for the specialist po. Tomorrow, siguro pwede na po tayong half day kasi more or less, this will also be part of the manual. Pero the TB ayun po, outpatient referrals, and yung feedback mechanism, one of the things that also that surface is also feedback. So we will be providing din po a form. Hopefully you can makita niyo po siya and maka-comment kayo para po maano po natin kung ano po yung nararapat, kasi po pati po yung feedback should be uniform na po throughout the healthcare provider network. And for the data, kasi nga po, we will be checked by not only by PhilHealth but also by DOH. So the data regarding sa referrals, or how do we do it? Ano po yung laman ng logbooks natin? Kasi kailangan may logbook na tayo. How do we do it? And ano po yung nilalaman ng logbooks? Sino yung maghahawak ng logbook? Saan po mapupunta yung data ng maghahawak ng logbook? Tomorrow po, yun po yung pag-uusapan natin. And I think we can compress it into half day naman po tomorrow. So hopefully, I know this has been a tiring day for everyone. Mainit-init na balitaktakan. Pero see you all tomorrow po for the day 2 of our drafting of our referral manual.
Salamat po sa lahat at pinagpapasalamat po namin yung mga nasa Zoom. May mga doctors po tayo, members ng Palawan Medical Society at members ng mga hospital na nandun. Salamat po at nakikita ko po yung kanilang mga comments and recommendations doon. Well noted po doon sa mga pakisave na lang po yung mga chat nila para po masama po natin sa update ng pagkaroon.
Ayun po.
So, ayun po. So, may questions pa po tayo?
Or we can ask one. Pwede po ba mahingi yung feedback ni Dr. sa walang choice si Dr. Paul sa siya lang talaga mag-feedback. At saka sa ACE Hospital. And then we'll also hear a feedback from the PHO doc siguro for us to have a good insight for tomorrow. Dr. Paul.
Speaking from private institution, parang when we started this morning, the task really looks daunting, no? Kasi what we are focusing on are the problems. Pero if we can commit, kasi talagang we have to make it work dahil the direction of the government and the landscape nga is towards universal healthcare. I think we can find common ground and solutions. So there are a lot of problems talaga kasi within our own institutions, hindi nga tayo magkasundo Tapos, pag sasama-samahin mo yung different institutions, we try to come up with Pero, first of all, we have to bear in mind that we're doing this for our countrymen. And then we also, it's our back against the wall. Wala naman tayong choice, we have to do it. So I think we will push through and we will come through, no? We will have a solution. It might be different, sabi nga ni Dr. Vargas, it might be a little different than the rest of the country because we have attributes na iba dito sa atin, no? But I think we can make it work. There will be a lot of headaches. Maraming pansit pa tayo kakainin. Pero we can make it work. MNG is fully committed to the cause.
Thank you, Dr. Heartwarming na marinig ko yung ganun statement mo. Next ko ay ating sa ACE Hospital, Dr. Kenneth Lee. Wala ka rin itong choice, Doc. O NT, marami pang babatuhan ng OD.
So, actually, yung discussion nga this morning, marami akong natutunan about UHC and like sabi nga ni Sir, hindi talaga natin to maiiwasan, mangyayari talaga to and it really is good for the Filipinos. So, yes, dito nakikita natin marami talagang problema pero we can work on it now para pagdating ng implementation ay ready na tayo.
Thank you, Doc. Positive ang ating and from the PHO po, then ONP. Si Doc Emery po. Okay.
Okay, so good afternoon po in behalf po of Dr. Labrador. Sa nangyari po for this whole day, yung gaps and challenges po na nakita natin na the city has a problem on the level 1 hospitals and the province has a problem on level 2 hospitals naman po. So, ang inaano ko lang po, insight and ay nakausap ko na rin po yung other doctors with the PHO. We are willing naman po to we have one referral for the whole province of Palawan and for the Princesa. We can work together for it kasi para yung challenges nandun po eh. We are willing naman po to work with that para isahan po. Kasi parang ang magiging mangyari eh, like if mauuna si city, mauubusan po kami ng level 2. Diba? Tapos kung mauuna si province, mawawalan po kayo ng level 1. So, why? Tapos kung yun naman po kasi ang ano natin, ang problem is a special health fund. So, napag-uusapan naman po natin yan for the Provincial Health Board and City Health Board. So, our governor and the vice mayor of the city, magkapatid naman po. So, parang nakikita naman namin na walang magkakaroon ng conflict doon sa hatian kung ano man po ang mangyayari sa special health fund. So, the province of Palawan are willing po to work together for the referral po ng buong entire Palawan and Puerto na po.
Salamat po na working towards the integration ng province and the city. Kaya na po as of the moment, hindi po member ng local health board ang vice mayor. It's purely the mayor, yung primary member, the core member, and then the extended member na base doon po sa UHC guidelines. Yung po yung sinunod namin. But eventually, just like the previous statement, yung local health board, it can be expanded depending on the local needs of the context. Next po ay yung bidan sa lahat. Ang pinakamarami pong pasyente pinatanggal. Sa hospital na pala.
OG.
Hello po, wala po akong choice ng book. Nagpapasalamat po ako kasi nagkakaroon tayo ng ganitong interaction, crafting ng ganun kasi we've been part of the first na mga pangyayari ko dito. Doon kasama ko sa province na na-craft dati nung ano din natin yung HPCN. Pero with this, nakasali ang universal healthcare ngayon, tama, universal healthcare, mai-integrate natin, nakikita na natin kung ano yung mga problems na soon will be arising. So ngayon pa lang na wala tayong choice kundi i-embrace ito at gawan natin ng paraan for the sake ng ating mga patients at saka sa atin na rin, we have to do our part. So nice na may mga ganito kasi before na mag-arise yung mga problems na later on, magagawa natin at least ng paraan. Pero maganda kung may pilot sana na ang mangyayari na kung paano gagawin natin para more na matatakil natin yung ibang problems pa.
Maraming salamat po, Dr. Ophelia. Sa lahat po ng mga partners natin na pinagpapasalamat po namin, actually the process itself manifested not only the interest but also the commitment. Yung pananatili pa lang po maghapon nandito, I know you're sacrificed a lot of patience just to be present here. Alam ko na meron po mga ganong level ng sakripisyo. And for us, ako po personally na-appreciate yung presence ng mga doctors na serving public. Kasi kahit na sa private po kayo, working with us, nakikita po namin na yung heart to serve people ay nandoon, looking beyond what is the income, but for the purpose, sabi nga ni Dr. Paul kanina ay yung objective natin is for the benefit of the people of Puerto Princesa and the whole Palawan. It's not only because we don't have a choice, but it's our, not only also of our money, kasi gusto talaga natin gawin yun. Kasi majority naman po dito, hindi taga Puerto. But they opted to serve Puerto Princesa and live in Palawan. Kaya, with this day, the crowd, kaya na po ang magtapos. Gusto na po natin i-acknowledge. Doc, pwede po namin yung feedback. Kasi yung gonna tomorrow po, no? Tama po ba? Sa ating...
Very. My flight is at 2 p.m. Actually, this is a perfect example of one of the principles of UHC. The whole of government, whole of society, whole of system approach. We have the government here, we have the private, we have practitioners, we have policy makers, we have administrators, we have managers. Nandito po tayong lahat. Yung pong prinsipyo na yun, ang phrase na nasa dulo nun, whole of government, whole of system, whole of society approach, especially in the development of health policies. So kayo, presensya nyo ngayon is really making it sure na yung paggawa ng polisiya na ipapatupad at the local level, sama-sama yung ginagawa. So technically, you're living one of the principles of the UHC. So I'd like to commend everyone in making sure that every stakeholder, all your comments, your suggestions, have actually, all those who have stake in the UHC are actually participating. Such that at the end of the day, there could always be an ownership of the process and of the outcomes. So congratulations po and kudos to everyone. I hope we can come out with a document as a result of this exercise. So thank you very much.
Just would like to acknowledge also Dr. Every Dinilio. He's the Assistant Dean for the School of Medicine at PSU. So, dyan papasok na yung sinasabi kanina na from yung curriculum, we start na yung universal healthcare.
Congratulations nga po para nakita ko yung Rooster of Medicine. The team po ng mga academy members na nagaling din po sa ating mga project. It's the first time na mabuo. Tama po, Dr. Remy, no? Mabuo. Finally, magkakaroon na ng medical school ang Palawan. Kaya, looking forward to that. Salamat po, Doc. And the wife is the previous president po ng Palawan Medical Society. The proud. Totoo na to.
Ayun po, just to ano po kay Doktora, na yung hopefully masundan siya ganun, ay mapilot. That's po part of the process. Bukas ko pa sana sasabihin. Pero the document itself, we will try to apply it. Kasi hindi pa lahat kasi may EMR. Pero we have, yun po, set na rin sana after 2 months, just to feedback, to get your feedback if it's happening or what's the problems with the manual that we have crafted so that we can come up to a more better version. So, yun nga po, because the document itself will not end dito or after 2 days. It will continuously be revised and continuously be changed in order for us and in order to address all the issues that will arise if we apply the document. If we apply the manual na po. Ayun. So, yun po, with that, I'm thanking everyone. Pero before that, can we all saan ba? Yun na lang, kasi sa likod, kasi maluwang dyan eh. So, can we, dun na, saan gusto? Dito, dito kasi nandito daw yung title. Pwede po pumunta na lang po sa harap just for a brief photo op lang po. And then, yan, you can leave na po. Thank you. So, punta na po tayo sa harap. Ay, opo bukas po yung continuation po ng ating document po 8 AM. Ay, yung nasa Zoom din po natin, you can join kasi nandito kayo sa projector. So can you kindly open your ano na lang po para open lang po yung cameras ninyo. Mga doctors po with us in Zoom. Okay po. One, two. Sorry, nakatayo. Sorry po.
One, two, three, smile. One, two, three, smile. One, two, three, smile. Nasyat po, waki po. One, two, three, waki.
Ayun po, with that, thank you po. Kita-kita po ulit tayo bukas. ABM po dito pa rin po. Salamat po.